Hello everyone, I'm audible to you. So we wish each one of them good morning to all the participants.
Good morning.
Yes, we ask you all the participants to keep mute of the audio while speaker is giving his or her talk. So if you're having any problem with uploading of the PPT, you can send to the mentioned email ID or a WhatsApp number. So myself, Akira Jacob, representing the Inovine conferences, welcomes all distinguished guests, doctors, scientists, educators, colleagues, friends, ladies and gentlemen. So it's a great honor for me to welcome all to all join this webinar on behalf of organizers of 6th World Congress on Nursing, Education and Healthcare. So yesterday we have successfully completed the first day in person. Today we are going to start the virtual presentation. So I would like to express my most sincere gratitude for your presence in this opening ceremony as a gateway to initiation to our scientific program. So moving on to our sessions, the nursing management, surgical nursing, dental nursing, cardiovascular nursing, healthcare, and so on. So I repeat once again, so make sure to introduce everyone at the beginning. Ensure that you can have a clean and a work appropriate background. Look into the camera when talking instead of looking at yourself. Be aware of your audio and video settings. So I request now Dr. Wendy Wong to share this presentation.
Good morning, everyone.
Yes, good morning, doctor. Go ahead with your presentation.
Okay, so
yes,
I will share my PowerPoint. So this is my presentation. So thank you for having me.
Yes, go ahead with your presentation.
Okay. So my study titled a qualitative study, nurse attitude towards drug user in Hong Kong. So I'm coming from Hong Kong and I'm teaching in a university and teaching the nursing student. So Hong Kong is a small city of China, and its area is 1,1114 kilometers square. However, the population in Hong Kong is high. Is more than 77 million people living here, and only 4%, around 6,000 people, are the lone drug user, based on the statistic in 2021. So this is the background of my study. In Hong Kong, actually, possessing, using, and selling certain kinds of drugs are illegal, including the marijuana, cocaine, and ketamine, all are illegal. Therefore, drug users are the minority in the society, and they bear the possible stigma. In 2018, the statistics show the total number of reported substance users has declined. However, the young user has slightly increased. So the nurse is regarded as the frontline caregivers in the healthcare system and also to the drug user. But the many studies reflect the attitudes of nurses towards drug user being inconsistent, including studies from the US, UK, and Australia. Moreover, there is limited research about nurse attitude and the influence of possible variable towards drug user in Asia, especially Hong Kong. It is necessary to identify their attitude towards drug user, because the nurse attitude may influence their behavior, choosing the style of communication and their care delivered toward the drug user. After the literature review, we can see that the factors, including the working experience of nurses with drug user, the nurse specialty stream, and their rank are dispersed among our founding article. So we cannot get a consistent answer whether which factors influencing the attitudes of nurse towards the drug user. So the situation in Hong Kong is remain doubtful. So this is the aim of my study, to assess the nurse attitude towards drug user and related factors that influence their attitudes in Hong Kong. So there were three objectives. They are to assess the difference in the attitude towards drug user between general and psychiatric nursing, the nurses, to assess the difference in the attitude towards drug user between registered nurses and enrolled nurses, and to assess the difference in attitude towards the drug user upon the frequency of their working experience with the drug users among nurses. So it is a qualitative design and cross-sectional study. We adopt the convenient sampling. We post the poster of recruitment of samples to the social media in 2021. Owing to the pandemic, we cannot deliver or distribute the questionnaire to the nurse face-to-face. So we deliver the online questionnaire through the Google link. For the inclusion criteria, the registered nurse and the enrolled nurses in Hong Kong all are recruited, including the general adult nursing and the psychiatric nurse. For the exclusion criteria, nurses with other specialty license, for example, mental subnormal registered nurse and the sick children registered nurse will be excluded, were excluded. To collect the data, we have the questionnaire consists of two parts. The part A is the demographic information. The respondents should fill in the form about what nursing license they have and what type of nurse they are. That means they are the general adult nurse or the psychiatric nurse, and the experience in providing nursing care for the drug user. And the other part, the part B, is we employed the questionnaire called DDPPQ. This is the drug and drug problems perception questionnaires. And it is distributed through the Google links in English. So when look into the DDPPQ, it is asking the level of agreement on 22 statements about working with drug user. There are 7 answers that the respondents can choose from strongly agree to strongly disagree with the statement. At the end of DDPPQ, we can calculate the total score. The lowest score represents positive attitude, whereas highest score represents negative will. The compound alpha are satisfactory of this questionnaire. So we grant the applicable approval from the study university, and also we have informed consent information sheet through the Google link. So we collect the response. We put the Google links on the internet, and the respondents can respond to the Google link. And in the first page, we have the information sheet and the informed consent. When the respondents proceed to the next page, it means it is implied consent to participate in this survey. So and then this is the part 1 of the questionnaire, and they need to key in the information about what kind of nurse you are, what license you have, and how about your working experience, so far and so on. So for the confidentiality, we store the data very safely, and also all the data safe with the encrypt password. The questionnaire are anonymous as well. Finally, 420 questionnaires were collected between March and May in 2021. 37 of them were excluded because the respondents are not a nurse, and they are fall into the exclusion criteria. This is the characteristic of the respondents. So you can see most of them, more than half of them are the registered nurses, and among half of them are the general adult nurse, and around 30% of them have to work with the drug user at least 1 day per week. So when analyze the data, we make use of the independent sample t-test to compare the mean score between the general adult nurse and the psychiatric nurse. So you can see the statistics show that the general adult nurse has relatively negative attitude toward the drug user in Hong Kong than psychiatric nurse. When using the independent sample t-test to compare the mean score between the enrolled nurse and the registered nurse, the statistics shows the registered nurse had a relatively positive attitude towards drug user. So we also compare the 4 groups of respondents. We divided respondents into 4 groups according to their working experience with the working frequency with the drug user every day. So group 1 is working every day, group 2 is 1 day per week, group 3 is 1 day per month, at least 1 day per month, and the group 4 is at least 1 day per year. So we use ANOVA to compare the means, and you can see group 1 and group 2 have a relatively positive attitude towards drug user in Hong Kong than group 3 to 4. That means when they have higher frequency to work with the drug user, they had more positive attitude. And for discussion, so based on the results, we know the more advanced education, that means the registered nurse have a more positive attitude than the lower education nurse, that means the enrolled nurse. So the education content of nursing program could influence the attitude of the nurse in Hong Kong. And also, you can see the general adult nurse has a relatively less positive, that means relatively negative attitudes towards drug user. That it may be due to they are not often exposed to the specialized knowledge about drug use, drug-related disorder, especially they may have not much knowledge about the social and behavioral perspective of the drug user or the drug problem. So their attitude towards drug user were less positive. Rather, psychiatric nurses are paired with the knowledge of substance use disorder, including their signs and symptoms, the social behavior, and the psychiatric mental background or the etiology of the drug use or drug disorder, and how to deal with those people. So they have a more positive attitudes when working with the drug user. And also the enrolled nurse in Hong Kong has less positive attitudes towards drug user than the registered nurse. So the higher education level are more willing to work with the drug user. So also the previous study reported that the nurse with insufficient knowledge have attitudes that were more punitive and negative than the positive and supportive towards the drug user. When comparing the education years of these nurses among the registered nurse and enrolled nurse, you can see for registered nurse in Hong Kong, we have the 4 to 5 year training, but the enrolled nurse in Hong Kong, they only have 2 years full-time training. So you can see the comprehensiveness of the nursing knowledge influence their attitudes towards the drug user. With more comprehensive nursing knowledge, nurses may have the more positive and supportive attitudes towards the drug user. If the knowledge is insufficient, they may affect their attitudes and they avoid to work with the drug user. And the result of study indicate that nurses in Hong Kong would, with lesser frequency of time working with drug user, demonstrate a less positive attitude towards the drug user, comparing the nurse with a higher frequency working time with them. So it was inconsistent finding with the empirical research because in the previous research, it indicates that no significant difference between these two groups of nurses. That means no matter how frequent work with the drug user, actually the attitudes among two groups do not have significant difference. But in Hong Kong, we can see there's significant difference. It may attribute to the cultural difference. That means in Hong Kong or in Asia, the recreational drug use is not common, and it is also an illegal offense. In contrast, in Western countries, some of the recreational drugs is common and they are legal to use. So to conclude, level of education, specific knowledge from different perspectives of drug use and working experience may be the factor influencing the nurse attitudes towards drug user. So in the future research, we can focus on the predictor of the attitudes among nurses towards the drug user. And also, as a nurse educator, we could reflect the curriculum and emphasis on the mental and social perspective knowledge of drug abuse, drug use among the general adult nursing education. Besides, the experiential learning may also help to develop a positive attitude among nursing students. So when the nursing students have the face-to-face contact with the drug user or have their experiential learning at the drug, maybe the substance use unit or clinic, they may have a more positive attitudes when they get registered. So this is the end of my presentation. Thank you for listening. Do you have any question from the floor?
Yes, thank you so much for your presentation, Dr. Wendy Wong.
Thank you so much. Thank you.
Yes, if you have any questions or comments, you can ask.
I have a question. My name is Valerie Esposito-Cabanek. You mentioned the other two studies. Were those also found to be the nurses with more experience, were more willing to work with drug users? I don't know if I missed that part in your discussion.
Oh, I see. Let me explain. It shows that the previous study, the two study in the previous, it shows that there's no significant difference between there's no difference actually. But in Hong Kong, we have difference according to their working experience with the drug user.
Okay. All right.
Thank you.
I also put something in the chat. I'm actually doing a study similar to that right now. I'm using the DDPPQ as well. So I found it very interesting. Thank you very much.
Wonderful. Thank you.
Thank you.
Yes, thank you so much, Dr. Wendy Wong.
Thank you. Thank you so much. Thank you for having me.
Okay. You'll get the certificate within 2 to 3 working days through the email.
Oh, okay.
Okay, fine. So moving on to your next presentation by Dr. Valerie A. Esposito, York College from USA. Go ahead with your presentation, ma'am.
Okay, I just want to ask, can you see my slides?
Yes, yes.
I just want to start from the beginning. That's okay. Okay, so I have a little bit of a different thing. Mine is more of an educational, pedagogical type of presentation that has to do with depression, suicidal ideation scenario. I work for City University of New York, York College Nursing Department, and we use interprofessional education, which is across the professions, so dental, social work, psychology, nursing, medicine, all of the healthcare disciplines that have a school within our university. We come together and we do case studies with students so they can practice multidisciplinary team approach to healthcare. All right, it's a series that was created by the central office of CUNY, and it's a university-wide. It models the interdisciplinary process for students, so it's designed as a teaching modality. Dr. Simino Boyce, I'm just throwing this in. She is the head of all the healthcare services for the university. And in her paper, she quotes the use of technology created an opportunity to include broader representation across disciplines and campuses. I find that to be very critical because interprofessional education is really what this is about. Okay, so how it begins is the students are instructed before the series what the exercise is. They're given the case study ahead of time. They're provided support, made aware that if anything triggers any emotional response, that they can stop at any moment. And the faculty allow the students to represent the roles of the discipline, and they discuss the patient scenario and the plan of care together. So, sorry about that. The significance of the communication. So obviously, good communication between interprofessional teams is documented. Sensitivity and diversity training is essential when participating in interdisciplinary communication. We know that communication failures can cause adverse events for the patient. So it's very important in our training and education to teach our nurses and obviously the other healthcare providers as well. Fostering a positive work environment helps with communication between healthcare disciplines. This includes body language, emotional intelligence, and mindful conversations. So the significance of using this virtual simulation. So healthcare education is incorporated this interdisciplinary education into the curriculum. I will show some studies that IPEs have students that practice IPEs in their training have a better understanding of the other disciplines' role, which promotes collaboration and a positive outcome for the patient. Okay, so this particular simulation was I created to mimic an inpatient scenario of admission of a patient diagnosed with depression and a suicide attempt. The case study includes a patient history, each discipline's role that's involved with the patient, a video. Well, I don't have the video, but I have the script of the nurse-patient interview, and the different disciplines were nursing, medicine, social work, nutrition, psychology, recreational therapy, occupational therapy. And this is something that can be done, really around the globe because it's simulated. Okay, so quick, this is the scenario. This is the patient summary. On the left, we have the basic stuff from the patient, 32-year-old female, lost a lot of weight recently. She is a police officer for New York City. She has 3 children. She's in the middle of a divorce. She lives with her mother. Her mother has anxiety. She's not on any medications. She does not seek help treatment because she's afraid she will lose her job. 32-year-old mixed race. These are the things she says when she's brought in. She was found, sorry, let me back up. Found on the floor in her bathroom after taking her mother's Xanax. She hit her face on the tub, so she had some mouth and oral injuries. She was conscious. Her vital signs were pretty stable, but when she brought to the hospital, she was told the staff, "I want to die." She told them what she took. She says she can't get through the divorce. She states she continues to be suicidal, cannot contract for safety. She did not want to die violently. That's why she took the pills. Extremely tearful, unable to focus, needs constant redirection. So this is how the patient's presenting. Social history, as I mentioned, it's a lot of information, but this is the whole case scenario. She lives with her mom in a separate apartment, but the same house. Progress notes. Now, each discipline, after reading the case presentation, how the patient presents, writes their own note. Here you can see it's the psychology evaluation, and they do their piece. The nutrition assessment note, because the patient had hit their mouth and she also has not been eating for the last year, 9 months. She lost a lot of 45 pounds, which is a lot. It's part of her depressive symptoms. So this is all of the goals for the nutritionist. I wrote a script of the nurse-patient interview. We had another nurse play the role of a patient. But you can see in the red, in the parentheses, the nurse's responses are therapeutic communication. This explains to the students why the nurse would say something like this and how it would be therapeutic for the patient. Tell me more about taking the pills, open-ended, reiterating what the patient says. You feel like you can't get on the divorce, validating what the patient says. It's very important to assess the patient's safety. These are things that we teach to the students. And okay. Again, more of the script, validating, creating a trusting relationship with the nurse patient and empathizing with the patient, allowing the patient time just to be present, not to overstimulate, give them time to process what's being said. This is all during the initial nurse patient interview. Again, it ends with, reassurance and letting the patient know that the team will meet and discuss a plan with her, come up with a strategy to keep her safe and treat her depression. Okay, this is the nursing assessment report. We do situation, background, assessment, recommendation. The situation is, from the previous screen, how the patient was brought in. The background is the history of the patient, what's been going on with her that got her to this point. The assessment is what the nurse got out of the interview, what the nurse sees, and the recommendations. We're keeping the patient on a constant observation until we can trust her for safety. She can contract for safety, starting on Lexapro and Ativan PRN. However, the nurse recommends that the patient is a candidate for ECT. Electroconvulsive therapy is shown to be, quite effective, 85% more effective than medications at some points. And plus, this patient is a police officer, and there's a lot of stigma with being treated, and she may or may not be able to return to work if she's on the medication. So there's a lot going into figuring out, once this patient is discharged, how to keep her healthy. So this is the nursing assessment report that would be presented in the IPE. Social work does their own report. Again, they start out with a history, what they're going to do while the patient's in the hospital, and how they plan for discharge, including contacting the mother, the work with the patient's permission, the police department, and find out how she can return to work. Right now, she's obviously not working. Now, the dental note, I'm not sure if you could see the pictures on the side. This is how the dental resident would come and do an assessment. This is the note the dental resident would put in the chart, and these are the things that the dental resident would speak about in the team meeting, dealing with the pain of the mouth. Recreational therapy, inpatient meets with patient. They do a mental status. They find out what were the patient's interests before. What are we considering? Other comorbidities that might be interfering. This patient doesn't have any. What the treatment plan might be, and the goal inpatient, and the goal when she gets out of the hospital. Occupational therapy, same thing. You can see each discipline that's needed in this particular case study does a full assessment evaluation. They use SOAP notes, subjective, objective assessment, and goals for the patient while they're inpatient. Again, talk about how we're going to treat her outpatient. Now, after each discipline shares their role, now the IPE, the discipline that shares this information, is the student in that discipline, right? So after each one shares it, they meet virtually in a team to discuss their findings, and they collaborate on a treatment plan. They represent their role. Faculty is present, excuse me, to guide the conversation, but we don't usually get involved in the conversation until the debriefing at the end to find out what worked, what didn't work, how the students felt, these types of things. So the debriefing is after the team meets. Just a little background on debriefing. It's meant to analyze, for the student to analyze and interpret the events that brought them together. It's a retrospective assessment and conversation of the student's experience and performance. And it is part of simulation learning. It's a standard at the end of sim to debrief with the students. And there's a lot of self-reflection during debriefing. Look at any implicit biases that may have come up with this particular patient's case or interview, any feelings that the healthcare provider, nurse, social worker, anybody that was in that room may have that might interfere with the patient's plan, and being open and honest with each other and the patient. This is all geared towards, positive patient outcome, but it's part of the education process. Okay, so IPE has totally been established as a valuable tool. It did get a lot more use, at least in my area, when COVID happened, because our clinical experiences had to go virtual. So this was one way to provide learning experiences that were faculty-led for the students. Enhances the importance and complexity of patient-centered care, because all the disciplines need to be involved. It's goal-driven. It's very impactful form of pedagogy. We've had a lot of successful positive results. We have a lot of cases. Mine was depression and suicide ideation, but we have them just about any diagnosis that a nurse could think of, this can be done with. Here are some references from the slides, and that's it. I don't know if I went too fast or not fast enough, but thank you for listening. And if you have any questions, this is my email, and you can WhatsApp me. I'd be happy to share more information about this with anyone that's interested in using this form of pedagogy. Again, it's created by the City University of New York. I just created this particular patient scenario, but I'm very happy to share it with you.
Thank you. Thank you so much, Dr. Valerie. Thank you for speaking up in this event.
Thank you very much.
Yes, yes. If you have any questions, you can ask. Any questions or comments, you can text in the chat box.
Thank you.
Okay, okay. So moving on to our next presentation by Dr. Rana Abdul Malik, Executive Healthcare Consultant from Lebanon.
Good morning, everybody. Very happy to be with you. I will be talking today about the drivers of patient experience and sharing some experiences and evidence-based practices from the point of care. I'm going to share my screen. Very happy to be with you this morning, and I hope that the comment that we will be discussing today will be helpful to your audience. Are you able to see my screen? I need some feedback from the organizing team.
Yes, yes.
Okay, I will be putting my camera off if you allow me, because I'm afraid that some okay, now you are sharing. I'm sharing my screen. Are you able to see my screen?
Yes, yes.
Okay. So what we'll be talking today, concept definition, we're gonna patient experience. We're going to go over the growth and relevance of the patient experience concept in healthcare and why it does matter. We're going to explore the Institute of Health Improvement, or IHI, patient experience framework, which was the initial framework that was put in place. We're going to go over it very briefly. That was put a decade ago almost. Then we're going to cover the Beryl Institute Patient Experience Framework, which is a much more updated framework done very recently, and it's always a work in progress, started in 2018, and its research is feeding into the feeding into the framework as they go. We're going to compare and contrast both models, and I'm going to share at the end some examples from the practice for successful implementation of patient experience initiative. So this is what we are going to discuss today. So almost a decade ago, Peter Drucker, who is a very famous management guru, identified healthcare as the most difficult, chaotic, and complex industry to manage. So he said that the hospital is altogether the most complex human organization ever devised. And here I'm showing you a picture of an operating room that shows a current operating room that we know today, that shows the complexity of the environment where patients are received and where healthcare providers are practicing. So what do you think of Peter Drucker's statement? Would you agree with him? I guess everybody would agree. And a much more important question to add up on the thoughts of Peter Drucker is, where is the patient in all of this, in the middle of this complexity? So this is a big question that we are going to really try to answer today during our discussion. So what patients want among this complexity and increasing complexity in every aspect of healthcare, what do patients want? This is what the evidence says. And here I have listed on the left side of the screen many references for you if you would like to really go over it and read more about the topic. But in a nutshell, patients want better humane communication and careful listening. They want clearer care and clearer discharge strategies. They want enhanced environment of care in healthcare facilities. They want us to attend to their complaints, and they want to be involved as partner in their care. So basically, if we really synthesize everything that has been done in this area, we come up with these 4 points that I'm sharing here. Going from there into trying to really conceptualize a common definition for patient experience. Before that, I want to really go over the patient experience across the care continuum of health. So we know that health is not only seen when the patient is a patient or admitted in a hospital. Health is a continuum. We go by being a person to being a patient to being a user of healthcare. So across this whole continuum, when we are a person, we experience health. When we are a patient, we experience disease. And when we are a user, we experience actually the healthcare services. And when we want to think about patient experience, we need to think about it from all these dimensions across the continuum of care. It's not only limited to when we think about it as a user. If we go over the synthesis of 14 years of evidence in relation to trying to define what is patient experience, between 2000 and 2014, we come up with these conclusions. Patient experience reflects happenings and events that take place independently and collectively across the care continuum, as we said. When understanding patient experience, it is critical to move beyond the results of patient satisfaction surveys. So as a user, we need to really assess the experience of the patient across the continuum, not only as a user of services. Patient experience is strongly tied to positively meeting patient expectations beyond clinical outcome or health status. So it's not only restricted to health outcomes and clinical outcomes and health status, it's about meeting the expectation from many other sides. Integral to the patient experience concept is the provision of individualized and patient-centered care that is mostly customized to the patient's needs and engaging patient and family in the process of care. So this is the synthesis. This is what the literature really has been saying about patient experience between 2000 and 2014. Now, what we are talking in the literature about are we are lacking a standardized definition for patient experience. Currently, patient experience is recognized as an independent dimension of healthcare quality, along with clinical effectiveness and patient safety. We know that clinical effectiveness, patient safety, excellence in quality of care are all dimensions of quality. Now there is emergence of the patient experience concept to be an independent dimension also of quality as one of the pillars. Healthcare is undergoing a shift, and we are seeing this, to a consumer mindset, or what we call user-centric. There is engagement and partnership with the patient that is becoming more focal. We are really stressing on this. And we are seeing an integration and alignment of patient experience and person-centered standards in leading standards or accreditation or designation endeavors like Joint Commission, like Plain Tree, like Language of Care. So these are all places where the integration of person-centered and patient experience concepts are being translated into standards of care and practice, okay, where voluntary healthcare providers would apply to get those designations and really make sure that they validate their practices according to their standards. After saying all this, we come to one final, in a way, definition, and I'm sharing, there are many others, but I'm sharing the Beryl Institute definition that is the most recent, or I may say it's the most reflective of patient experience nowadays. And it says this, and I'm quoting, the sum of all interactions shaped by organizational culture that influence patient perceptions across the continuum of care, as we said. So it's not only as a user or as a patient, but even when we are healthy, how we are providing care for preventive measures and all of these parts of the healthcare of the person. So now moving into patient experience and patient satisfaction, are they the same? So we're going to compare both concepts. They are overlapping, definitely, but they are different. Patient experience and patient satisfaction are often used interchangeably, so we don't really make this discernment between both of them. They are different concepts, but they do overlap at some point. Patient experience surveys sometimes are mistaken for customer satisfaction surveys, are not the same. The only valid and reliable tool to measure patient experience currently is the customer assessment of healthcare provider and system, what we call CAHPS or CAPS. It is vital that healthcare professionals understand the distinction between the two concepts and apply them appropriately to their work to drive focused improvement intervention. So it's not that we want to measure one or the other. We want both to be measured to drive better improvement measures in healthcare. And here I'm showing an example to really do some comparison between how we assess patient experience and versus how we assess patient satisfaction. And I'm extracting questions on the right side of the screen. You see a question extracted from a regular patient satisfaction survey, and on the left side of the screen you see a question extracted from the HCA CAPS. So, and the patient experience focuses on how patient experience or perceive key aspect of their care, as we said, not how satisfied they were with their care, such as communication, understanding, instructions, and so on and so forth. And here is an example about the process of medication administration, where we asked them, before giving you a new medication, how often did hospital staff tell you what the medicine was for? So we're not asking about satisfaction with the medication process, but we asked them about a specific experience related to explanation of instructions before giving any new medication. When we compare them to patient satisfaction, which is asking the patient about expectations for his or her care encounter, two patients can give two different perceptions, because we are measuring their perception there. And here is a list of examples. How we really ask questions related to satisfaction. For example, overall, how satisfied were you when you received care from us? So this is in a nutshell to really compare or understand the difference between the two concepts. Now, why patient experience is important in healthcare, and we're gonna really go over some important concept to really cover the importance of this concept and its relevance, its high relevance, and its increasingly high relevance in healthcare. We have a growing body of evidence that shows that improving patient experience and developing partnerships with patients are linked to improved healthcare outcome. And here I have quoted the systematic reviews and other reviews that really summarizes if we, for example, take one aspect of patient experience, which is the patient and family engagement in care, and all of these boxes that you see in the circle are outcomes related to that are seen or evidenced outcome that were experienced after implementing patient and family engagement in care. So we can manage better complex conditions, chronic condition. We have seen improved quality of life. We have seen that patients are seeking proper assistance, what it should be. We have seen that they have less anxiety and stress. They experience shorter hospital length of stay and less cost, less hospitalization and emergency use, because they really understand what's going on and how to deal with their condition. And we have reduced elective rates of surgeries. So more on the evidence. In relation to patient experience, we know that 8% of patients say that they will switch provider if dissatisfied with communication. So this is a fact. Communication is a factor most strongly associated with potential and preventable admission. 19% higher of non-adherence among patients whose physician communicates poorly, and hospital with high patient experience score have higher profitability. So all of these research and all of these numbers, they do make the case that patient experience matters. We need to really give attention to structuring the way we care for patients from an experience perspective, not only from a satisfaction perspective. Now, how to structure this patient experience concept in our care provision? And here I'm offering two frameworks that are evidence-based. One that has been done in or released into the practice back in 2011, and it's still relevant, which is the IHI framework. And then I'm going to go over how we have seen the shift in patient experience and what are the new elements that we have added to the framework through the Beryl Institute model. Okay, so this is the initial framework created by the Institute of Health Improvement, and these are the primary drivers. It is divided into two types of drivers. The secondary drivers, they feed into the primary driver, and the primary driver will feed into the main goal of the framework. I'm going to show you the diagram for that, but it's very important to understand what is the aim for this model. The aim is exceptional patient and family experience of inpatient care as measured by the HCCAP. Okay, so this is their basic aim. So this is very much concerned to have an inpatient experience excellence. Okay, and the primary driver for these for this is leadership, staff hearts and minds, how to engage them, to engage the staff in the processes, respectful partnership with the patient, reliable care that is highly evidenced, and evidence-based care. So these are the primary drivers, and how we really understand these primary drivers, how we define them. When we talk about leadership, we talk about governance and executive leaders that demonstrate everything in the culture is focused on the patient, so they lead the way in that manner. Staff and heart minds, we speak about the hearts and minds of staff and provider are fully engaged towards patient experience. Respectful partnership, where every care aspect is anchored in a respectful partnership and anticipating and responding a patient need. So we really structure the processes for the patient. We don't bring the patient to the process, we bring the process to the patient. Okay, providing reliable care, hospital system deliver reliable care that is 24/7. And definitely evidence-based care. The core team instills confidence by providing collaborative and evidence-based care. And here is, as I promised earlier, here is the diagram that is available by HI, where you have very detailed secondary driver, and here are on the right side of the screen the secondary driver, that each cluster feeds into the primary driver that I have shown you earlier, and they all feed into the main aim of this initial model. So this was done in 2011, as seen here. And this is the new, if I may say, the new framework, the new approach for patient experience as advanced by the Barrel Institute. And you can see a lot of similarities. Some concepts are still there. They stand the test of time, if I may say, like a decade ago. But some other new concepts are put into place. And these are the drivers of patient experience according to the Barrel Institute, a model, culture and leadership. So it's basically always there. Infrastructure and governance. So this is an element that has been extracted from the leadership component and put much more into perspective. Staff and provider engagement is still there. Policy and measurement is much more prominent. Environment and hospitality, this is a completely new element. Innovation and technology, also, it's a new element to patient experience. Patient, family, and community engagement has been always there and it remains. Quality and clinical excellence is also present. So you can see that we have added elements that were not present a decade ago, and we have new elements that has been put into focus by giving them some more attention and extracting them as a standing dimension. And here is the definition of each element. I will not go into the details because of the time pressure. However, I'm going to discuss the aim of this model, which is to advance strategic lens. Through this strategic lens to advance patient experience, it provides a mean through which organization-wide assessment to address experience assessment and excellence is done. So you make sure that you have these 8 strategic lens and you start assessing your patient experience across these dimensions, okay? And when we compare, we can see that, the opening slide where I have put what the patient wants. And if you compare both models, they are both trying to satisfy the elements that the patients really has expressed through decades of survey by their expectations from the healthcare system. Now I'm going to cover quickly some practice-driven examples to give you some ideas how to really implement some of these drivers in your own healthcare institutions. First one is having people who are assigned or dedicated to be experienced patient experience professionals. This is a formal or an informal leader who influence the system, processes, and behavior that cultivate consistently positive experience as defined by patients across the care continuum. The role is currently defined according to 4 domains, and here on the right side of the screen, I have really listed for you the definition of the role and the tasks that they are responsible across the domains, okay? Important for function definition and capacity building purposes, they are very important people in the healthcare team to develop people and to develop the concept of patient experience understanding among your staff. They are key for successful and sustainable patient experience efforts in any organization. So this is one initial step. Second, language of care training, and this is an evidence-based, skill-based approach to enhance communicating, caring, and empathy. So in the past, we said that empathy cannot be learned. Now there is a big shift with this program, and there are many other programs in place, but this one is evidence-based. A lot of supporting research is being done across it. Personally, I have experienced training my staff in previous practices, and really it led into a different approach to patient, different understanding to the communication dynamics with patients. So it teaches staff and providers at all levels, including physicians, the 7 habits, and these are the listed, and their approach is the heart, head, heart. So any message you want to give, you start with the heart, you put the head or the logical part of the message, and you end it with the heart. So this is their framework for communication, and followed by the 7 habits, the practice of presence, acknowledging feeling, showing caring non-verbally, explaining positive intent, the blameless apology, the gift of appreciation, and say it again with the heart. So this is the basic framework for the language of caring training. Why it's important to train your staff to enhance patient experience, because it encourages empathic communication, it personalizes care approach without scripting, and improves patient experience scores tremendously. How this is done, and here I'm sharing my experience, it's very important to start by having a very solid assessment and planning phase, then starting communicating and capacity building that is related to each skill or habit, what we call it habit, have secure leadership support for that, and sustain improving by doing a lot of coaching on site, a lot of training that is situational training. And it's very important to adapt it culturally, because every culture is different in relation to how we communicate with our patients. Another example from the practice is creating an integrative cancer care support. Why it's important? Because it has been proven that integrative approaches to cancer care decreases symptom and improved quality of life. Adopting such an integrative approach is important to manage side effects that come with cancer treatment, recovery, and survivorships. Such an approach includes combining evidence-based integrative therapies with the conventional medicine, including radiotherapy, radiation, surgery, whatever, to create a cohesive approach to cancer care. So, and these are the components that we usually include when we are thinking about a comprehensive cancer care approach or an integrative cancer care framework. Another practice exemplar, which is the bedside shift report, and this is a shift from giving an office report to really bringing the intershift report from nurse to nurse to the bedside. And this has proven to really improve communication with patient and to improve mostly the opportunities of missed care, and to improve engagement of the patient in his or her own care. Okay, sharing here my experience from previous practices where for cultural perspective, instead of completely moving forward into having an intershift report that is exclusively in the room, what we did is that we divided the process of the bedshift side report into two phases. Phase one, out of the room, then we shift during the round and do the rest of the report inside the room. What we talk about as nurses, what we discuss in phase one outside the room, we transmit the clinical information, we transmit the patient background, and we use the SBAR tool to really hand over all the clinical information that is relevant to the patient. Then we go inside the room, both the ongoing and the incoming nurse, and they start sharing history. They do the physical assessment together quickly. They do the environmental check. They discuss the plan of care with the patient. They check and assess the preference if there is any, and they engage the patient and care partner in the plan of care for the coming shift. Okay, this phase approach really allowed nurses to remove conception and reflect. We did it because this is what they asked for. Okay, they were afraid to implement it at one shot, like go from the office directly to the room. Like if we do it by stages, it was much more approachable. In doing this project, we used active educational approaches. We reviewed local context and removed barriers to ensure organizational processes support for the bedside report. We did some scripting for the nurses at the beginning, and we trained them on language of care habits to support and improve their confidence when dealing with patients, and especially when dealing with sensitive information in a culturally adapted way. And engaging the patient in the process of care was achieved by really considering their preferences. Okay, so this is another example. And the last example that I'm going to cover is telehealth, how to really implement telehealth and elevate the human experience when really using telehealth because we don't want to use the human touch when talking to a screen. And you know that telehealth has really been very much into demand and has seen an upsurge during the latest pandemic. And here is some statistics related to during the pandemic or mid-pandemic. In a recent survey, when 1,000 patients in the United States were surveyed, done at the mid-pandemic, result revealed that 75% of patients using telehealth were satisfied with their experience. So this is a very good news for people who are considering to really have telehealth in place. However, more is to be done on the improvement of empathic communication and follow-up. The top drivers were convenience, safety of being at home, and speed of access that was stated by the patients. However, the top dissatisfied were the quality of care, impersonal experience, and technical issues that were faced. And this is a suggestion for you if you want to really create more empathic telehealth care that is delivered through different modalities. When designing your process, you need to design and measure the virtual journey across these three stages. The awareness and access, how patients learn about and access the virtual care visit, the care experience itself, how patients felt about their virtual experience and the care they receive, and the follow-up and future interest, how patients want to utilize virtual care in the future. So this is very important from a design perspective. On the right side of the screen, I'm showing you like a screenshot of what the LOC training would be or the scripting would be when you want to really train your staff. And this is only an example. It's like a 5-page thing script, but here I'm just extracting like a screenshot of one part of it, just to show you that you can train your staff across the stages of telehealth to really demonstrate more caring and more sensitive approach to the patient. And here is an example of how to do it. Final thoughts, integrating patient experience for health and wellness are part of the care. So this is where we are going in the future. Evaluating patient experience feedback and frame improvement actions accordingly, it's very important. So we just only measure the patient experience. We need to really frame the improvement accordingly. And we offered here in this session today many frameworks to really start improving improvement actions around them. Elevate the experience of all patient touch points, not only the clinical interaction. We're mostly focused by the clinical interaction, but really a patient experience is across the board. And then place a central focus on the relationship between the patient and the healthcare practitioner, which is a cornerstone element of any quality of care. Thank you so much for your time. These are my references. And for any questions, I'm very happy to receive you, and if you want to contact me by email. Thank you so much for the organizing committee for this invitation, and I'm ready to take any questions if we still have time.
So thank you so much for sharing your topic, Dr. Rana Abdul Malik. So if you have any questions or comments, please text in the chat box. Okay, so moving on to our next presentation, Dr. Maha Al-Qasr, Maqasid, University of Beirut, Lebanon.
Good morning, everyone. Is my voice clear?
Yes, yes. Go ahead with your presentation.
Okay, thank you. My name is Maha Al-Qasr. I'm a faculty member of Maqasid University of Beirut, School of Nursing and Health Sciences, the university that I am representing today with a great honor. First, I would like to thank those who organized this event. I think it's a perfect mix of topics, people, science, and social gathering, where nurses and other healthcare professionals from all over the world can meet and share their studies. Such gathering will definitely have its influence on nursing researchers, evidence-based education, and on future nursing practice in general. So again, thank you, Inovine, for organizing the 6th World Congress on Nursing Education and Health Sciences. Now I start sharing my studies. Are you able to see it?
Yes, yes.
Okay, thank you. My study is about a comparison of two methods of delivering information, pre-coronary angiography. Coronary artery disease is impaired blood flow in the arteries that supply blood to the heart. It is the most prevalent form of cardiovascular diseases. Coronary angiography is the gold standard for determining the presence of obstructive coronary artery disease. It is an invasive procedure which has various physiological and psychological complications. Because of the great attention being given to the physiological complications, their occurrences have become rare, whereas psychological needs of the patients are not being handled and are not given the same attention as with respect to the physiological needs. Therefore, many patients may suffer from psychological disturbances associated with the procedure, including anxiety and psychological distress. Anxiety is described as the fear of the unknown, as disproportionate to the threat involved related to the future, whereas psychological distress is defined as a state of emotional suffering which may be characterized by symptoms of depression, loss of interest, sadness, hopelessness, and anxiety, restlessness, or feeling tense. It is found that patients who receive educational information before the procedure have less anxiety, distress, and their related symptoms. Educational information can be delivered through different methods or medias, including pamphlets, videos, face-to-face interaction, or verbal. The use of videos in patients' education has been associated with increased patient satisfaction and increased physician satisfaction, which meet the requirements of the accreditation of healthcare organizations. Verbal education, which is the most traditional form of patients' education, reduces patients' anxiety and stress. It also gives an opportunity to evaluate the patient's comprehension of information. What is the nurse's role in patient teaching? Patient teaching is a nursing process that involves assessing patients' learning needs, developing a trusting relationship with patients, applying critical thinking, delivering knowledge, collaborating with other team members. What was the aim of the study? The aim of the study was to compare the effects of two methods of delivering information, pre-coronary angiography, on anxiety and psychological distress. The hypothesis: delivering both verbal and video information is more effective than delivering verbal information only in reducing pre-coronary angiography anxiety and psychological distress. Moving to material and methods. A quasi-experimental research design was implemented. The study was conducted at Cardiac Cath Lab, Baqasid General Hospital, Beirut, Lebanon. The subject was comprised of convenient sample of 100 patients undergoing coronary angiography. Inclusion criteria: adult patients undergoing elective diagnostic coronary angiography for the first time. They were allocated into two groups, randomly allocated into two groups. The control group was educated by nursing verbal information method, while the study group was educated by both verbal information and the video information method. Who was excluded from the study? Any adult who had visual or hearing problems that are not corrected, history of psychological disorders and not receiving medication, and who had undergone previous coronary angiography. With respect to tools, the study used three tools: the State Anxiety Inventory, the SAI, the Profile of Mood States, POMS, and tool 3, it is the physiological indicators of anxiety and psychological distress, as reflected in blood pressure, systolic and diastolic, heart rate, and the respiratory rate. Tool 1, which is the State Anxiety Inventory, It is a 20-item self-report instrument used to evaluate an individual's temporal feeling of apprehension, tension, nervousness, and worry. Additionally, patients' demographics and health-related characteristics were included in this tool, such as age, gender, marital status, level of education, and past medical history. Tool 2, which is the profile of mood states, it's a 65-item self-report instrument to assess 6 mood subscales. Moving to tool 3, it is the physiological indicators of anxiety and psychological distress as reflected in blood pressure, both diastolic and systolic, heart rate, and the respiratory rate. بالمثل, an official permission to conduct the study was obtained from the university and the IRB of Maqasid General Hospital. Tools 1 and 3 were translated into Arabic. Tool 3 was developed by the researcher and its content was tested for validity. The reliability of the tool were tested using pre and post test. Video demonstrating coronary angiography was developed by the researcher after reviewing the relevant and recent literature. A pilot study was carried out on 5 patients that were not included in the study to test the feasibility, clarity, and the applicability of the study tools, and accordingly modifications were done. Patients admitted for elective diagnostic coronary angiography and who were potentially eligible for the study were randomly allocated into 2 groups. Patients' demographic data, health-related characteristics, and anxiety levels were assessed using tool 1 and mood state using tool 2. In addition to the hemodynamic parameters, blood pressure, respiratory rate, and the pulse rate using tool 3. The study group received the information by using a verbal and video educational method, while info present in this video was delivered verbally for the control group. After giving education, the anxiety level, mood state, and physiological manifestation of the stress and anxiety were measured again using tool 1, 2, and 3 respectively. Data collection started 6 months and was lasted for 6 months and entered into the SPSS program. Data obtained was confidential, and patients' withdrawal from the study of any stage at any stage definitely was allowed. Moving to results. The mean age distribution among the study group and the control group. In the study group, the mean age was 56.54 years, whereas it is 59.2 in the control group. With respect to the gender among the study and the control group, in the study group, approximately half of them were 52% were males and 48 were females. And in the control group, 54 were males and 46% were females. Moving to the marital status among the study and the control groups. In the study group, the majority, 94% were married and 60% were not, whereas in the control group, 88% were married and 12 were not. With respect to the level of education among the study and the control groups, in the study group, 10% reached the elementary level, 42% the intermediate, 36% secondary, and 12% reached university level. Moving to the control group, 22% reached elementary, 32% intermediate, 38% secondary, and 8% they reached the university level. Concerning the association between the total POMS score and the intervention, here we have to mention that POMS score, there is no cut-off level for the POMS score, only the comparison pre and post intervention were used. In the study group, the score before intervention was 92.3, whereas it decreased to 90.8, 90.9 post-intervention. Whereas to the control group, the score pre-intervention was 87.7, and it decreased to 85.7 post-intervention. As with respect to the SAY, the cutoff level is 39 score, which means that all who has above this score, 40 and above, they have positive SAY, or they are positive for anxiety. They do have anxiety. In the study group, the score pre-intervention was 52.18, and it decreased to 50.3 post-intervention. In the control group, the score pre-intervention was 42.6, and it also decreased to 40.7 post-intervention. As to the mean systolic blood pressure, in this here it is used that any patient exceeding 140, it's considered to be abnormal or elevated the blood pressure, systolic blood pressure. As to the mean systolic blood pressure in the study group, the mean was 136.8, and it slightly increased to 138.24. Whereas in the control group, the mean systolic blood pressure was 128.9, and it also approximately remained the same pre with respect to post-intervention. With respect to the mean diastolic blood pressure, in the study group, here we used any elevation in the diastolic blood pressure above 90 and above, it is considered to be elevated. In the study group, the mean diastolic blood pressure before intervention was 79.9, and it slightly increased to 81.9, whereas in the control group, it was pre-intervention 76, and it approximately remained the same. Moving to the heart rate, in the study group, the mean heart rate was 75, and it increased to 77.8%. Here, it is taken that heart rate above 100% is considered to be abnormal. Whereas in the control group, the mean heart rate was before intervention was 69.7, and it approximately make no change pre and post intervention. Moving to the respiratory rate, any respiratory rate, any value above 20%, it's considered to be abnormal. The mean respiratory rate in the study group was 19.24, and approximately it remained the same. It moved to 19.32. Whereas in the control group, pre-intervention, it was 19.4, and it slightly increased to 19.8. With respect to the distribution of positive SAY, yani those who have anxiety, who scored above 40, as we mentioned before, that is the cutoff level is 39. 4% in the study group have a score of less than 45, between 40 and 45, 38% between 45 and 55, 48% between 55 and 65, and 10% above 65. All those have positive SAY, yani do have anxiety. With respect to the control group, between 40 and 45, they account for 16.2%. Between 45 and 55 score of SAY, it accounts for 13.5%. 40.5 between 55 and 65, and 29.7 those scored 65 and above. The distribution of gender among positive SAY in the study and the control group, approximately half, approximately 52% were males and 48% were females with positive SAY in the study group. And while in the control group, 51.4 males and 48.6 females, those who have positive anxiety. Moving to the distribution of marital status among positive anxiety level, in the study group, majority were married. They account for 94%, and the 6% goes to the non-married, while as in the control group, 97.3 to the married and 2.7 to the non-married. Moving to the mean distribution, of the level of education among positive say, in the study group, 10% reached the elementary, 42% the intermediate, 36% secondary, and 12% the university, reached the university level among those who have positive anxiety. Whereas in the control group, 24.3 those who reached elementary level, 24.3 again for intermediate, 43.2 for secondary, and 8.1 for the university level. Conclusion and recommendations. Based on the results of the current study, it can be concluded that both the video and verbal education, pre-coronary angiography, are effective in reducing anxiety associated with this procedure. However, none of these methods was found to be more effective than the other in anxiety reduction. Concerning the physiological parameters of the anxiety, there was no statistically significant difference in the systolic blood pressure, systolic and diastolic, and the respiratory rate in both the groups between pre and post intervention. Concerning the recommendation, based on the previous results, it can be recommended the following. Keep the verbal education intervention pre-coronary angiography in practice. Start using the video education intervention pre-coronary angiography in order to make the nurses get familiarized with this method. For the future studies, there is still a need to replicate this study with different settings and several institutions in order to be able to generalize the results. Further future studies are needed to evaluate the effectiveness of educational information that is provided as soon as patients are informed of their needs to undergo coronary angiography could be considered. Thank you. Please let me know if anyone has a question. I'm ready to answer.
Thank you so much, Dr. Maha.
Thank you.
So is there any questions to ask? You can ask. Or you can text in the chat box. So moving on to our next presentation, Dr. Sandra de Rome, Monash University, Melbourne from Australia. Hello, Dr. Sandra.
Hello.
Yes.
Can you hear me?
Yes, yes.
Okay, thank you very much for the opportunity to present. Can you see my presentation?
Yes, yes.
Great. Okay, I wanted to talk to you about a process for encouraging undergraduate nurses to engage with perioperative practice. And perioperative practice refers to caring for patients before, during, and after surgery. And I've developed an effective model to grow the perioperative workforce, providing nursing theory and precepted clinical rotations to inexperienced nurses using a collaborative multidisciplinary arrangement is recommended as an effective model to connect and grow the perioperative workforce. I live in Victoria, which is, if you look at a map of Australia, we're down in the corner on the east coast. And some of our demographics include nurses encountering increasingly complex patients due to high rates of comorbidities and obesities, both in Victoria and Australia, chronic and complex patient conditions that constitute greater than 70% of Victorian healthcare costs. There's a projected increase in hospitalised patients over 65 years old, up to, the predictions have been done up to 2031. But that's also has been compounded by COVID, of course. And we need to grow our perioperative nursing workforce because there's reduced or no exposure to perioperative nursing during many of the undergraduate Bachelor of Nursing courses, and working very hard with the universities to try and improve that. We've also got an ageing perioperative workforce, an increasing population in Victoria, an increasing complexity of aging patients, as discussed, and research clearly demonstrates the value of guided perioperative nursing for undergraduates on the effective recruitment and retention of nurses. This is data from 2019. The further data is still being collated. It's been a little skewed with the COVID outbreak. But you can see there that we really need to push our nurses into specialised practice, particularly in midwifery and in perioperative nursing. We've also got increasing elective waiting lists, and that's been compounded by the COVID situation. In Victoria, we were one of the most locked down cities in the world, and so there was quite a delay placed on our patients awaiting surgery, awaiting elective surgery in the public hospital system. The government have been very proactive. They've increased the funding dramatically and increased the number of educators. So we're pushing to attract undergraduate students through into the perioperative stream. So hopefully we will improve. This is some data too from 2020. We find it very difficult to get suitable applicants for perioperative practice, but if they come and undergo this program that I'm going to explain to you, many aren't expecting to enjoy it so much, and they really want to come back and work in the operating suite. We've also noticed that attitudes of nurses towards their jobs and their employers have changed with the pandemic. Amid insufficient staffing and years of the challenging COVID situation, the need for parents to teach their children at home when schools were locked down, and many clinicians are expecting more flexibilities from their employers. So we're working on that as well. But assisting undergraduates to make a career decision can help successfully recruit, support and retain nurses in specialised areas of practice. Okay. So we need to open the door and demystify the operating suite to recruit nurses. A shortage of specialist nurses, compounded by the rapidly growing population, increasing age of nurses, and lack of undergraduate nurse exposure to perioperative nursing, necessitate innovative measures to introduce perioperative nursing as a rewarding career option, and to implement strategies to recruit and retain nurses in this area of specialty practice. An interactive program enables undergraduate nurses to experience perioperative patient care in a well-supported, precepted environment. So we get our undergrads coming through from 2 to 6 weeks. Generally, the median's about 4. And then if they come back for a graduate year, most of them do a 4-month or a 6-month rotation. And if they go on and do postgraduate studies, it's a 12-month university course. Most undergraduate students are planning their career path, and they really want to secure a place in a graduate nurse program. That's their main goal following completion of their degree. An undergraduate perioperative placement often steers their career plans in an unanticipated direction. They don't realise how much they love it. So it's all about the selling. So engaging and innovative education We've got clinical coaches, preceptors, and clinical nurse educators to support the students and innovative teaching and learning strategies. And they're designed to empower students to become involved in their learning, provide insight into the perioperative patient's journey, enable an appreciation of the complexities associated with perioperative nursing practice, and they achieve a comprehensive series of learning activities. And it really is hard work I put them through, but they absolutely love it. It certainly engages them. So they're precepted by superb teams of perioperative nurses using a structured program. So this information is imparted to the senior nurses so that they understand the reasons for running these programs, and they can see over time that they recruit great staff that are really interested in learning this area of specialty. A high level of inclusion helps build confidence as the inexperienced nurses integrate into the multidisciplinary team, and they're encouraged to focus on evidence-based practice and perioperative patient care. They experience diverse aspects of care delivered by various perioperative nursing and medical roles. And so engaging novice nurses using precepted immersion connects clinical practice with theoretical concepts to create a positive perioperative experience. So we have careful selection and preparation of the preceptors. We welcome the students with empathy. We know it's scary. Coming into an operating suite is like going to another planet. Everyone's wearing the same scrubs. They don't know if it's the cleaner or the consultant. You know, it's difficult to work out who's who. So we really need to nurture them as they come through. We give them a good orientation and structured learning. They have collaborative relationships with the multidisciplinary team and regular daily debriefing and feedback. The preceptors want to teach those with less experience. We do encourage this, but occasionally you get some that say to me, look, I'm just over it. I don't want to do it, or they've got things happening in their life. And I say, that's okay, take a break. But their attitude and their welcoming persona really does greatly influence the recruitment and retention of these nurses. They're genuine, welcoming, inclusive, empathetic, approachable, knowledgeable, and enthusiastic. And they go through a preceptor and assessment course in preparation for this. Prior to commencing their placement, the students receive a welcome information package. They get a timetable, and I explain what's required, you know, that to keep their nails short and wear no jewelry and all that kind of thing, so that they're really well prepared when they arrive. They've got comfortable shoes on, and on the first day, they're orientated to the operating suite in the broader hospital. They usually work 4 10-hour shifts a week. And I put them through all the different areas: holding bay, the sterilisation services, instrument and circulating nursing roles, anaesthetics, and the post-anaesthetic care unit. I give them learning activities to complete, which are quite comprehensive, and they're to keep them in their pocket so that they can quickly pull them out and ask questions. And I commonly receive comments from particularly the anaesthetists, but also the surgeons. They say to me, oh, your students are so bright. They ask amazing questions. And I think, oh, yes. I say, oh, they're very clever these days. But they're asking the questions from their notes there. So it enables them to become immersed with the different roles and develop a rapport with their preceptors and the multidisciplinary team. And as they delve into their learning activities, they're encouraged to ask lots of questions. We get a bit concerned if they're not asking questions. I need to make sure that they've got timetabled allocations that are appropriate. You know, the list or staffing may change, the procedure may be inappropriate. You know, we may be doing a organ procurement or, you know, a range of procedures that are just not appropriate for an inexperienced nurse. So need to work that out. And that's just reviewed each day before they arrive, so that we're making sure that they have a really great experience. When they're in the holding bay, where the patients are admitted to the operating suite, they look at consent. They're given a range of activities to review. So here's some of them outlined here. You know, they need to tell me what would a nurse do if a patient stated that they've changed their mind and now they don't want to undergo surgery. So we talk about those kind of things and meet with them every day. We talk about marking the site of surgery, fasting, and patient's allergies, etc. So hopefully, even if they don't go on and work in perioperative nursing, what they're learning will help them in their future careers. In anaesthesia, they learn about checking the anaesthetic machine and the different drugs that are administered to the patients, and priming lines, etc. It's quite hands-on. So they're really getting in there and not just standing in the corner, but certainly being involved in the patient care with their preceptors. They need to explain the checks that we perform to make sure that we've got the right patient having the right procedure at the right time on the right site or side. So we go through all of that. I ask them to, for example, tell me why hypertension can occur with spinal anaesthesia and why a patient is tilted when they're having a cesarean section, that kind of, those kind of activities. In the instrument and circulating role, we teach them how to scrub gown and glove and get them scrubbed up at the operating table so that they can really learn and see the anatomy up close. And they learn about the minimising blood loss, and these are just a sample of some of the questions. There's certainly a lot that are given to them. In the recovery room, the post-anaesthetic care unit, they have to explain what the anaesthetist hands over to the PACU nurse and describing the assessments that are undertaken, and they'll be undertaking these assessments with guidance from their preceptors so that they really learn well how to care for the immediately post-op patient. And they look at pain and pain scales and the various medications that may be prescribed. And they jot these down, and I've got a whole table of drugs that they need to examine. And they find that really helpful. They look at drain tubes, urinary output, what happens when a patient's returned to either the ward or day surgery, and how to provide a comprehensive handover for a patient going back to the ward. So it can be an unanticipated career path for these nurses. And we find that hospitals that welcome the undergrad nursing students to perioperative placements do recruit if they're really well cared for, and they complete their structured learning activities, enjoy their placement, and often apply for a graduate nurse program that has a perioperative nursing rotation. They then, after their graduate year, they often apply to university to study a Master of Nursing Practice, and many are retained in the operating suites and progress to the clinical nurse specialist and beyond. And then they become preceptors, and they're just fantastic preceptors because they absolutely know, what this all involves. So in summary, this presentation has described an effective process to engage novice nurses through supported immersion, linking clinical practice with theoretical concepts to create a positive perioperative experience. Careful preparation and selection of preceptors, collaboration with a multidisciplinary team, student orientation and empowerment, combined with regular feedback, are pivotal to the success of this program. Thank you very much. Does anyone have any questions?
Yes, thank you very much, Dr. Sandra.
Thank you.
So we have missed your presence for the conference in person.
Oh, I know. I was so sad. Hopefully I'll make it to the next one. I really wanted to come, but I was quite unwell, so I was unable to fly.
No problem, no problem.
Thank you very much for the opportunity, though.
Yes, if anyone having questions? Okay, so moving on to our next talk by Dr. Sudha Anbangal Bhalagan Santami Salve, sorry for wrong, from Wadi Aldavasa General Hospital, Ministry of Health, from KSA University. Hello, Dr. Sudha.
Hello, hi, good
Yes,
morning.
yes.
I'm just sharing my screen.
Yes, yes.
Good morning, everyone. I'm Sudha Anbalagan. I'm master in nursing, doing doctorate, and I've done my PGDHM and CPHQ also. I'm working here as a nursing educator in Wadi Al Dawasir General Hospital, Kingdom of Saudi Arabia. Wadi Al Dawasir is one of the town in Kingdom of Saudi Arabia, which is having 1 lakh and above population, having this hospital, Wadi Al Dawasir General Hospital. I'm working as a nurse educator here. So this is the performance improvement project on CRRT, that is continuous renal replacement therapy. So first we will see what is continuous renal replacement therapy. It's a slow and continuous extracorporeal blood purification therapy, just like a hemodialysis, but actually this is not hemodialysis because this is mainly for ICU critically ill patients who's having acute renal failure or acute kidney injury. Once again, this is an extracorporeal blood purification intended for critically ill patients in intensive care unit to deliver different modalities. The CRRT having different modalities for a patient with impaired renal function and sepsis, fluid overload, hyperkalemia, and also drug toxicity. It provides a continuous clearance of the blood, continuous replacement of electrolyte, acid base, and continuous removal of fluid in a slow motion for extended period of time to maintain a hemodynamic status of the patient. So this may be for 24 hours and this may be for 6 hours or 8 hours. It depends upon the nephrologist. And these are all the machines we are using for CRRT, Fresenius multifiltrate CRRT machine, Prismaflex Gambro CRRT machine. These two machines we are using in our hospital for CRRT, that is continuous renal replacement therapy. These machines are relevant and these machines are convenient and effective for acute renal replacement therapy. These machines are providing services of different modalities, which includes SCUF. SCUF means slow continuous ultrafiltration, CVVH, continuous veno-venous hemofiltration, CVVHDF. This CVVHDF is one of the common modality of treatment of CRRT we are using in our hospital, that is continuous veno-venous hemodiafiltration. And other modalities also available, but each machine has its own individual features and treatment modes. But it's using different mechanisms like ultrafiltration, diffusion, convection, and adsorption. Like a different mechanisms are used in the CRRT modalities. Introduction: CRRT is progressively more applied in intensive care setting. It's significant for critical care nurses to be skillful and knowledgeable in initiating and managing the patients, those who are receiving CRRT, by ensuring safety and quality of care. It's been observed that in the course of COVID outbreak since the year 2020, there is additional necessity for CRRT care services due to acute renal failure or acute kidney injury secondary to COVID-19. Henceforth, found that in Wadi Dawasir General Hospital, lack of trained and practiced nursing staffs for CRRT on hemodynamically unstable patients in the critical areas of ICU and COVID ICU. And moreover, there was role confusion and conflict between kidney unit, AKU means this is artificial kidney unit, and critical areas in this regard. Henceforward, to prevent the problem in the future, this topic has been initiated for the project. Here, the diagram shows that quality of healthcare model. This is before initiating this performance improvement project. This is the quality of healthcare model. The structure includes all of the factors that affect the CRRT. CRRT performed in kidney unit and by kidney unit nurses. Lack of utilization of CRRT machines like Fresenius and Gambro machines. Lack of staff training on CRRT. Less number of trained nurses on CRRT in critical care units. There is no policy and procedure guidelines, and there is no clinical pathways, and there is no competency checklist for CRRT. And also, the important factor is COVID-19 environment. And the process include is the sum of all actions required in CRRT performance improvement project. The actions required as follows: identify the problem, organize a team, clarify the current process, understand the current problem, Select desired expected outcome and plan for actions, implement the actions as planned. Check for all the end results of performance improvement project. An outcome contains all the effects on patients or staffs, including changes to health status, behavior, or knowledge, as well as patient satisfaction, etc. There is no pathway for CRRT, which is required for the patient management. Lack of international ICU standard of care, increased time of care, increased patient risk, and also it's affecting quality, efficiency, and continuity of service. In this project, focus PDCA as methodology is adapted. The F stands for an opportunity to improve. So this is my statement of problem, that is to increase CRRT trained nursing staff from 38% to 100% in critical care units of ICU and COVID ICU within 3 months. Less volume of trained nursing staff for CRRT on hemodynamically unstable patients in the intensive care unit of ICU and COVID ICU. As a result of increasing number of CRRT trained staffs in the critical areas through accurate educational programs with practice patients, can be improved CRRT care of renal failure patients in critical care settings. And O stand for organize a team. I organized a team for initiating this project. I myself, as a team leader or project manager, and ICU head nurse, and artificial kidney unit head nurse, and charge nurse of kidney unit, and also ICU staff nurse, and with the definition of their roles and responsibilities. And also nephrology, 2 nephrologists as a subject expert, and ICU specialist, he is head of the ICU, and education and training coordinator, and total quality management and patient safety staff. These all the team members, their individual roles and responsibilities were defined and explained to them. C stand for clarify the current process. This is before initiating this performance improvement project. The patients, those who are met with clinical and laboratory patients who met with clinical and laboratory indicators for CRRT, whether hemodynamically stable patients or unstable patients, the CRRT has been done in artificial kidney unit. Can you please mute your mic? Can you please mute all of your mic, if you don't mind? If hemodynamically stable patients or unstable patients, the CRRT will be done in artificial kidney unit, but critically ill patients, the CRRT will be done in ICU. CRRT procedure initiation and termination by kidney unit nurses. So because of this process, there was conflict existed between kidney unit and also the ICU. So U stand for understand the problems or variations in the process. The fishbone analysis for CRRT shows that the under manpower, deficiency of CRRT trainers, there is nursing staff shortage, less number of patients requiring CRRT, and methods, no CRRT policy and procedure guidelines. There is no frequent CRRT internal and external trainings. Under environment, there is COVID-19 pandemic circumstances. Under the measurements, there is no CRRT nursing competences for all the nurses. Inadequate CRRT equipment and supplies for training also. So from this analysis, I selected the objectives, which includes to train 100% of critical care unit nursing staffs for performing CRRT procedure, to minimize transferring hemodynamically unstable and critically ill patients from critical care areas to kidney unit for CRRT, to create nursing competences to assess and evaluate the critical to create nursing competences to assess and evaluate the critical care nurses' skills on CRRT procedure, to make pathway, policy, and procedure guidelines for CRRT in critical care settings. These all were my desired outcomes. And P stand for plan the project and assign the task for the team members. The project planning under the steps. Step 1 is list the critical care nurses. Step 2, ensure sources available for CRT training. Step 3, arrange for internal and external trainers. Step 4, prepare CRT nursing competences, PPGs, and clinical pathways. Step 5, schedule the CRT training. Step 6, train all critical care nurses for CRT in controlled environment. Step 7, assess the critical care nurses competency in pre, intra, and post CRT procedure. Implement CRT in intensive care settings by excellent level trained nurses. And the last step is implement newly formulated and approved CRT PPGs and pathways. Under this plan the project, we have assigned the task for the team members under the activities involved and responsible person and what is the target date, resources available, and what will be the outcome. Under these headings, the tasks were assigned for the team members. And D stand for do the work that's needed. So based on the assigned task, the team members were requested to complete their task. And C stand for check the results and measure changes. Almost 3 months have been taken to train the critical care nurses for CRRT. That is month July to September 2021. In these 3 months, there were almost 3 sessions were conducted. In each sessions, almost 24% and 19%, 29%, 10%, 14%. In this individual sessions, almost these percentage have been trained for each sessions. And critical care nurses CRT competency level in percentage. Actually, the CRT competency level has been classified as below average, average, good, very good, and excellent. In this, COVID ICU nurses fall in 10% under below average, and under 30 percentage of the COVID ICU nurses under good competency level. And overall, ICU nurses 100% they have shown excellent competency level in CRRT, and 60% of COVID ICU nurses have shown excellent level of CRRT competency. And the competency evaluation on CRRT has been evaluated on 3 domains, that is knowledge, skills, and attitude. The skills has been divided into 3 categories as a pre-CRRT, intra-CRRT, and post-CRRT. Under the knowledge, 100% of ICU and COVID ICU nurses have shown their competency. In pre-CRRT, 100% of ICU nurses, 80% of COVID ICU nurses. In intra-CRRT, 73% of ICU, 60% of COVID ICU staff nurses. And post-CRRT, 82% of ICU and 60% of COVID ICU nurses. And attitude, totally 100% of ICU and COVID ICU nurses have shown competency evaluation. In intra-CRRT, the percentage is less because all the nurses are having trouble in troubleshooting of alarms, which is produced by the CRRT machines. And A stands for act to maintain the changes. In this, what is the recommendations or the actions should be followed in the hospital is adhere to the CRRT policy, procedure, and pathway. Constant CRRT competency assessment is required. Continuous education and training is required for critical care nurses on CRRT at best of every 6 months in a year. External CRRT training need to be arranged, particularly for troubleshooting the alarms. CRT training should be made as a prerequisite for critical care nurses before appointing them into the unit. At the end of my presentation, it's showing now quality of healthcare model. This is after initiated of this performance improvement project on CRRT. So here under the structure, now CRRT performed in critical care units only for hemodynamically stable patients and unstable patients by critical care nurses only. CRRT machines, Fresenius and Gambro machines were utilized for CRRT procedure. Internal and external trainings on CRRT were being arranged. 100% of critical care nurses trained on CRRT. Now there is policy and procedure guidelines. There is clinical pathways. There is competency checklist or developed, and it's available for future use to evaluate the nurses on CRRT. Under the process, This project is based on focused PDCA methodology. I identified the problem, organized a team, clarified the current process, and understood the current problem, decide expected outcome, and planned for the actions. And the same actions have been implemented, and also checked for all the end results of this project. The outcome of this project is there is clear pathway for patient management, those who are requiring CRRT, and also met with ICU standardized care, because CRRT should be done in ICU only, not in the kidney units. And also it has decreased the time of care and decreased the patient risk. Thank you so much. If you have any doubts and queries, please, you can ask me.
Thank you so much, Dr. Sudha.
Thank you, dear.
So, is there any questions to ask? So, okay, moving on to our next presentation by Dr. Najao Abala, University Kadi Ayat from Morocco. Dr. Sudha, please close your screen.
Sorry.
Management of invasive small bowel obstruction. Manage invasive small bowel Management of adhesive small bowel obstruction in pediatrics. Adhesive small bowel obstruction is a mechanical disruption in the patency of the gastrointestinal tract, caused by peritoneal adhesions and resulting in combination of emesis, obstipation, and abdominal pain. Those adhesions may be acquired or congenital. However, most are acquired as a result of an abdominal pelvic surgery. Adhesive small bowel obstruction is very common in adults and is considered the second cause of intestinal obstruction. The conservative management found to be effective in a large proportion of adult cases, as well as operative management that is also effective and can be even essential in some cases, although it carries a risk of associated morbidity and mortality. In pediatric patients, there is a lack of consensus or available guidelines on the management of adhesive small bowel obstruction. Moreover, there is a small number of existing studies in the broader literature that have reviewed those therapeutic approaches in this group age. The present study was designed to retrospectively review the epidemiological, the clinical, and the paraclinical features, and mainly to outline and compare the different aspects of adhesive small bowel obstruction management in children admitted for this condition at our pediatric surgery department. This is a retrospective study that involves 61 cases of adhesive small bowel obstruction in 57 children under 15 years of age who were admitted in the pediatric surgery department of Mohammed VI Teaching Hospital of Marrakesh within a period of 7 years between January 2012 and December 2018. It aimed to review the epidemiological, the clinical, and paraclinical features, and also to outline and compare the existing therapeutic approaches of managing adhesive small bowel obstruction in pediatric patients, conservative management versus operative management, and to review their outcomes. Between January 2012 and December 2018, we have identified 61 episodes of adhesive small bowel obstruction. In 57 patients that were admitted in our pediatric surgery department, 46 patients were males and 11 were females with a sex ratio of 4.18. The mean age was 7 years and 5 months, and the age extremes ranged between 8 days and 15 years. One case was diagnosed in a newborn, while 10 cases were registered in patients under the age of 3 years. Appendicitis was the commonest previous surgical condition associated with adhesive small bowel obstruction in our patients. It was recorded in 36 children, followed by intussusception, perforated bowel by abdominal trauma, and midgut volvulus, while 3 patients had neither medical nor surgical history. Management of adhesive small bowel obstruction in pediatrics. Adhesive small bowel obstruction Management of invasive small bowel obstruction in pediatrics. Invasive small bowel obstruction is a mechanical disruption in the patency of the gastrointestinal tract caused by peritoneal adhesions and management. The conservative management found to be effective in a large proportion of adult cases, as well as operative management that is also effective and can be even essential in some cases, although it carries a risk of associated morbidity and mortality. In pediatric patients, there is a lack of consensus or available guidelines on the management of adhesive small bowel obstruction. Moreover, there is a small number of existing studies in the broader literature that have reviewed those therapeutic approaches in this group age. The present study was designed to retrospectively review the epidemiological, the clinical, and the paraclinical features, and mainly to outline and compare the different aspects of adhesive small bowel obstruction management in children admitted for this condition at our pediatric surgery department. This is a retrospective study that involves 61 cases of adhesive small bowel obstruction in 57 children under 15 years of age who were admitted in the pediatric surgery department of Mohammed VI Teaching Hospital of Marrakesh within a period of 7 years between January 2012 and December 2018. It aimed to review the epidemiological, the clinical, and paraclinical features, and also to outline and compare the existing therapeutic approaches of managing adhesive small bowel obstruction in pediatric patients, conservative management versus operative management, and to review their outcomes. Between January 2012 and December 2018, we have identified 61 episodes of adhesive small bowel obstruction. In 57 patients that were admitted in our pediatric surgery department, 46 patients were males and 11 were females with a sex ratio of 4.18. The mean age was 7 years and 5 months, and the age extremes ranged between 8 days and 15 years. One case was diagnosed in a newborn, while 10 cases were registered in patients under the age of 3 years. Appendicitis was the commonest previous surgical condition associated with adhesive small bowel obstruction in our patients. It was recorded in 36 children, followed by intussusception, perforated bowel by abdominal trauma, and midgut volvulus, while 3 patients had neither medical nor surgical history. The mean time period of development of adhesive small bowel obstruction symptoms was 1 year, and the extremes ranged between 7 days and 10 years. The patient delay ranged from 6 hours to 7 days, with a mean delay of 54 hours. Out of 61 cases, 11 cases underwent immediate surgery without any previous conservative therapy trial. 50 cases were treated conservatively, and out of those patients, 16 cases underwent delayed surgical exploration after unsuccessful conservative management. For the 50 episodes managed conservatively, 17 cases were managed according to the standard decompressive therapy, while 33 cases have received water-soluble contrast agent, gastrografine, just after their admission along with decompressive therapy, without waiting for 48 hours delay. The mean duration of the standard decompressive therapy was 2.1 days versus 3 days for the water-soluble contrast agent. The successful rate of the standard decompressive therapy was 76% versus 68% for the gastrography protocol. An overall success rate for the conservative management was 68%. 17 patients out of 71 have been managed operatively. 11 of them have had immediate surgical exploration after their admission. The remaining 16 patients underwent delayed surgery after unsuccessful conservative management trial. All operative management in our studied group have been performed using laparotomy. During surgical exploration, single ball band was found in 56% versus 44% for multiple ball bands. Adhesions was found in 63% of the cases, and only 2 patients had gangrenous ball. Adhesiolysis and retrograde decompression were performed in 25 patients, while intestinal resection and anastomosis was performed in 2 cases. The mean length of the hospital stay was shorter for the cases managed conservatively versus those managed operatively. Moreover, the mean length of hospital stay of standard decompressive therapy group was 2.1 days, which is shorter compared to the group treated with gastrografin, which was 3.5 days. There have been 4 cases of adenoid small bowel obstruction recurrence. 3 of them were previously managed conservatively. The remaining case was managed operatively. During the recurrent episodes, the 3 patients who have been previously managed non-operatively underwent surgery after unsuccessful conservative trial, while the patient who had been previously managed operatively was successfully managed non-operatively. 2 cases of death were registered in our studied group. One of them died after 24 hours of conservative management from a sudden cardiorespiratory arrest secondary to a massive inhalation of gastric content. The second died in the critical care unit from post-operative sepsis. He was previously managed operatively after 72 hours of unsuccessful conservative management. Small bowel obstruction is a significant complication after surgery, with an incidence in children between 1 and 0.9. Appendicitis is the commonest previous condition associated with adhesive small bowel obstruction in children. The incidence of adhesive small bowel obstruction was higher after perforated appendicitis than non-perforated one. Young and all reported a rate of 0.3% after non-perforated appendicitis versus 3% after perforated appendicitis. This can be explained by the high level of inflammation that occurs during perforated appendicitis. In our study as well, the majority of children with adhesive small bowel obstruction had appendicitis. 47% of cases had perforated appendicitis and 15% had non-perforated. While other surgical conditions related in adhesive small bowel obstruction in children, Vijay has reported that Hirschsprung disease and intussusception were associated with a high rate of adhesive small bowel obstruction. In our study, intussusception was noted in 7% of the children. Garantinol found that operation on the ileum is followed by a high risk of readmission for adhesion. This risk is much higher and it can reach up to 25% when ileostomy is performed. According to Agoa et al., bowel obstruction is relatively uncommon after intra-abdominal malignancies in children, with an overall incidence of 3.7. Bowel obstruction can occur anytime. Agar and al. Reported that most of the adhesive small bowel obstruction occurred less than 3 months after laparotomy, and those episodes were associated with a high success rate of conservative management, which was 81% versus 59% when the time elapsed after the laparotomy is more than 18 months. In the present study, 53% of adhesive small bowel obstruction episodes occurred in less than 3 months after the surgical procedures, and about 80% occurred in less than 1 year. In pediatric patients, most of the adhesive bowel obstruction occur within the first year after surgery. The minimum of laboratory tests includes blood cell count, lactate, electrolyte, CRP, and creatinine. Currently available laboratory tests do not contribute to the diagnosis of small bowel obstruction, but they can confirm the clinical suspicion of volume depletion, guide volume resuscitation, and assess recognition of bowel ischemia. Elevated leukocytosis counts and CRP has been implicated as a marker for strangulation, although sensitivity and specificity of these tests are relatively low. L-lactate level increases sensitivity of detecting bowel ischemia and is considered a reliable indicator for emergency surgical intervention. These are perioperative pictures of one of our patients showing a congenital adhesive band obstruction of the small bowel. The paradigm of the initial management of children with adhesive small bowel obstruction is similar to that for adults and has not changed appreciably in the last 2 decades. Non-operative management should always be tried in patients with adhesive small bowel obstruction unless there are signs of peritonitis and strangulation or bowel ischemia. Guideline of Brock et al. Under the auspices of the World Society of Emergency Surgery recommends that use of a conservative trial for managing the patients is the absence of fever, leukocytes, localized tenderness, and complete obstruction. Immediate surgery for patients with any of these 4 classic predictors: fever, tachycardia, leukocytes, localized tenderness. Eisen reported in his study that only fever and leukocytes could predict the need for operative management. There is no evidence for the optimal duration of non-operative treatment, but most authors consider a 72 hours period as a safe and appropriate. Lotz and al. Recommend an observation period of 24 to 48 hours in stable infants, young children less than 1 to 2 years, and 48 hours for children greater than 1 to 2 years of age. In the absence of clinical indicators suggesting improvement, observation periods greater than 48 hours carry a higher risk of bowel ischemia and necrosis, and the likelihood of a resolution of the small bowel obstruction is extremely low. The success rate of the usual conservative management without WSCA ranged from 0% to 73%. Despite the presence of the resource, Eisen et al. Reported a much lower success rate of conservative treatment than reported in the other studies. The reason of this rate is not apparent, but would suggest that children in that study may have had more severe adhesive small bowel obstruction episodes than those in other studies. Further studies are needed to identify the characteristics of children with adhesive small bowel obstruction who are most likely to respond positively to conservative treatment. In the present study, the success of the standard conservative management without WSCA was observed in 13 cases out of 17 cases, with a success rate of 76%, which is consistent with the published reports. Water-soluble contrast agents has a diagnostic and therapeutic role. Gastrografin is the most commonly used contrast med. Many studies have been performed to evaluate the role of water-soluble contrast in the management of adhesive small bowel obstruction in adult patients. They concluded that the contrast agent has great diagnostic benefits in assessing the indication for surgical intervention and the timing of surgery. Gastrografin helps to promote an earlier resolution of obstruction and also reduces the length of hospital stay compared with standard conservative management. However, its role in reducing the rate of laparotomies remain inconclusive. studies evaluate the role of WSCA management of adhesive small bowel obstruction in young patients. In all studies, the success rates range from 61 to 84%. Bonard has a success rate of 75%, while Linden has a success rate of 83%, while in our study we have a success rate of 64%. We present here an abdominal radiographic of one of our patients obtained 12 hours after introduction of gastrografine, showing a dilated bowel loop and air fluid levels filled with gastrografine. In B, we have an abdominal radiograph obtained 24 hours after gastrografine. Bonard and Linden have directly compared standard gastrointestinal decompression versus the use of water-soluble contrast in the pediatric population. They reported that the rate of success was relatively high in the water-soluble group compared to those treated with standard decompressive therapy. 75% and 83% for WSCA groups versus 50% and 55% for the standard decompressive. Furthermore, the length of hospital stay was also shorter in water-soluble groups. In our study, success rate in the group treated with WSCA was 64%, which is consistent with the studies reviewed. The operative management of adhesive small bowel obstruction can be performed early or delayed after unsuccessful conservative management. In our study, 18% of the patients were operated on immediately after their admission, which is an occurrence with the literature. On the other hand, delayed surgery is performed after the failure of the conservative management. Some authors indicate that there is a correlation between the timing of surgery and the risk of bowel ischemia. Figging reported that 31% of the patients managed operatively underwent bowel resection, and none of the patients who were operated on before the 16th hour needed bowel resection. He also reported that the rate of bowel resection in patients who were operated on in the first 48 hours was 12%, which was lower compared with the rate of 27% of bowel resection encountered in patients operated on lately after 48 hours. Abdominal exploration through laparotomy has been the standard treatment for adhesive small bowel obstruction. In recent years, however, laparoscopic surgery for adhesive small bowel obstruction has been introduced. The potential benefits of laparoscopy include less extensive adhesion, reformation, earlier return of bowel movements, reduced postoperative pain, and shorter length of stay. The surgical procedures have the benefit to assess the bowel viability, which will further guide to choose the right surgical procedure. For Vijay and al., they have reported a high bowel resection anastomosis, while for Eason it reported a much lower rate, which was of 9%. In our study, we have registered 7% of bowel resection. Many studies have reported the occurrence of postoperative complications. Eason reported the complication rate of 12%. The most common complications observed were surgical site infection, wound adhesions, prolonged ileus, sepsis and peritonitis after anastomosis leakage, and pneumonia. In our study, we have registered only one case of sepsis and peritonitis that occurred after operative management. The operative management required a much longer time of hospital stay in comparison to the conservative management. The length of stay for patients treated operatively ranged between 6.4 and 14 days. Recurrent adhesive small bowel obstruction continues to be a concern long after the initial treatment of obstruction, with a reported rate of 16 to 53%. Although surgical treatment of adhesive small bowel obstruction may lead to additional formation of adhesions and recurrent episodes of adhesive small obstruction, The recurrence is slightly higher for patients treated conservatively than those managed operatively. Moreover, this rises for both approaches after 5 years period. In our study, we encountered 4 cases of adhesive small obstruction recurrence. 3 were previously managed conservatively, and only 1 had undergone surgery, which is accordant with those existing studies. We have registered 2 deaths in our study. One of them died after 24 hours of conservative management from a sudden cardiopulmonary arrest secondary to a massive inhalation of gastric content. The second one was managed operatively after 72 hours of unsuccessful conservative management. He died from sepsis after being transferred to pediatric critical care medicine. At Gorenal reported a mortality rate of 1.1, 2 deaths too. One occurred after preoperative perforation complicated to advanced peritonitis, and the other after sepsis caused by peritonitis resulting from leakage. In conclusion, adhesive small bowel obstruction is one of the leading emergencies encountered in pediatric surgery that needs early and effective management. It can occur at any age and after any abdominopelvic surgery. However, in some rare cases, it can be secondary to congenital adhesions. Conservative management, either with standard decompressive therapy or using water-soluble contrast agent, is a safe and effective approach in managing adhesive small bowel obstruction. In selected children without predictor signs of strangulation and bowel ischemia, which the biological tests may assist to their recognition. However, in the absence of clinical indicators suggesting improvement, this approach should not exceed 48 hours of trial. Further prospective studies are needed to establish optimal management for adhesive small bowel obstruction in the pediatric population. However, in the light of our findings and after analyzing the related studies, we came out with this decision-making tree, which is based on some important recommendations. Once a child is admitted for adhesive small bowel obstruction, we search for the presence of worrisome signs suggesting peritonitis, strangulation, or bowel ischemia that can be evaluated either clinically, biologically, or radiologically. If these signs are or any of these signs are present, then an operative management is mandatory. If none of them are present, then we can start a conservative management and the patient is monitored. If everything goes smoothly, then we can start liquid feeding after 24 hours or 48, and we can discharge our patient. If there is any sign that is deterioration of the patient, or after for 24 hours of absence of contrast in or post-secum, then an operative management is required. Thank you.
So that was a presentation by Dr. Najab. Sorry for technical issue. We can't unable to play your slides. So we have a 10 minutes break session. So please join again.
It is a great honor to participate in this year's conference, and the objectives of the current presentation is to present briefly acute peritonitis, intra-abdominal infection, as is It is a great honor to participate in this year's to be live with you, but I had to send out my pre-recorded. It is a great honor to participate in this year's conference, and it's unfortunate that due to surgery, wasn't able to be live with you, but I had to send out my pre-recorded presentation about the open abdomen and negative pressure wound therapy for acute peritonitis, especially in the presence of anastomosis and the objectives of the current presentation is to present briefly acute peritonitis, the concept of damage control surgery in acute peritonitis, the use of open abdomens in such cases, the negative pressure wound therapy in the case of an open abdomen with acute peritonitis, and especially how to manage ostomy and anastomosis in combination with negative pressure. Intra-abdominal infections, as is already known, are divided in non-complicated infections which involve a single organ, do not spread to the peritoneum, and can be treated with either surgical intervention or antibiotic, and to complicated infections that proceed beyond the single organ, cause either localized or diffuse peritonitis, and their treatment involves both surgical and antibiotic therapy. Secondary peritonitis is the most common form of peritonitis. Is an acute peritoneal infection that is caused either by loss of integrity of the gastrointestinal tract, for example, perforation of appendicitis or cholecystitis, or cases of anastomotic dehiscence, or from infected viscera with a direct invasion, like in the cases of peritonitis with a formation of a plus complicated intra-abdominal infection in which source control is the cornerstone of treatment, and its goal is to eliminate the source infection, to control ongoing intra-abdominal contamination, reduce the bacterial inoculum, collect or control anatomic derangement, restore the normal physiologic function, and this can be done either with operation with surgery or in a non-operative way with percutaneous drainage. Source control, as said, is the cornerstone of treatment and should be undertaken within 24 hours of diagnosis. Its primary objectives are determining the cause of peritonitis, draining fluid collections, and controlling the origin of abdominal sepsis. Source control refers to the resection or suture of a diseased or perforated viscus, the removal of the infected organ, drainage of abscesses or fluid collections, debridement of infected or necrotic tissue, resection of ischemic bowel, and repair or resection of traumatic perforation with primary anastomosis or exteriorization of the bowel. The concept of damage control surgery means that in cases of severe infection which cause marked inflammatory responses, the patient develop an organ dysfunction and progress to multiple organ dysfunction syndrome. In these cases, a staged operative approach may minimize further physiological insult caused by time and energy intense primary definitive operative strategy, and so we can have the patient to resuscitate in the intensive care unit until relaparotomy. The laparotomy strategy can be either with an open abdomen, with a planned laparotomy, or with on-demand laparotomy. Regarding the difference of planned laparotomy versus on-demand laparotomy, there is no difference in morbidity and mortality. Planned laparotomy is not recommended as a general strategy in patients with secondary peritonitis. The on-demand laparotomy is recommended for patients with severe peritonitis because it has the ability to streamline health care resources, reduce overall medical costs, and prevent the need of further laparotomies with the increased morbidity this is associated. Routine planned laparotomy is not recommended in high-risk patients with severe peritonitis when adequate source control can be obtained at the time of the index procedure. Such patients should be treated with on-demand rather with a scheduled laparotomy. Damage control surgery is utilized very often in severe abdominal sepsis, where in these cases damage control surgery, especially if using an open abdomen strategies, allows for early draining of any residual infections, the control of any persistent source of infection, and prevents abdominal compartment syndromes, and also differs the definitive intervention anastomosis until the patient is hemodynamically stable and thus better able to heal. There is sufficient evidence to advocate damage control surgery as a general strategy in patients with secondary peritonitis, but damage control surgery may be an option in selected significantly physiologically deranged patients with ongoing sepsis. The indications for damage control surgery are major physiologic instability, diffuse infections, and ongoing bowel ischemia. It should be considered high risk for failure of initial source control, and the use of alternative temporizing approaches to source control is indicated. The open abdomen. The rationale behind the open abdomen is that it may be a viable option for treating physiologically deranged patients with ongoing sepsis, thus facilitating subsequent exploration and control of abdominal contents, and then preventing abdominal compartment syndrome. The rapid closure with the assistance of negative pressure therapy should be the primary objective in the management of patients with open abdomen in order to prevent morbidity such as fistula, loss of domain, and massive incisional. The open abdomen is an option for emergency surgery patients with severe peritonitis and septic shocks under the following circumstances. abbreviated laparotomy due to severe physiological derangement, the need for a deferred intestinal anastomosis, a planned second look for intestinal ischemia, persistent source of peritonitis, failure of source control, and extensive visceral edema with the concern of development of abdominal compartment. The objective is to leave the abdomen open and treat the infected peritoneal cavity like an open abscess with subsequent reoperations involving generous irrigations and potentially active temporary abdominal closure techniques, leading to a definitive control of contamination and prevention of intra-abdominal hypertension and progression to abdominal compartment syndrome. Take a look of the vicious cycle of persistent intra-abdominal hypertension in patients with intra-abdominal infection where bleeding, edema, obstruction, inflammation, surgical parking, or excess fluid lead to intra-abdominal hypertension, which in turn leads to decreased abdominal perfusion, anoxic metabolism, and finally we have the upcoming of acidosis, which leads to multiple organ dysfunction syndrome and multiple organ failure. Also, the acidosis causes the reactive oxidant species and leading to increased capillary leak syndrome and again increased intra-abdominal hypertension, but also to mucus barrier destruction and thus to increase of bacterial location and again acidosis, and this leads again to the continue of the vicious cycle. Negative pressure wound therapy (NPWT) protects the viscera, reduces the formation of adhesion between the bowel and the anterior peritoneum, actively drains toxins and bacteria-rich intraperitoneal fluid, removes exudates and collects and monitors fluid loss, prevents the loss of abdominal domain, encourages the approximation of facial edges towards the midline, causes no damage to skin or abdominal fascia, decreases abdominal compartment syndrome, and finally reduces morbidity and mortality. Here we can take a look of devices of negative pressure wound therapy, where we have this visceral protective layer, which is positioned in the abdominal, on the abdominal context in the abdominal cavity, where the sponge is covered by protective layer that the adhesions, and then over that we put a perforated foam positioned over the protective layer, and then drape and put the aspirating set positioned over the perforated foam before placing the aspiration on the plastic drape. We cut a hole 2 of 3 centimeters in the plastic drape to allow aspiration. Here again we can take the look of the aphthera, where we have the protective layer where it's placed in the abdomen and aspirates the fluid and helps to keep the facial edges as close as possible, so it has to overlap for 8 to 10 centimeters. We pull to the paracolligator, the right and the left. Over that we put the perforated foam layer, and then we put the tube and device to put the pressure in minus, usually in minus 125 millimeter of mercury. Have an aphthera, we can use a white foam to cover and protect the abdominal context and the bowel to protect it from a perforation, over which we place a second foam that must not contain silver. It should be a simple black foam, and then we put again the drapes and the aspiration system to have the negative pressure. Regarding the optimal technique, it seems that negative pressure wound therapy with continuous facial traction is suggested as the preferred technique for temporary abdominal closure. And temporary closure without negative pressure wound therapy, like a mesh alone or a Bogota bag, whenever possible, should not be applied for the purpose of temporary abdominal closure because of the low delayed facial closure rate and because it's accompanied by significant intestinal fistula. Temporary abdominal closure using negative pressure wound therapy can be useful to decrease the time to a definitive abdominal closure, but prolonged negative pressure wound therapy may increase the risk of enteric fistula. Regarding temporary abdominal closure, there are a 74 study with over 4,000 patients, of which percentage of almost 80% had peritonitis, and in 38 studies they included the negative pressure wound therapy. Regarding the delayed facial closure, the negative pressure wound therapy with facial traction was achieved in 73%. The negative pressure wound therapy with dynamic irritation sutures lead to almost the same 73% closure. In cases of mesh, the percentage was only 34.2%. In the cases of zipper, the percentage was only 34%. Here we can see one of our cases where we have put the protective layer at the visa, and then we have utilized the mesh, which is a temporarily mesh placement, to have facial traction, and in the next chains of the abdominal can cut the mesh, and here cut it, and then after the change of the protective layer, we can reapproximate the mesh and have the facial edges to get closer together without causing injury to the fascia itself, or we can if it's feasible to close the abdomen, we can remove the mesh and then close the abdomen. Here we can see another patient. As I said, we have cut the mesh, open the abdomen, change the protective layer, and then we have plicated the mesh in the middle with suture so as to approximate as much as possible the facial edges. And here it's even closer, the next change of the protective layers. We approximate it even closer the facial edge. We plicated more the mesh. We use not to cut the mesh, but just to plicate it, so in case we have an increased abdomen, or we have in the next change something that we can leave the abdomen a little bit more open, and in this patient in the next surgery we were able to close the abdomen. And here is the over the mesh we put the second foam, and then membranes, and the negative pressure device to have the negative pressure. Negative pressure wound therapy with a dynamic component, either mesh mediated facial traction or dynamic suture. We prefer the mesh mediated facial traction, gives the best result in terms of delayed facial closure. However, dynamic suture results more often in fistula. Negative pressure wound therapy without a dynamic component, Baker's wax or commercial product for the use of temporary facial closure has a moderate delayed facial closure rate and the fistula rate similar to mesh closure without negative pressure wound therapy. Negative pressure wound therapy on delayed facial closure and fistula rate. So the 10 prospective studies with negative pressure wound therapy with 600 patients. Delayed facial closure was able to achieve in over 50%, and in the atmospheric fistula was present almost 10%. In four prospective studies with negative pressure wound therapy with facial traction with 400 patients, the delayed facial closure rate increased to almost 80%, and the atmospheric fistula rate was decreased to 4%. In international register of open abdomen, in which I had the honor to participate. The main indication for abdomen, as we can see here, was peritonitis in almost half of the patients. And negative pressure wound therapy was utilized in most of the patients as a temporary abdominal closure. Males and females were almost the same percentage. Definite closure was higher than all other cases with a rate of 85%. Facial closure was 53%. Complication during the treatment was 33%, and was the lowest of all the complications of all the treatments. The fistula rate was a significant and was 14%. And it was higher than some other techniques, and the mortality during open abdomen was lower and was 30%. So, regarding the negative events in peritonitis with the complication negative pressure wound therapy had the lower percentage of negative events compared to Bogota bag and skin closure, compared to Baker vacuum pack, and compared to the Whitman pads. It had the lowest mortality also with 14% compared to the other techniques, but it had a significant fistula rate comparable to Bogota bag and greater than the Baker vacuum technique. Regarding the definite abdominal closure, we can see that the negative pressure wound therapy had the greater percentage of 85% of definitive abdominal closure. It's the greater compared with all other techniques. Negative pressure wound therapy with distillation. At the moment, there is a need for more evidence to support the fluid distillation, and no recommendation for its use in abdominal closure. An abdominal wound can be made at this time. In cases of ostomies, as we can see here in a patient of ours which had anastomotic dehiscence after TME. In this case, we had to perform an ostomy and try to place a negative pressure wound therapy device, and there is no need to make great changes. We have to cut the non-adherent fenestrative polyurethane viscera protective layer and braces sit around the bowel intraperitoneally. We have just to cut here and place one over the bowel and the other under the bowel from right and left over and under, and then place the occlusive dressing that protects the abdominal conduct from external contamination around the stomach. Place the ostomy bag over the dressing, and we can use standard pressures of minus 125 millimeters of mercury. In cases of anastomosis, there is need for more studies in order to study the effect of negative pressure wound therapy in the healing of intestinal anastomosis. There is need for more evidence in order to identify the ideal treatment of anastomosis with negative pressure wound therapy. And there is an experimental study about the breast strength of porcine intestinal anastomosis following negative pressure study. There were suture anastomosis performed and stable anastomosis performed. The anastomosis could be either in direct contact with a protective layer, or to be at a remote position, and also except of the contact with a protective layer, the negative pressure was off and on. The results of the study showed that in cases of a suture anastomosis, in a direct contact and a remote site with a negative pressure on and off, there was not significant difference between the breasting pressure in these cases. And in cases of stable anastomosis with either in direct contact and at a remote site with negative pressure off and on, there was no difference between this anastomosis also, but there was a significant difference between the basing pressure of the suture anastomosis and the stable one, with the suture anastomosis having a significantly greater breasting pressure. Also, in another studies from which we get indirect evidence about the effect of negative pressure wound therapy at the anastomosis, we see that in cases with a negative pressure wound therapy and the atmospheric fistula, there was not significant difference in the pressure of atmospheric fistula, either if there was an anastomosis or if there was not an anastomosis, showing that maybe the negative pressure wound therapy doesn't have a negative effect in the healing of the current practices is to close the bowel proximally and distally and defer the anastomosis for a second laparotomy after the removal of negative pressure wound therapy. The reduction of the negative pressure to as low as 25 mm of mercury to protect the anastomosis, still high enough to prevent lateralization of facial edges or to cover the anastomosic regions with omental fat to avoid direct. Here we can see that it's evident that even in a study of 2019, the majority of patients with acute diverticulitis have a Hartmann procedure and an ostomy form, and only a small percentage, less than 10%, underwent the primary anastomosis. So maybe it would be in the patient benefit to use damage control surgery in cases of diffuse peritonitis, as acute diverticulitis, and then to restore the bowel continuity, which in these cases it has been achieved to 70%, and only 30% has a Hartmann procedure with. And here's another study that shows that this is feasible, and we can have a colorectal anastomosis with the use of damage control surgery with negative pressure wound therapy in patients with a diffuse peritonitis for acute perforated acute diverticulitis. Also, we can see that in most cases the negative pressure wound therapy is cases of large bowel perforation, small bowel perforation, and anastomotic failure. It's the majority of cases of the utilization of negative pressure wound therapy for open abdomen. So, regarding the exploration before definite closure in critically ill and non-trauma patient with open abdomen, once any requirements for ongoing resuscitation have ameliorated, early operation with the intention of closing the abdomen should be given high priority. And in critically ill patients with open abdomen, the laparotomy with the concern of ongoing ischemia and contamination, their operation should be conducted no later than 25 of usually 48 hours after the index operation, with the duration from the index operation shortening with increasing degree. Regarding the definitive closure, fascia should be closed as soon as possible. Acidosis, hypothermia, and coagulopathy.
So that was a presentation by Dr. Orestes Inoris from Aristotle University of Thessaloniki, Greece. So next, moving on to audio presentation of Samantha Gare, Intensive Care Nurse, International SOS Australia.
Good morning, everybody. My name is Samantha Gear. I am an intensive care nurse living in Sydney, Australia. I am currently working for International SOS, and I just came back to Australia after living overseas for the last 4 years. I lived and worked in the United Arab Emirates, and I work for Cleveland Clinic as an intensive care nurse. Today we're going to be doing a presentation about giving your patients a fast hug to help reduce hospital stay. Our main focus for today will be ventilator-associated pneumonia, in short form VAP. You will see that throughout the rest of the presentation, ventilator-associated pneumonia will be referred to as VAP. The above picture highlights the pathophysiology behind VAP. However, we're going to go into more detail about this on the next few slides. VAP is a hospital pneumonia which occurs 48 hours or more after tracheal or mechanical ventilation. VAP occurs in 9 to 27% of intubated. What is pneumonia? Pneumonia is an inflammatory lung infection which causes the alveoli to fill with fluid or pus, resulting in hypoxia. There are various kinds of pneumonia, such as community-acquired, hospital-acquired, aspiration, and ventilator-associated. Bacterial infections are generally the most common form of pneumonia. However, viruses, including COVID-19, fungi, parasite, and chemical or physical injury to the lungs can also lead to pneumonia. The World Health Organization states that Streptococcus pneumoniae is. There is a vaccine for Streptococcus pneumoniae, but it's too expensive for many developing countries. Now we're going to have a look at this chest x-ray, and I'm no expert in reading chest x-rays. However, we're just going to go through some important factors from this image. Here we can see that the trachea is midline. However, the costophrenic angle on the right side is not well defined when compared with the left side. We can also see a poorly defined angle and some white on the X-ray. Now, this white generally indicates a pleural effusion or consolidation, which decreases gas exchange and ventilation, causing shortness of breath and fatigue. Fatigue generally occurs because the patient has to use more accessory muscles to try and achieve adequate ventilation. This type of pneumonia is classified as a right lower lobe pneumonia, and a follow-up X-ray must be done daily or earlier if clinically indicated to ensure treatment is effective. A diagnosis of the pathophysiology behind VAP. So, as we know, pneumonia is an umbrella term caused by a variety of organisms that result in infection in the lungs. The common agents that cause VAP are gram-negative bacilli, such as E. saturae, and gram-positive cocci, such as Staphylococcus aureus. It is really important to consider the impact VAP would have on the immunocompromised patient and those patients presenting with multiple comorbidities. The macrophages generally protect the lungs from foreign pathogens. And when a pathogen tries to enter the respiratory tract, the body has its own physical defense mechanism, such as mucociliary clearance, the cough reflex, and the ability to remove secretions. But when patients are intubated, this defense mechanism is removed. When this defense mechanism is removed, it causes and overwhelms the macrophages, causing a fibrin-rich exudate which fills the alveoli spaces, causing them to stick together, limiting gas exchange. This inflammatory response causes an increase in the production of neutrophils, which damages the lung tissue and leads to fibrosis and pulmonary edema, impairing lung expansion. And due to this inflammatory response, up to 40% of patients can develop pleural effusions. The primary route of infection into the lungs is microaspiration of organisms which have colonized in the oropharyngeal tract. Approximately 45% of healthy subjects aspirate during their sleep. The ETT and trach facilitates aspiration of oropharyngeal secretions and causes direct access of bacteria into the lungs, which can result in pneumonia. The comatose patient is also predisposed to developing pneumonia through direct contact with environmental reservoirs such as the respiratory devices and contaminated water. Disposable tubing used in the respiratory circuits are generally a closed system. However, contamination can still occur. Therefore, it is recommended to change these circuits frequently. Trach and ETT tubes may become contaminated during regular routine care, and there is also a higher risk of contamination during emergency intubation. Therefore, it is important that a sterile field is maintained. Some clinical features of patients with VAP are fever, tachypnea, increased or plurant secretions, crackles, reduced breath sounds, bronchospasm, reduced tidal volumes, and increased inspiratory pressure, also new and progressive infiltrate on the X-ray. Now, ironically, the biggest risk factor for developing VAP is mechanical ventilation. However, there are other risk factors, and they include the older population, reduced consciousness, chest surgery, re-intubation, prolonged intubation, paralysis, and immunocompromised patients. For prolonged intubation, it is recommended. So now we're going to cover the treatment for VAP, and that is the fast hug concept. So the fast hug concept was developed in 2005 by Professor Jean-Louis Vincent, who is a Belgian physician and a professor of intensive care medicine. Since his discovery in 2005, the fast hug has developed to include spontaneous breathing trial, bowel care, indwelling catheter removal, and de-escalation of antibiotics, also known as the fast hugs bit. However, for today's presentation, I will only be covering fast hug up to glucose control. The Fast Hugs bid highlights key areas that should be considered regularly by the entire team for each ICU patient during their entire ICU stay. So this concept can be used for any critically ill patient and must be used at least once a day during rounding and on change of shift. The aim of the concept is to involve the multidisciplinary team to ensure essential aspects of care are not forgotten. Feeding. So malnutrition increases complications, and many patients that present to the ICU are already malnourished. Patients require adequate nutritional support with daily review of feeding, and a dietitian can be involved to ensure that the patient's needs are met. Oral feeding cannot be possible in a comatose patient, therefore enteral feeding must be started within 24 to 48 hours. Feeding is to ensure that the body has enough nutrients for wound healing as well as enough nutrition to fight the disease process and to further reduce complications. Analgesia. A daily assessment must be conducted to ensure that the patient is comfortable and pain-free. Although a pain assessment might be hard to do with a comatose patient, it is essential to look at the patient's facial expressions as well as their vital signs to determine the patient's level of pain. It is particularly important to pay attention to the facial expressions and the vital signs when an invasive procedure is done or when turning the patient. It is also important to do this for sedation. Sedation needs to be assessed daily to ensure that the patient is having right amounts of sedation or whether or not the sedation medication can be stopped. Sometimes it is important to assess the RASS score to determine if the sedation medication needs to be changed. If a patient is scoring a +3 or a +4 on the RASS score, it is important to change the medication to ensure that the patient feels comfortable. There are no rules really on how much sedation to give and how often to give it. Titration is really based upon clinical judgment. Although it may be easier to have a calm and quiet patient, oversedation can cause harmful effects such as increased hospital stay and hypotension. Generally, a RASS score between a -2 to 0 is desirable for patient comfort and safety. Thromboprophylaxis. Mechanical or pharmacological prophylaxis is required to prevent further complications such as a DVT, furthermore a PE, furthermore a stroke. If prophylaxis is contraindicated, it really needs to be reviewed and documented on a daily basis. It is also important to review the patient's bloods on a daily basis, including their INR, clotting factors, kidney function, and liver function tests. Head of the bed. Generally, it is required to sit the patient up between 30 to 40 degrees in order to reduce aspiration of gastric contents. This is evidence-based practice and must be used unless contraindicated based on the patient's condition. Aspiration is a major mechanism for VAP, and some factors to minimize aspiration are elevating the head of the bed, minimizing sedation, draining subglottic secretions in ventilated patients, maintaining endotracheal tube airway cuff pressure between 20 to 30 centimeters, and application of positive end expiratory pressure. The American Thoracic Society and Center for Diseases Control and Prevention have recommended the semi-recumbent position in order to reduce aspiration and prevent VAP. Ulcer prophylaxis. Stress ulcers are quite common in the ICU as gastric pH levels change due to antibiotic treatment and just in general the patient's illness. Stress ulcer prevention reduces the risk of gastric hemorrhages and further complicating the patient's treatment. There has been limited study to indicate which choice of prophylaxis is best. However, a proton pump inhibitor, also called a PPI, is commonly used. There have been some studies, however, which indicate that a PPI can increase the risk of infection. However, the data on that is still limited. Glucose control. It is really important to maintain tight glucose control in the intensive care unit, as hyperglycemia and hypoglycemia can have drastic effects on our patients. Hypoglycemia is generally associated with increased mortality, and for certain types of patients, it can worsen their prognosis. These types of patients are those who present with a myocardial infarct, stroke, and sepsis. Stress hypoglycemia. That concludes our fast hug concept. There have been many studies done worldwide which indicate that VAP prevention bundles are effective on reducing mortality and the development of VAP. A study conducted by Papademos in 2008 found that by introducing the fast hug concept, this decreased ventilator days from 19.3 to 7.3, which further decreased the cost to the hospital, decreased mortality rates, and length of stay. That concludes our presentation for today. I would like to thank you all for your attention, and I hope that you enjoyed this presentation. Just a quick reminder, next time, whenever in doubt, just give your patients a fast hug to ensure that they have adequate treatment. Thank you all so much. Have a wonderful day.
Next presentation is by Data Key Vancy, Indiana State University School of Nursing from USA.
Good morning. My name is Dr. Deetta Vance. Thank you for having me today. Today we're going to be talking about a case study regarding anorexia in adolescents. We'll start today with just a brief overview of eating disorders. Eating disorders are a severe disturbance in eating behaviors as well as emotional responses and thoughts resulting in unhealthy weight loss or gain. It can also be associated with overeating, so not just undereating or restricting. Types of eating disorders are anorexia, bulimia, and binge eating, among others. Anorexia is restricting caloric intake, bulimia is purging, binge eating is excessively overeating with or without purging. It has been associated with bullying in schools or in other social situations, body image disturbance, genetic predisposition, and other mental illness, including anxiety, depression, and OCD, which is obsessive compulsive disorder. Eating disorders are a mental illness and are a serious threat to health and life. They can impact anyone, no matter age, race, size, gender, identity, sexual orientation, or background. Eating disorders can present in a variety of ways, but there are some common signs of eating disorders, including alterations in weight, which is a gain or a loss, preoccupation with body image. They call this body checking, looking in the mirror, touching your body, smoothing your clothes, that sort of thing. disruption in eating patterns, preoccupation with nutritional content changes and exercise patterns, mood fluctuations, use of laxatives, diuretics, or diet pills, and involvement on various social media platforms and groups that support disordered eating behaviors. Statistics surrounding eating disorders, any type, are quite alarming. According to the National Association of Anorexia Nervosa and Associated Disorders, eating disorders affect at least 9% of the population worldwide. 9% of the US population, or 28.8 million Americans, will have an eating disorder in their lifetime. That's not just adolescents, that's everyone, but 9% is still a pretty high number. Less than 6% of people with eating disorders are medically diagnosed as underweight. So that is also significant because eating disorders do not always fit the patient looking extremely malnourished or even emaciated. 28 to 74% of risk for eating disorders is through genetic heritability. Eating disorders are among the deadliest mental illnesses, second only to opioid overdose. Young people between the ages of 15 and 24 with anorexia have 10 times the risk of dying compared to their same-aged peers. Males represent 25% of individuals with anorexia nervosa, and they are at a higher risk of dying, in part because they are often diagnosed later since many people assume males don't have eating disorders. So oftentimes we do view some sort of eating disorder as more prevalent in females. However, males are also at high risk. 10,200 deaths each year are the direct result of an eating disorder. That's one death every 52 minutes. About 26% of people with eating disorders attempt suicide. As I said previously, the occurrence of an eating disorder is oftentimes associated with other mental illness. And the economic cost of eating disorders is $64.7 billion each year. So what does this mean for providers? We are responsible for recognizing signs and symptoms of eating disorders, ensuring access to appropriate screening tools, and access to referral resources for treatment. Awareness of the signs and symptoms of eating disorders could lead to appropriate diagnosis and life-saving treatment. Obsessive compulsive presentation of patient related to weight, food, exercise, time, or other fixations on certain thoughts are all very key indicators that we need to take a further look into the situation. Timely screening and a thorough evaluation and referral is imperative to get that patient to treatment as soon as possible. Supporting the patient. So earlier I did give some broad statistics regarding eating disorders that affected everyone regardless of age. However, regarding children and adolescents, 42% of first to third grade girls want to be thinner. 81% of 10-year-old children are afraid of being fat. 46% of 9 to 11-year-olds are sometimes or very often on diets. 35 to 57% of adolescent girls engage in crash dieting, fasting, self-induced vomiting, diet pills, or laxatives. In a college campus survey, 91% of the women admitted to controlling their weight through dieting. So given those statistics, which are honestly very concerning, I wanted to move on through a case study regarding a 17-year-old female who was diagnosed with anorexia but also had anxiety and depression. So this was a 17-year-old female who presented to the emergency department with complaints of severe anxiety and chest pain. She came in with her mom. She's homosexual with a history of anxiety and depression, as well as suicidal ideation, and presented with symptoms of panic attack. The mother reported that the patient has lost about 60 pounds in the last 9 months. She also said that this is the 7th time that she had been brought into the emergency department for evaluation and has been unable to access other means of care. The mother has concerns that the patient is restricting food and has continued to lose weight despite support at home and diet supplements, such as Ensure and that sort of thing. Mother reported that the daughter first admitted 3 months ago that she had been pacing in her room at night, walking 20 to 25,000 steps, as well as restricting calorie intake to approximately 200 calories a day that she would mostly purge. The mother appeared very frustrated that she could not find anyone to help her or believe that her child was in danger. She reported that the patient has resorted to cutting and has had suicidal ideation in the past, but currently patient was denying having any suicidal ideation or a plan for self-harm. The patient did admit that she knows she has a problem, but she cannot seem to help herself and has hidden her behavior from her parents and other family members as well as friends. The patient reported always being cold, 3 to 5 panic attacks daily, insomnia, near syncopal episodes, vision disturbances, severe headaches, occasional chest pain, dizziness, lack of menses for the past 9 months, occasional suicidal ideation, self-harm, and obsessive thoughts regarding food, exercise, and body image. The mother did report expressing her concerns to the pediatrician several times, however felt that her concerns were not taken seriously. So in speaking to other parents of children who have eating disorders, this is a pretty common presentation. Patient goes to the emergency room because there has been no attention or full screenings completed, maybe because the patient presentation didn't really seem like an emergency. But this is not an uncommon presentation of these children when they come into the ER. So next I want to discuss pertinent exam findings and initial test results. So if you look at the vital signs, her pulse was extremely low at 38, blood pressure was low, 88/42. She was 5'4" and weighed approximately 105 pounds. However, it was concerning that the mother is saying that she had lost a significant amount of weight, about 60 pounds in the last 9 months. Patient appears emaciated, anxious with an inability to sit still, and in seemingly acute distress. Heart rate was bradycardic and occasionally irregular. She had healed horizontal scars averaging about 2 to 3 inches in length, noted to bilateral anterior aspects of forearms. Otherwise, exam was benign. The CBC, the CMP, magnesium, phos, and urinalysis were all normal. And on EKG, there were occasional PVCs noted, however, otherwise normal. So apart from her bradycardia and low blood pressure, and clearly having some sort of panic attack, the labs did not support any sort of real emergency, even though as a provider, I would say that a pulse that low would be extremely concerning. So now I want to talk about what happened next. This is typically something that does happen to these patients when they present to the ER. So the emergency provider recommended evaluation by psych. The patient waited with parents for approximately 13 hours for evaluation by psych. However, there was no psych consult or personnel available to be completed. She received 2 liters of lactated ringers while in the ED. Labs were not rechecked. Vital signs improved at heart rate of 58, blood pressure of 96/56, repeat EKG was normal. Based on denial of suicidal ideation, normal labs, and EKG, the emergency provider recommended discharge of patient to home despite abnormal vital signs and mother's concerns with extreme weight loss and mood disturbances on presentation, as well as not having a psych consult. The mother at that point became very frustrated and demanded referral to consult with an eating disorder specialist. After 2 hours, she received a list of numbers to call, making a statement that she had already called most of them, and she left the emergency room with her daughter. So when you think about what actually happened, and we know that in the emergency room, it's very busy there. However, these patients are going undetected, and sending this patient home obviously put her at higher risk for further deterioration, suicide, self-harm, all sorts of poor outcomes. So we should really pay attention to how could we have handled the situation differently. So there are screening tools that you can do. Obviously, we all know about the PHQ-9, but there's also an eating disorder diagnostic scale. Screening is easily available online. I've put the link here for you to access. The SCOFF questionnaire, which is, do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone or 14 pounds in a 13-month period or in 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? So those are questions. That's the SCOFF questionnaire that you can ask and document in the chart to kind of further explore where the patient is currently. So despite normal labs and EKG, vital signs were concerning. The patient's reports of calorie restricting and exercising, as well as the mother's reports of rapid weight loss and mood disturbances. The concerns were not acknowledged or taken seriously. It's the provider's job to seek to understand the entire clinical picture of the patient, ranging from a possibility of an eating disorder to child abuse neglect. Admission for observation and further testing was definitely warranted, either to the hospital or to psych, or at the very least should have had a psych consult. Active provision of referral of the patient to an eating disorder specialist. And then also we should be looking to support and acknowledge both the mother's and the patient's concerns. So for this particular patient, once home and afterwards, the mother was able to secure an evaluation by an eating disorder specialist. Appointment was scheduled 1 month from date of discharge from the emergency department with no support or resources during that time period. Following evaluation, patient was admitted to residential care for eating disorder treatment for 4 months, leading to absence from school. Disruption of the family unit, including other children in the household related to caring for the patient, because there's so much energy and focus on the eating disorder for meal planning, travel time commitments, and appointments back and forth to the eating disorder facility. There were therapies offered to the parents, joint therapies with parent and patients that needed to be completed. However, both parents also worked full-time, so this is not an uncommon situation. And then also lack of understanding of disruption of normal household activities. There's definitely a need for therapy, but this goes unrecognized and unsupported for family members to help cope with familial functioning changes during treatment and once the patient is in recovery also. So once the patient's discharged, it just seems the family is supposed to just know what to do or not have their feelings and concerns addressed, so they become at higher risk for depression and anxiety, and then, over-focused on the child and the eating disorder. So in summary, I just wanted to give some key points. It's important that we understand that eating disorders are a mental illness that can be life-threatening and take steps to gain competence on recognizing signs and symptoms of a serious concern. Fully evaluate any concerns when an eating disorder is suspected, including the use of screening tools. I think it's also very, very important that we as providers understand that presentation of a patient with an eating disorder may not be obvious, including lack of appearance of obvious weight loss and normal test results, even normal vital signs, even though this particular patient we discussed did not have or had abnormal vital signs, that is not always the case. I think it's also very important to make sure that we're reviewing history. This patient had been in the ER 7 times, but there was no discussion of previous weights. And the mother's claims that the patient had lost so much weight in the interim was not really addressed either. Then also proactively gain access to referrals for treatment and provide to family and patient. And then also very important to offer support to not only the patient, but the family as well. This may include therapy recommendations, evaluation management of any mental illness of family, both pharmacological and non-pharmacological. Thank you.
So that was a presentation by Dita Key Vancy. So it was a nice presentation. Thank you, Dr. Dita. Next, audio presentation by Emine Il Kasau, Faculty of Medicine and Pharmacy, University Qadi Ayat from Morocco.
Ladies and gentlemen, thank you for giving me this chance to be with you in this second Global Summit of Pediatrics and Neonatology. First of all, I would like to thank all the organization committee for letting me share with you this whole experience about some pathologies, and first one is the congenital coxavara in children, which is primary deformity of the hip that dates from epidemiology, from embryonic period. Coxavara is not really a disease; it's a symptom of a defect of enchondral ossification of the medial part of the femoral neck. Cervicodiaphyseal angle is less or equal to 110 degrees, and the symptomatology is often poor, and that's what make the diagnosis difficult and delighted. So the indication of surgical treatment or not is still not well codified, and that is the reason for our study to see all the phases of indications of surgical treatment. So this is a retrospective study of about 13 children and 18 hips, which was managed in the Department of Pediatric Orthopedic and Traumatology in University Hospital of Marrakesh in Morocco. The study was over 12 years, from January 2009 and December 2021, and the follow-up, the minimum follow-up of our patients was 1 year. Uh, the clinical evaluation of patients was considered according to presence or not of pain, lameness, Trendelenburg sign, hip joint amplitudes, and leg length discrepancy. We have three groups of evaluation after surgery: normal group or good group, moderate, and limited. The movement of the hip is the base to evaluate patients. So when patients have flexion superior to 100 degree and extension normal at 0 degrees and abduction at superior at to 30 degrees, we consider that the patient is normal or have good results. The patient is considered with moderate results when flexion of hip is between 80 and 100 degrees, when extension is incomplete and abduction is between 15 degrees and 30 degrees. Limited or poor results for patients with a flexion less than 80 degrees, incomplete extension, and abduction less than 50 degrees. So the HEA angle was the angle between Herlinger's line and another line drawn through the proximal physis. No, this is the Herlinger's line between the Y cartilage, and the second line is drawn through the physis of femoral head. In the normal cases, this angle should be at 25 degrees. We consider that the patients have coxavara when this angle is superior to 60 degrees. The second angle to calculate is the NSA angle. This angle between the neck and the neck axis and the shaft axis, it should be normal when it is at 130 degrees. So patients after surgery will be evaluated according to radiological evaluation according to Catton and Muslard. Patients with So about treatment, the aim was to correct the cervicodiaphyseal angle and restore near normal hip joints biomechanics and physiology. For that, we had the choice between orthopedics methods like motor rehabilitation or surgery, and also surgical methods like the proximal femoral valgus osteotomy. This one could be anter-trochanteric or subtrochanteric. Some associated gestures are more often necessaries, like an epiphysiodesis of greater trochanter, as we see in the first image here. The osteotomy used is an anter-trochanteric osteotomy. Here is the greater trochanter and here is the lower trochanter, and the osteotomy is between the two. We make the osteotomy to have valgization, and here you see that we could have the correction of the angle, but in this one the osteotomy is anter-trochanteric. The second one, or the second type of osteotomy or valgus osteotomy, is this one. This is the subtrochanteric osteotomy. As you see, here is the greater trochanter, the lower trochanter, and here is the osteotomy with a triangle of sustraction. After excision of this triangle, we could have the correction of the valgus. So after that, we could even use a screwed plate to stabilize the osteotomy and the reduction. So in the third image here, we see the fixation with an anterior or a front plate screwed as described by Trousseau. More often we use this type of plate. It's a DCP plate that we use to fix this osteotomy in the front side of the neck and the shaft. We could also use the same plate, but in the external side here with screws that go in the neck and other ones that goes in the diaphyseal. We could also use this one. This is an LCP plate which is used at the external side of the femur, and it gives a good result and a good fixation. Indication for surgery, or in general to do surgery or not, are at the first time the functional prejudice, which means that when patients have serious problem of lameness and Trendelenburg sign and also pain. About the radiological evaluation, patients with an NSA angle superior to 110 degrees and should have clinical and radiological surveillance if no clinical worsening. When the NSA angle is less or equal to 110 degrees, formal surgical indication is here, and it should be done as soon as the diagnosis is made, preferably at a young age. Another criteria to do surgery or not is the HEA angle. this one, when it is superior to 60 degrees, here also the surgical indication is formal. So now let's move to see the results of our series. We start first by some epidemiological data as it is showed in this diagram that shows that boys are more often dominating and more often having this pathology and in our cases we have boys in 62% of the groups of ages were separated in 4 groups and refined the group between and we find the group between 3 and 5 years with 5 patients. The group between 5 and 8 years represent 4 cases. The group between 8 and 11 years with 1 case, and the last group between 11 and 40 years, which is often a developmental coxavara and represent 3 cases. So in this table we will see and expose symptoms and clinical examination finding in our series. So we see that lumpiness was present in all patients. Bilateral coxavara was found in 61% of cases, and we note that 70% of cases had limitation of movement, especially the abduction. Some associated malformation were noted also, like bilateral genivalgum, cubitus varus, and homolateral dislocation of the hip. The radiological evaluation before surgery shows in the X-ray examination that 16 hips had an HEA angle superior to 60 degrees and 70 patients had an NSA angle less than 110 degrees, so surgical indication was formal for 16 hips. The surgical technique used for our patients was subtrochanteric osteotomy with fixation with DCP plates according to Trousseau technique in 44% of cases, intertrochanteric osteotomy with fixation with DCP plates in 25% of cases, and subtrochanteric osteotomy with LCP plate fixation in 31% of cases. Some associated surgical procedures were necessary for some patients, and we used epiphysiodesis of greater trochanter, like we see here, with 1 screw oblique in 1 patient. Adductors tenotomy in 56% of cases. The lengthening of the lower limb is planned in patients with femoral hypoplasia, and all patients underwent a rehabilitation to achieve the best possible mobility. So, the evaluation of postoperative results showed that in our patient we had 63% of cases with excellent results, as we see here, 25% of excellent results and 38% of cases of good results. However, 37% of cases had moderate or poor results. So let's analyze these good results. Good results according to age groups. When we analyze our results according to the age groups, we find that for groups aged from 3 to 5 years, we had about 86% of good cases. That is a good number. The second group with good results was the group between 11 and 40 degrees. And here we have 2 out of 3 patients with good results, 66% of cases with good results. However, patients between 5 to 10 years had only 1 out of 3 patients with good results. So here also we have analyzed our results according to the used plates, and we see that we had 4 LCP plates. For LCP plates, we have 78% of good cases with good results. However, in the DCP plate, when it is used, we have more than half of patients with moderate and poor results. That showed that maybe the plates used have also an application for the final results of surgery. About the complications, we note that in our series we had 2 cases of recurrence of coxavara after surgery. 3 patients had femoral head necrosis, 1 case of displacement of osteosynthesis material, and 1 case of pseudarthrosis of the osteotomy site. In the analyzing of these results and complication also, we note that 60% of cases, which mean 3 cases having an antertrochanteric valgus osteotomy, progressed to necrosis of femoral head. That's why we say that this osteotomy exposed to femoral necrosis. The pseudarthrosis of osteotomy site have been noted in 1 case, and this one was bone grafted 6 months later. In this photo, we expose the case of a patient in the left photo, a patient with a displacement of the osteosynthesis material. that was surgically revised for material resting and bone grafting after that in a second time. The second image at the right is for a case of femoral head necrosis, as we see here, femoral head necrosis after surgery, and here we expose the image after material removal. In this slide, we expose the case of an 8-year-old boy. In the first X-ray that show an coxavara with an NSA and HEA angle at the first consultation, respectively, at 105 degrees and 65 degrees. The second image here shows the immediate post-operative X-ray, and we have used an LCP plate after subtrochanteric osteotomy, valgus osteotomy. We see that the valuation of NSA angle is about 120 degrees. In the third image, here it is after 37 months of follow-up with a very good result. As you see, we have a patient which was classed according to the Catton and Mouchard classification with an NSA angle of 132 degrees, which is very good. So, for discussion, after reviewing the literature and as in the study underwent by David and al., we found that a recurrence and failure of surgery is not really related to the age of surgery. According to postoperative HEA factor, the postoperative HEA factor but the HEA factor, the HEA angle is the crucial factor or element in the prevention of recurrences. The recommendation are to have an HEA angle on postoperative less than 40 degrees. The risk of recurrence is very high and significant risk of necrosis of the femoral head in cases of antertrochanteric proximal femoral valgization osteotomy. In another study underwent by Hani and all, the recurrence of coxavara was noted to the using a DCP plate, while the LCP plate improved better results. However, another study of the team of the Hospital University of Fez in Morocco shows that when we use a DCP plate fixed in the front side of the femur after subtrochanteric valgus osteotomy, the results are good. So, to conclude, The diagnosis of coxavara is based on anterior-posterior pelvic radiographs that shows closure of the neck shaft angle. When it is less than 120 degrees and verticalization of the cervical cephalic growth plate with an HEA angle superior to 16 degrees. The treatment of coxavara is often surgical, but still not yet well codified. The best therapeutic results being obtained on deformities on an initial NSA angle at superior to 90 degrees, and when we use an LCP plate and a subtrochanteric osteotomy with an HEA postoperative angle equal or less than 40 degrees. And thank you for your attention.
Thank you, Dr. Emine Il Kasau from Morocco. So moving on to your next presentation by Najab Abala, University Khari Ayat from Morocco. Dr. Najab? Are you going to give presentation? Dr. Najab Abala? Shall we share your PPT?
I think you have my presentation. You already have my presentation and the recording associated with the recording.
Okay. We'll play it.
Thank you.
Dr. Najab, sorry to inform you that you have sent your PPT is unable to open.
I'm joining you by my phone, so I don't have the presentation. If you can pass my presentation, I will present if you want.
Sir, I didn't get you, ma'am. Can you repeat it?
I'm joining you by my phone. I participate with my phone, so I don't have my presentation.
Okay. So whatever the next talk is, content is not there in it. Whatever you have sent it's getting repaired.
I didn't catch you.
Whatever the PPT you have sent to us, it is not showing any content. Whatever the next PPT you have sent to us with title, a rare emergency testicular torsion in undescent testes.
You want me to resend it?
No, we are unable to see the content in those PPT. So shall we move on to our next talk?
Okay.
Okay, fine. So moving on, our next talk by Eman El Kasau from Morocco. It's an audio presentation.
Okay, thank you. Ladies and gentlemen, thank you for letting me sharing with you our work about osteotomies and treatment of this developmental dysplasia of the hip in children. To start, we should remember that DDH is still a real public health problem in our country. Prevention in the strict sense of the term is impossible for this truly congenital pathology. In our context, screening efforts remain insufficient. Consequently, late diagnosis beyond the age of walking remains frequent, which implies a significant recourse to aggressive surgical treatment with non-negligible complications. We choose as late age criterion any child over 3 years old in whom no possibility of orthopedic treatment is indicated. So, patient with malformation syndrome or presenting a cerebral palsy were eliminated from the study. This study is a retrospective one about 77 patients and 100 hips that was managed in the Department of Pediatric Surgery, Pediatric Orthopedic Surgery in the University Hospital Mohammed VI in Marrakesh, Morocco. It's a work over 11 years from January 2009 and December 2090. The patient's age was superior or equal to 3 years, and the average follow-up was 1 year and a half. To evaluate our results clinically, we have used the Mackay score as described in this table. This score is based on clinical examination that should search stability and mobility of the hip, the presence or not of pain and lameness, and the Trendelenburg sign. So we have classed our results to excellent, good, moderate, or poor. So let's move to our results. As we see here, the average age of our cases was 6 years, with extremes ranging from 3 years to 13 years. We divided the cases into 4 groups. The first one is between 3 and 5 years, and where we have 40 patients. The second one is patients between 6 and 8 years. The third one between 9 and 10 years, and the last group with patients aged over 10 years. 40 cases were about sex. Girls were by far the most represented, which was found in 85% of cases. In this table, apart from the female sex, the other risk factors found in our series are gathered in this following table, and we see that primary first child was about 42% of cases, and breech presentation was found in 24% of patients. Macrosomia was noted in 5%, and familial history of developmental dysplasia of the hip in 3% of cases. 3 cases of associated there was 7 cases of associated malformation. However, no twin pregnancy was found. About clinical finding, in our series, equilibration lameness was the reason for consultation in all our children. Regarding the affected side, DDH was unilateral in 70% of cases, and bilateral in 30% of cases. Our study concerns children diagnosed late, that is to say, after 3 years. Therefore, we were led to look for indirect but suggestive signs of DDH. Here we see some of these signs. We have the limitation of hip abduction, which was found in 91% of cases, as we see here, with a retraction of adductors. The classic sign in 63% of cases. The Galeazzi sign in 66% of cases, which is the signification of an lamb inequality of length due to the ascension of the proximal part of the femur. The last sign is the lumbar epilodosis in 26% of cases, as we see in this photo. Our preoperative radiological results showed that 74% of cases were classified as tonus stage 4, and 20% of cases was classed as tonus 3. Just 6% was tonus 1. The image here in the right side is an anterior-posterior X-ray showing a tonus 4 left DDH in an 8 years old girl with acetabular dysplasia that was moderate to severe in all patients classed 3 or over to according to several class. So here about the surgical treatment. The surgical treatment is a heavy treatment and requires a team well trained. Several operating times can be performed depending on the age of the child, the stage of dislocation, and associated dysplasia. Here in the right side we see the installation of the patients in dorsolateral decubitus, and we use almost an anterolateral approach according to Bikini. In our series, 22% of patients of hips had an isolated capsulorrhaphy, and 28% had saltar osteotomy. 30% of cases had saltar osteotomy associated to femoral osteotomy, and in 6% of cases of hips underwent isolated femoral osteotomy that was even derotation or varization. And we performed also in 40% of cases of the hips a triple pelvic osteotomy associated to a femoral osteotomy that was a shortening osteotomy. Here we see some complication of surgical treatment that we have noted in our series. These complications were not negligible, and we had 2 cases of infection in pins of the saltar osteotomy, 10 cases of residual dysplasia, 3 cases of dislocation recurrence, and we had also 2 femur fracture within the 15 days following removal of the femoral osteotomy plate. 2 cases of coxavara, and stiffness was found in 6 cases. In 75 cases, no complication were noted. Here in this table we see some the secondary surgery needed by some patients, and it was necessary for 13 hips of our series. The reasons for second surgery were delayed and the treatment or saved are detailed in as followed in this table. So we have two cases of that where we had isolated capsulorrhaphy, two cases of capsulorrhaphy plus Salter osteotomy, two cases of capsulorrhaphy of and derotation, femoral osteotomy and shortening, four cases of classic, and three cases of triple pelvic osteotomy associated to derotation, femoral osteotomy and shortening. Postoperative results were generally satisfactory and clinically according to the Mackay score. We noted that 78% of cases had excellent or good results. However, we noted in 20% of cases that patients had lower limb length inequality that was noted, and it was sended out to superior or equal to 2 centimeter in 10 cases and less than 2 centimeter in the 10 other cases. So in this table we have radiography results according to Severin score. We reported 78% of good results. In total evaluation, according to the clinical and radiological results, we had 78% of excellent and good cases versus 22% of middle or poor results. So we have do an analysis of our results. First of all, we have analyzed our results according to age groups, and we distinguish that the age of our patients, our patient played a determining role of the quality of the results, as in this table showing from the age of 8 years, the rate of poor clinical results become higher, and radiological results as well as the rate of osteochondritis and failure that increases up to 50% of cases as we see here. So surgical techniques used, we noted that with regard to the type of treatment, the association of pelvic and femoral osteotomy, particularly in the classic technique, has proven its effectiveness with a rate of poor clinical and radiological results not exceeding 30% of cases, 13% of cases, and an osteochondritis rate at only 3% of cases. Here, the radiological study includes the standard X-ray with its two tones and severing classification. We can realize also arthrography, which is rather measures of controlling the treatment in certain difficult cases, but we noted as confirmed in this article by Ahmed Kursad and all that CT scan of the pelvis was also believed that perioperative CT scan has a very significant impact on the choice of the type of surgery, and it is systematically recommended in order to have a more precise idea of the dysplasia and to orient towards the best surgical technique. Some article also recommends that MRI allows early detection of possible epiphyseal necrosis. So for MRI, the lack of marketing authorization for this technique and the cumbersome nature of its implementation make this practice still unfeasible for us. The age of the child at the time of the surgery is very important in the final results obtained. A few authors have suggested that operative treatment in neglected cases over 10 years is not recommended or even dangerous, such as Ryan and al. And Zemir and al. A number of authors have accepted the surgical option but have suggested that the results worsen with age, such as Galpin here in USA that have finished the age of surgery at 13. So in our series, the age limit of our surgical treated patients was 13 years. However, the rate of poor clinical results and the radiological results in our series between the age of 10 to 13 years was very worrying and reached a failure rate of 50% of cases, which oblige us to recommend the age limit of the up to 10 years for the risk of serious and irreversible complication. So here we propose through this work some recommendations, and we can say that in front of DDH in child over 3 years, with a congruent hip, we recommend to realize a systematic pelvic CT scan. So in case of anterolateral dysplasia in children between 3 and 7 years, we recommend to the choice of Salter osteotomy associated to femoral shortening osteotomy and in the case of posterior dysplasia in children with the same age, we recommend the Duga or Pemberton osteotomy associated with the shortening osteotomy of the femur as the technique of choice. In children between 8 to 10 years with a wide acetabulum and anterior dysplasia, we recommend a Pemberton osteotomy associated with a shortening osteotomy of the femur in the first intention. In case of severe dysplasia, a triple pelvic osteotomy is recommended associated to femoral shortening osteotomy. In the case of non-congruent hip, the technique of choice is the shelf technique in children between 8 and 10 years, and for patients that have exhausted their growth potential, the Chiari osteotomy is recommended. So to conclude, we can say that developmental dysplasia of the hip is still a public health problem in our country. It's due to lack of screening, and we can see through this work that advanced age is the equivalent of significant complications. Isolated capsulorrhaphy is the source of residual subluxation, so the best option is an early detection and treatment that should be well chosen to have best results and less complications. And thank you.
Thank you, Inovine, for your valuable presentation. So moving on to our next presentation by Dr. Kelly Bogle Glee Manchingha, Sefako, Magato Health Sciences University, South Africa. Yes, Doctor, go ahead with your presentation.
Good day.
Yes.
Good day, everyone. Is my presentation visible enough?
Yes, yes.
Thank you very much for the opportunity. My name is Kelebogile Manjinja from South Africa, Rustenburg, Northwest. I studied with the Sefako Makato Health Sciences University. Currently, I'm working as a nurse educator at the Gauteng College of Nursing, SG Lawrence campus. Thank you again for the opportunity for my presentation from my study of my master's degree, as I'm currently studying towards my PhD in nursing. The title of today's topic is Implementation of Perinatal Problem Identification Program Requires Institutional Support. The introduction and background of the study stands as follows. The Perinatal Problem Identification Program is a simple, a user-friendly computer-based program that is used in South Africa to capture perinatal data. The program was designed and developed in South Africa in one of the universities as a facility tool for perinatal deaths, and it provided a remarkable change in the reproduction of perinatal mortality of facilities that care for seeking units. The information obtained from the program or the PPIP data provides a reliable picture of perinatal care in South Africa to the healthcare worker, to areas that needs to be improved, hence the institutional support to professional nurses and midwives is imperative for an effective implementation. PPIP is more than just a data collection tool in identification of avoidable factors such as hospital-related personnel and maternal and child care, but it has brought change as a tool for quality of care and best practices. As we continue with the introduction, the appropriate implementation of practice solutions emanating from the PPIP program in South Africa is crucial for the improvement of quality of care, but to allow professional nurses to take ownership of the implementation process, as well as to achieve the Sustainable Development Goal number 3, target 3.1 and 3.2 by 2030. In this situation, implementation of PPIP requires institutional support for its optimal implementation. Our research objective on our study was to explore and describe the perceptions of professional nurses and midwives regarding the implementation of perinatal problem identification program. For the success of the program use in the neonatal wards of the hospital that was under study. The research question, our primary research question was, what are the perceptions of midwives and professional nurses working in the neonatal wards of the hospital in the Bojanala district, Northwest Province, regarding the implementation of PPIP. My apology. So the following question came from the interview instrument, which was what can be done for professional nurses and midwives. So the research design and methodology that was followed was a qualitative, exploratory, descriptive, and contextual design that was adopted to enable the research to explore and describe the in-depth perception of professional nurses regarding the PPIP in the neonatal wards. The study setting occurred in the neonatal wards of the hospital in Bojanala district of Northwest Province in South Africa, and the hospital was chosen for the services provided to seeking units. A purpose of sampling method was used to select professional nurses and midwives working in the neonatal wards and who met the criteria for the study. For inclusion and exclusion criteria, the study included professional nurses who have 3 years or more experience working in the neonatal wards to share the in-depth perceptions of implementation of PPIP, and excludes professional nurses who are not working in the neonatal wards, for example, professional nurses and midwives working in maternity. 3 focus group interviews were conducted using interview guide, audio recording. Interview guide was pre-tested with 1 focus group interview. Trustworthy and ethical considerations were maintained throughout the study. Research findings: lack of institutional support, which is our main theme or our main finding, with the sub-themes: the absence of person dedicated to coordinate the implementation of PPIP, with the absence of a person dedicated to coordinate the implementation process. we felt that because there is no somebody responsible to implement this process, to guide the professional nurses and midwives regarding the implementation of this program. Hence, there is lack of implementation. But if the institution would give support to professional nurses by providing a champion that will lead and dedicate themselves to coordinate the implementation of PPIP, then its implementation would be a success. Due to lack of PPIP capacity and skills development program, some of the participants indicated that because of shortage of staff or shortage of professional nurses and midwives working in the neonatal wards, it is impossible for them to attend the review mortality meetings, neonatal mortality meetings, where causes of death are identified and identified as avoidable factors, whether personnel related or institutional related, etc. But because of the shortage of staff, they do not get the opportunity to go and attend these review meetings, because at these review meetings, there's also training taking place on how to improve the care that is provided to these sick neonates, to improve the quality of care, to improve the better practices of nursing in the neonatal wards. Benefits of attending mortality meeting is that whenever they get a chance, of which there is no chance due to shortage of staff, shortage of professional nurses and midwives in the neonatal wards, it is impossible for them to attend these meetings. Therefore, they do not receive training, appropriate training. Some of them, they are still using the outdated training that they have used at their training, but the updated workshops and conferences, because the institutional support, the institution do not support them, they are unable to attend conferences, symposiums that relate to neonatal care and that relate to sick neonates. The recommendations from our findings are as follows. Because the study highlighted the need for appointment of PPIP coordinator to champion the implementation and PPIP solutions. Therefore, the recommendation have been made out of the emanating themes of findings that were part of the study. A schedule regular updating sessions to invest on the knowledge and understanding of the professional nurses regarding implementation and implementing the solutions of PPIP and its sustainability. Establish a continued training and development program related to PPIP implementation to improve support regarding the attendance of neonatal care related to conferences that relates to neonates for professional nurses. Those are some of the recommendations made from the study. The findings, as we conclude our presentation, the findings from the reflection of the study regarding the implementation of PPIP in the neonatal wards provided to neonates highlight on the support required for professional nurses to acquire knowledge and of importance of PPIP. These challenges emphasizes the importance of institutional support to professional nurses to improve the best practice of care. Therefore, appropriate implementation of practice solution emanating from the study of the PPIP in South Africa is crucial, not only to improve quality care, but to allow professional nurses and midwives to take ownership of the implementation process. If they do not take ownership of the implementation processes, we are not going to achieve the Sustainable Development Goal Target 3 Sustainable Development Goal 3, Target 3.1 and 3.2 by 2030, of which is part of our responsibility to ensure that we reduce neonatal mortality in our country as well as worldwide. So therefore, we need institutional support in order to take ownership of the implementation process. That is my presentation. If there's any questions, you're more than welcome to engage. Thank you very much.
So thank you for your presentation, ma'am.
Thank you very much.
Okay, if you have any questions, you can ask us or chat in a chat box. Okay, thank you for your presentation, ma'am.
Thank you very much.
Okay, okay.
And thank you for the opportunity.
Yes, yes.
Thank you.
So moving on to our next presentation by Dr. Mary Estella Bister, Georgia Southern University from USA. Can you able to hear me, ma'am?
Good morning. Yeah, I'm just opened my presentation.
Yes, yes. Go ahead with your presentation.
Can you all see?
Yes, yes, we can see
Okay.
you.
Okay. Good morning from my side. Good afternoon from your side. And thank you for joining me. I'm from Georgia in the US, and we are called the Peach State. And we always say, welcome. We're glad you are on Georgia's mind. But today, I want also to tell you that I've got Rome on my mind all the time, because whenever I present blood cases to my students, I say, Rome, Italy is my favorite place, and let's go to Rome. So though I'm far away, welcome to you all there in Rome. Just something to show you my journey as a nurse educator. It started in Cape Town, South Africa, here at the southern tip of Africa. I've been there for 20 years teaching. I then moved to Jeddah in the Middle East, where I was 10 years, partially in education, and then also director practice quality research. And from 2016 to 17, I'm at Statesboro in Georgia on the East Coast here in the US. So I want to first talk about a pilot. Now, you all know that foggy weather happens quite often. And one of the first things the pilot does is to recognize there may be a problem flying through this weather, trying to land, but they also ask help in time. Now, at this point, I want to say I'm not presenting research. The purpose of my talk is to give a few thought-provoking ideas and to say, do we recognize we have a problem? But let's look at what pilots do next after they've called for help. They always keep their purpose in mind, and their purpose is the safety of the passengers, the safety of the flight crew. They need to try and keep their customers happy because airlines have become a very competitive area. The success rate is noticed in terms of how many flights are on time, how many delays. And then we know that when they do approach that weather, they have to make changes. They have to change their flight path. They may increase their height. They may have to decide to land on a different place, always keeping safety and quality around. They need to depend on each other's experience and expertise in that cockpit because the pilot is not alone. And yes, they use technology. It may sometimes be necessary to land on autopilot, but they need to use it very carefully, judiciously. And then they always need to reflect, to review their outcomes, and learn from their mistakes. I'm sure looking at this, you already know where I'm heading, to ask, where are we now? Do we recognize that we have a problem? I want to refer to some statistics about student attrition rates, nursing student attrition rate due to non-academic reasons. We realized that it costs a lot to train our nursing students. And then it is concerning that as in 2020, 20% of our US nursing students drop out before they're finishing the program. The UK statistics are even more alarming, where they have seen 33% dropping out into 20. And yes, I know you all are going to say, well, it's COVID related. But the reality is that can we just keep on getting students and then they drop out? And then when they look from a qualitative point of view, they have seen that students can't cope with the physical, psychological, and social problems. And the second theme emerging was there's a mismatch between what the student expects and what they experience in reality. So this first statistic tells us we have a problem in nursing education. Hopefully we recognize it. Our students of today are different. And yes, they don't want us to think out of our box. We need to start thinking out of their box. Many of them are Gen Z students. They are digitally enhanced. That's what they do. Smartphone, smartwatch. But there's also a sense for these students of, I want to belong somewhere. I want to feel I belong. I want to be engaged in what you're teaching me. They've got different learning styles. And do we accommodate them? Because that different learning styles require us to have different teaching styles. We cannot stand anymore in front of a group of students and just sort of spit out the knowledge that we expect them. And I want to share this story with you because this was a very breaking moment for me. This was a top student as a first semester student. She was passionate, eager to learn. She was dedicated. The fourth semester, that was when I had her in my class again, I asked her a question. I said, Mariah, what happened with that sparkle in your eyes that I've seen in your first semester. And she said, I don't like nursing anymore. I don't know if I am going to do the NCLEX. I don't want a nursing job. All my friends have started looking for jobs. I'm not going to look for a job. I don't know what I'm going to do. This is not anymore for me. And this was like a very sad situation for me, because I realized, and yes, I know it is not just the teacher, it is also the student, but along the line, the student lost their passion, interest, and actually their purpose that many of them have for quite some time before they're joining the nursing program. I want to show you the US Bachelor NCLEX pass rates. And for those of you who don't have board exams, this is the state exam that all nursing students in the US and Canada have to do to enter the profession. And if you notice that 222 compared to 219, it has got a sharp decline, okay? And we're now at 82.95% of students taking this course, NCLEX, pass the first time. And if you look at what it was in 2019, 91.22. So there seems to be a real decrease in the number of students passing. And I know there's a lot of conversation saying, oh, we spend too much time on NCLEX preparation, but this is a reality. So I really want to say, yes, we have a problem here. So how can we help our students to get through this, call it challenge, barrier of having to pass a national exam? And these remarks come from real students, successful students. They say, encourage us. You've got this. Tell us, we will help you. Being available, not just by preparing them, but even during that preparation month or two before they take on the NCLEX, they want to know they've got the support of their faculty. The preparation, students said, while most schools have got an end semester preparation course, teach this to us throughout the program. And actually, that's what we at Georgia Southern started doing, that from the junior 1 semester, we prepare them through special preparations. Exam readiness. Don't use your scores or predictor scores as, oh, you're going to fail because that's what the prediction says. Create confidence in them to motivate them. Remember what I was just said. The Gen Z students want to feel engaged. And then, unfortunately, we know, regardless of the preparation, all of these students said that the NCLEX was nothing like what they've experienced before. We are concerned, especially with our new NCLEX coming in spring of 23, with new type of exam items, that we not necessarily have the software to prepare them well enough for this challenge. In nursing education, we have got another problem. Academia is not financially competitive. Many nurse educators, and we already have a shortage, leave the profession. Some of them get a second job just for financial reasons. We see amounts like a bedside nurse coming into the academia with the relevant qualifications, dropping their income with $40,000 to $60,000 a year. So financially, we are in a dilemma that we cannot recruit nurse educators. Now, I know some people going to say, oh, yeah, you're a born teacher. Yes, it is the love of it. But I always say I cannot go to a store and say, oh, for my passion and love to teach, will you give me that microwave for free? So the other thing we see is our role models are decreasing. Many registered nurses continue with the masters, the nurse practitioners, even the doctorate, with very limited practice required before they do it. And all of them tend to do it, not necessarily to strengthen the clinical side, but rather to enhance their own income potentially. And then the increased class sizes, less individual attention, and we tend to revert to lectures. Burnout in nurses, this conference has highlighted that so far. Lucrative travel contracts we see with less stability, less preceptors available, the role modeling, and then we struggle to find clinical sites. We have to revert to simulation that's not always robust, high-fidelity simulation. And then students often lack purpose and meaning during their clinical experience. Also overload, infobesity as I call it. This is a workload estimator that looking at the workload for students. And this is really a very helpful tool. And I don't know how many of you do look at your students' workload. Well, I have determined retrospectively for one of my courses, students need 42.02 hours out of class to spend. And that tells me there's a problem, because if a student have got 4 courses and each course requires 40 hours of time out of class time, it is physically impossible, because we think we have to teach every chapter out of the book. So I really would recommend you to find a workload estimated for your student when you do your assignments, even things like reading. Because when we assign reading, we often assume that it is at the speed that we read. The entrance criteria. What do we require students? And those of you coming from the States know that during COVID, many of the standardized tests were dropped. How do we recruit students? Do we paint this beautiful picture? And how do we invest in that retention efforts? How do we try to keep that 20% dropout, 33% dropout in some other places? And how do we invest in nursing educators? How are we going to overcome that financial burden placed on somebody? So with these thoughts, I want to say we must look at the pilot in that foggy weather trying to land this aircraft, reflect. And that's what we tried to do today, to reflect of where we are. What happened? to review and see where's our gaps. But then if we don't go forward and say, how do we repair it? We definitely have got a problem. And with that, thank you for listening. I'm not going to pronounce the Italian. I'm sure those of you who are there will be able to read that. And I just put my email. You're welcome. Those of you who have similar interests or any other question. And thank you, Madam Chair. I will stop sharing and allow for questions.
So thank you very much for your presentation, Dr. Mary Astilla Bester. So are there any questions to ask?
Thank you, Valerie, for that comment.
So moving on to our next talk by Mary Johnson, Dr. MGR Medical University from India. Dr. Mary Johnson, are you available? Yes. Go ahead with your presentation. Can you please share your screen? So Dr. Mary Johnson has a technical issues to connect. So next we'll go with another talk by Dr. Zina M. Aisha, lecturer critical care nursing, Tanta University from Egypt. Dr. Zina, are you available?
Yes, dear.
Yes, go ahead with your presentation.
Okay. Dear.
Yes.
Is my screen is now it's clear for all?
Yes.
Okay. Ladies and gentlemen, grateful thanks for all of organizing team for the conference committee to give me a great opportunity to participate in this biggest event. Thank you for all of you. I am Zainab I am Egyptian and working as assistant professor in the professor critical care nursing, and currently I am working at Al-Biruni University. Today I will starting for my presentation about the efficacy of combining daily interruption of sedation with early progressive mobility protocol on the clinical outcome of the critically ill ventilated patient. One of the main challenges facing critically ill patients undergoing mechanical ventilation in the ICU is keeping them totally or virtually completely immobile, which has been linked to several serious complications, one of which is muscle inactivity and deconditioning, which has been linked to an increased risk of the ICU acquired weakness. And this is the picture we are familiar in for critical ill patient present in ICU. As you saw in the picture, those patients bedridden, totally independent, totally dependent on the nurses, and they can moving by themselves. They attach with a lot of the equipment, a lot of the supportive measures, a lot of the equipment, and they can't move. That's why early mobilization for those patients is very, very critical for them. What about the ICU acquired weakness syndrome? An ICU acquired weakness syndrome is supported by the observation that muscle wasting and weakness are among the most prominent long-term complication of the mechanical ventilation, and the usage of other supportive respiratory devices. In addition, a strong association appears to exist between the acquired weakness and protracted ventilator dependency. An important determinant for ICU length of the hospital stay multivariate analysis has identified several risk factors associated with increased incidence of this ICU acquired weakness, including severe systemic inflammations, medication, especially corticosteroid and neuromuscular blockage agent, glycemic control, and immobility. What about the impact of this ICU acquired weakness? The ICU acquired weakness has a negative impact for sure, a negative impact on those patients, since it tends to extend the duration of mechanical ventilation, prolong the length of ICU and hospital stay, and also increase the risk of mortality at hospital discharge. The evidence-based practice of an early progressive mobility protocol is a safe and effective strategy to reduce this complication of the immobility is very, very serious for those patients. What is the meaning for early mobilization for those mechanical ventilation patients? Early mobilization is a component of the ABCDE bundle, awakening from sedation, breathe independently from the ventilation, and choice of the sedation. The last one is the delirium management. Early mobilization, which was created to make evidence-based procedure in ICU setting more realistic and effective, safe, and improve the clinical outcome of, in all ICU settings. I apologize. What is the meaning for early mobilization? A broadly accepted definition of early mobilization is the application of the physical activity within the first 2 to 5 days of the critical illness or injury. It's so difficult, especially with the patient having acute state. Safety consideration were once a week in impediment to using this early mobilization in clinical practice, especially for those mechanical ventilation patients. However, recent systemic review and meta-analysis have proved that early mobilization of ICU patients is safe, with low incidence rate of the adverse events. Regarding the study, early mobilization in the intensive care unit is currently a hot topic. One of the most massive and threatening long-term complication among critically ill ventilation patients is the ICU acquired weakness. As a result, early progressive mobility protocol and discontinuation of the sedation in the early day of the treatment were linked to better critically ill patients' outcomes. And those patients, we need to changing the picture from the completely bedridden patient to those in the second picture. This is the state we find a lot of patients in mechanically ventilated, bedridden patient, can't move, needed support from the respiration, from everything related to the caring of those patients. And we need to changing the condition of those patients from this bedridden restlessness condition to help them to be more active and starting to move and retain their activity and muscle strength. This is our target after the implementation of the program to help the patient to change and shifting from the completely bedridden status to initiation of the mobilization and retain of their muscle strength and trying for doing certain activities and keep out of the bed. To evaluate the efficacy of combining daily interruption of sedation with an early progressive mobility protocol on the clinical outcome of the critically ill ventilated patient. Design and implement an early progressive mobility protocol as a guide for early mobilization for the critically ill patients. and also to compare the effect of the routine care versus daily sedation interruption and an early progressive mobility protocol on physiological and functional outcomes in the ventilated patient. Also, one of the aims of the study to assess the hemodynamic respiratory metabolic effect of the cycling exercise performed during the first 2 to 5 days of initiation of the mechanical ventilation as early mobilization for those patients. What about the research question? The first one is if there is any relation, if the early mobility protocol safe, reasonable, and achievable for the critically ill ventilation patient. If there is a decrease in ventilator days or length of hospital stay for those patients using an early mobility protocol, and what are the effects of an early mobility protocol on the hemodynamic parameter, length of hospital stay, and patient prognosis. Suppose this is the targeted outcome from those patients, we needed to obtain hemodynamic stability and improving the level of consciousness for those patients, improving the weaning and help to early weaning of the patient from mechanical ventilation to avoid multi complications can happen from the mechanical ventilation by decreasing also the duration of the mechanical ventilation and ICU hospital stay, length of hospital stay, decrease the prevalence of the muscle weakness, and improving and avoid the incidence of the delirium, improving the functional status and muscle strength, and decrease the mobility complication, looks like DVT, hospital-acquired infection, and so on. For the research design, an experimental research design was utilized in this research. The research was carried out in Tantammen University Hospital, ICU, specifically the post-anesthetic and emergency critical care unit, which treats the patient with a variety of the diseases in acute stage of their illness. A purposeful sample of around 60 adult mechanically ventilation patients of both sexes who met the inclusive criteria was randomly divided into 2 groups, each group having 30 patients. Group 1 was the control group, and control B, group 2 is the studied group. What about the inclusive criteria? As our patients is very critical, and we must avoid a lot of intervening variable by determining the inclusive criteria for selection of those patients who are confined and who are available to be selected to be included in the study. Adult patients of both sexes needed mechanical ventilation support for more than 72 hours using any ventilator modes. No active seizures and no alcohol withdrawal, no admission, new admission in the first 24 hours of the hospitalization. During the program will be carried out in the early mobilization from the first 2 to 5 days of intubation, hemodynamically stable, no agitation, Richmond assessment sedation score greater than 2, no paralytic agent or neuromuscular blockers, and no vasopressor medication used. There has been no myocardial ischemia in the last 24 hours, no hypoxia, don't have any signs and symptoms of increased intracranial pressure, and the patient must reach the level of mentality that permits interaction with the staff. 4 tools were used by the researcher based on the reviewing of the relevant literature. Tool 1, critically ill patient assessment tool. This tool was developed and designed by the researcher after reviewing of the related literature to assess and collect the baseline data regarding the patient. It included 5 parts. The first part, patient sociodemographic data, patient clinical data, glaucoma scale, simplified acute physiological scale, and Richmond agitation sedation scale. And tool 2, the health assessment and clinical data assessment tool, was divided into 3 parts. Part 1, it concerned by the data regarding the assessment of the daily awakening trial criteria. Part B, medical research council strength score, and Part C, intensive care delirium screening checklist. Tool 3 is the BERM ICU mobility assessment score, and the last tool is the medical research council strengthening score. The process was carried out through the following phases. We have 4 phases to carry out of this study. The first one is the assessment phase. How this phase goes on. The initial phase, was carried out by the researcher for all ventilated patients to assess the patient who meet the inclusive criteria of the study. 60 adult mechanically ventilated patients fulfilling the inclusive criteria were randomly selected and randomly assigned into two groups with 30 patients in each one. Both groups were assessed using tools of the study to collect the baseline data from the patient and or his family and from the secondary source as healthcare team and medical records within the first 2 to 5 days of intubation and continued daily for the duration of the ICU stay until the patient discharged from the intensive care units and the patient starting for mobilization out of the bed. Monitoring for the patient vital signs and hemodynamic parameter first before the starting of the protocol as the baseline data. Assessing the patient criteria for spontaneous breathing trial according to the following algorithm. This is the daily awakening protocol. We must follow this one to consider what about the patient if he is available to be and to perform the daily awakening trial for himself or not. The second phase is the implementation phase. During this phase, immediately after the patient admission at the first 24 hours of intubation, the following respiratory steps for both groups were taken. These preparatory steps, the first thing is the new simplified acute physiological score. It's estimated once on admission and is calculated method for to optimize for proper scheme. The measurement was completed and resulted in an integral point score between 0 and 163. The set includes on the variable 12, it contains 12 physiological variable, age and type of admission, 3 underlying disease variables. This score is used to measure the severity of the disease and predetermine the mortality rate for those patients, as this patient condition have severe life-threatening conditions. And the second one is the Richmond agitation sedation score. This monitored for all of the patients once per shift to establish the sufficient level of sedation to promote more precise medication titration. That this monitoring was carried out each shift. This carried out through observe each patient and scoring the patient according to these scores. By using the Richmond agitation scale, this is very important to determine if the patient is to determine the awakening condition of the patient and the patient need for the sedation. Observe the patient if he was alert, restless, or agitated, and the scoring ranging from 0 to +4. If not the patient alert, state the patient name and say to open his eyes and look forward. If the patient awakening, sustained, and maintaining or sustaining eye opening and maintain the eye contact, he will scoring -1. The patient awaken with eye opening and eye contact but not sustained, scoring -2. The patient had any movement in response to the voice but no eye contact, scoring -3. When no responses to verbal stimulation, physically stimulate the patient by shaking the shoulder and rubbing the sternum. If the patient had any movement to physical stimulation, it will be scored -4. And the patient has no response, it will be scored -5. This modify another tool, the modified burning assessment program, is based on the percentage of the positive answers. This tool used to test the readiness of the patient to wean from the mechanical ventilation. The patient had a total percentage score before the weaning process should be initiated as the first spontaneous breathing trial as a predictor of the successful liberation from the mechanical ventilation. The final POAP score is the number of the yes answers divided by 26. This higher the score, where the greater the readiness for the patient to wean from the mechanical ventilation. And this part was carried out each shift. Another process or another step in the implementation phase, the spontaneous breathing trial are administered to all mechanical ventilation patients at least once every 24 hours to help the patient to elaborate it and separate it from the massive doses of the sedation. And it will be dependent also and binding directly with the scoring of Richmond agitation sedation score. Starting with assessing spontaneous breathing trial safely, and screening for the patient. If the patient has a successful spontaneous breathing trial, safety screening if the following criteria are met. Looks like oxygen saturation, stability of airway, no agitation. There has been no myocardial infarction in the last 24 hours. There have been no change in the intracranial pressure, no neuromuscular blockage, systolic blood pressure greater than 90, and increasing titration of the vasopressors. If the patient has successful spontaneous breathing trial, the patient will continue on the current sedation and sitting for consideration of extubation. This was discussed during the interprofessional morning daily medical rounds with the consultant, with the nurses, with the team of the ICU to decide if the patient having a successful or not successful trial. If the patient has an unsuccessful trial, the patient is placed again on the previous sitting and plans are discussed during the rounds. After all of these steps, an early progressive mobility protocol will take its place. It was developed by the researcher after reviewing of the protocols founded in the critical care literature for the use of the selected critically ill patient. This progressive mobilization was initiated on the day of the admission. The selected patient was assessed for hemodynamic, level of consciousness, level of sedation, winning criteria, and mobility readiness through permeability assessment score. The early mobility protocol was placed on the clipboard at each patient side as a reminder for all of early mobility progression from all the team. It's added to the patient file also and on the patient bed, which means that the patient is at low risk of an adverse events and has no problem with proceeding the progressive mobility protocol according to the following table. This is early rehabilitation and progressive mobility protocol initiation and safety. Green mark will be applied for the patient with low risk of an adverse events, and active mobilization is allowed according to the applied protocol. Yellow mark, this is potential risk. This applied for the patient who have potential risk and consequences on adverse events are higher than green, but may outweighed by the potential benefits of the mobilization. The precaution and recommendation should be clarified before any mobilization. During mobilization, instruction is given to perform movement gradually and very cautiously. And the last one is the red mark. Red mark is applied for patients who are significant potential risks and or consequences of an adverse event. Any active movement shouldn't occur unless specifically authorized by the treating ICU consultant with the senior treating doctor and senior nursing staff. Neurointensivists with bedside nurses assess the patient with the yellow code every 12 hours for mobility readiness and review the medical record to assure mobility and mobility order were written. The researcher educates and explains to the bedside practitioner nurse how she can assessing the mobility for those patients by using burn ICU mobility score and mobility level milestone. Progressive mobilization was initiated on the day of admission unless the patient were physiologically unstable. Nurses were encouraged to use the ICU bed features and available mobilization aids for turning and positioning the patient inside the bed. And neurointensivist physiotherapists beside nurses initial patient screening and assignment of mobility level progression criteria from level to other level dependent on the following: the hemodynamic stability of the patient, the level of consciousness, absence of agitation or any anxiety, any restlessness or any ICU psychosis, the patient's ability to tolerate for the previous level was without any adverse events. It's safer to increase the intensity of the activity slowly and progressively as each treatment is tolerated. Also, it depended on the activity. The activity should be selected based on the assessment of the patient underlying cardiovascular and respiratory reserve. Activity should be determined from the patient responses to previous mobilization level. After that, the duration and frequency will be dependent according to the previous one. Mobilization should be as functional as possible. Patient safety should be considered during all of the phases of the mobilization activity. And this is figure showing the level. We have 4 levels for the progressive mobility protocol to help the patient to moving from the bed to becoming walking independently. We have, for sure, for dealing with those patients, the study not easy, and we have a lot of challenges, and we faced by certain limitations for this study. This study has some limitations, looks like when mobilizing the patient to a chair, many patients didn't stand and pivot at the bedside, rather they were lifted. Some patients stay at level 2 and can't proceed to level 3. Lack of lifting aids and bedside safety chairs in the ICU. Until now, no previous study have investigated the safety, feasibility, or effectiveness of early mobilization in patients who are critically ill and ventilated and who has sustained traumatic injury at Tanta University. As a result, when the protocol was first implemented, the idea and the executions of the protocol were met with some resistance and obstacles. However, as the protocol was implemented and the patient condition was starting to be improved and they touching how the patient improved by the mobilization, all the entire ICU staff realized that the protocol was effective and all of them became good contributors for helping the patient to move out of the bed. The study major finding reveals that there was a statistically significant difference between the two groups in terms of progressive mobility milestone level, Medical Research Council strength score, and functional evaluation with p-value of 0.000 respectively. Moreover, there were highly statistical significant difference between the two groups regarding the clinical outcome. And this is the main point for the study, is the patient outcome. We find a good improvement in the level of the consciousness for the patient, decreasing the length of hospital stay, occurrence of the adverse events from the immobility, prognosis, and enhancement in the winning outcome, discharge status, as well as reduction of the ICU acquired weakness by implementing the protocol to improving the functional recovery and improving the muscle strength. This table showed a significant statistical significant difference in between the two groups regarding to the progressive mobility milestone. Also, this table shows the percentage of distribution of the studied patient according to the Medical Research Council strength score, and there is statistical significant difference in between them regarding the patients who know movement, the patient only traces movement in scene, the muscles who can only move if the resistance or gravity moved. And this is the efficacy and the impact of combining daily interruption of sedation with early progressive mobility protocol on the clinical patient outcome. From this table, we can observe that there is statistically significant difference and improvement in the patient clinical outcome regarding the length of the hospital stay, the adverse events, and the discharge status also impacted the winning outcome. My conclusion, the implementation of the protocol for combining both daily interruption of the sedation with early progressive mobility had a positive impact on improving the clinical outcome for those stuck critically ill patients. And my recommendation, it was recommended that they merge both hands in handling the daily sedation interruption with the early progressive mobility protocol as a part of the daily routine care for those critically ill ventilation patients to improve their clinical outcome. Thank you all for your patience and your attentive listening. Thank you for all and welcome by any question. Thanks.
Thank you. Thank you so much, Dr. Zinam, for your valuable presentation. So any questions there to ask? So thank you once again very much. So moving on to our next presentation by Dr. Mary Johnson, Dr. MGR Medical University from India. Please go ahead with your presentation, ma'am.
Yes, I'm trying to share the screen.
Yes, please share your screen.
Can you see my screen, ma'am?
No, no.
Can you, ma'am?
Not visible. Can you share us in WhatsApp so that we can play you?
Oh, that will be really nice.
Okay, please share us in WhatsApp so that we can.
WhatsApp. Yes, ma'am. I'll do it. I'll do it.
Yes, yes. Ma'am, can we move on to negative talk? Are you there, ma'am? Dr. Mary Johnson? Ma'am, are you there? Or shall we schedule to another person? Ma'am, are you available? Sorry, ma'am. We are going to move our next talk. Dr. Janita, are you available to take talk now to give your presentation?
Yes, ma'am.
Yes, go ahead with your presentation.
Okay, ma'am.
Please share your screen.
Okay, ma'am. Is it visible, ma'am?
Yes. So go ahead with your presentation.
Okay. Good afternoon, all of you. Am I audible, ma'am?
Yes.
Okay. Thank you for giving me such a wonderful chance to be with you in this 6th World Congress on Nursing Education and Healthcare. I would like to thank the All Organization Committee for allowing me to share with you my presentation. Myself, Janita John Vagila, working as an Associate Nursing Officer at Zydus Hospital, Ahmedabad, Gujarat. I have total 13 years experience as an infection control nurse at UN Mehta Institute of Cardiac and Research Center. Today, I am going to present here my study regarding the reduction of CLABSI rate in pediatric post-surgical ICU by implementing multimodal strategies of infection prevention and control as a part of patient safety. So first of all, I want to share here some amazing facts about the microbes. So I have one question here. Who came first on the planet, microbes or human beings? What do you think? So if you search the revolution history, you will come to know that microbes came on this planet about 4,000 million years ago. So the microbes are our seniors and more familiar with this planet than the human beings. Or we people think that we are smart, but that is not true. The microorganisms are smarter than us and they are the biological computers. So there is a constant battle between the microbes and human beings like this. So microorganisms have to cause the infection and we have to prevent it. So the battle is still going on. So we have to live with them. We cannot completely kill them because some of the microbes are very important for our immune system too. So we have to live with them. So to fight against these microbes, we should follow some important smart strategies. So when we people as a team meet like a clinicians, nurses, administrator, paramedical staff to discuss regarding the strategies to prevent the infection, that time the scenario is like this. Only the blame game and the fighting with one another saying it is not my mistake, it is the surgeon mistake, it is the clinician mistake and blah, blah, blah. So, on other hand, if we talk about the microbes, at that time, the scenario is like this. So we can see the difference between the pictures. So we can say that the microorganisms are very smart from us because they also make a plan to attack the host very smartly. So microbes have some amazing qualities. They are the biological computers. Microbes have some amazing intelligences like communication, decision making, city living, navigation, etc. So microbes communicate with each other by the secret code which is called foreign sensing. They secrete a chemical on their surface. Foreign sensing using autoinducers allow bacteria to communicate within and between species. So one of the most straightforward is demonstrated by Bacillus subtilis. If Bacillus subtilis individuals are growing in a food poor zone, they release the chemicals into their surroundings. These essentially tell their neighbors There is not much food here, so clear off or we will both starve. So this is called intelligent communication. Another good quality is decision making. Each individual bacterium releases a small amount of a chemical into the surrounding area. If there are lots of other bacteria around, all releasing the same chemical, levels can reach a critical point and a trigger change in a behavior. So pathogenic bacteria often use foreign sensing to decide when to launch attack on their host. Next one is city living. Not only can bacteria be talkative and cooperative, but they also form communities. When they do, the result is a biofilm. So there are also other intelligences called navigations, learning, memories, etc. So we can say microbes are smarter and biological computers. So these germs are small, but they are very scary. And this is not only the theory, not only the hypothesis, but it is proven by the WHO data. So as per the WHO, HAI are the most common adverse event in the healthcare delivery. Of every 100 admitted patients, 7 in developed country and 10 in developing country will develop the HAI. In high income countries, 30% patients admitted to ICU develop the HAI. In low and medium income countries, this rate is 2 to 3 times more than high income countries. So let's move forward to my study and presentation. So in my presentation, I have included the introduction, methodology, results, and conclusions. So as we all know, healthcare-associated infections continue to be a source of great medical and economical strain for healthcare system across the world. So HAIs are cause of significant morbidity and mortality in patients receiving the healthcare. So anyone getting medical care is at some risk of HAI. So as per the IPSG fifth goal, to reduce the HAI, we should follow structured infection prevention and control measures. So most common HAIs are 40, WEP, CLEPSI, and SSI. So CLEPSI is one of the most common HAI. So CLEPSI stands a major threat to patient safety and is associated with additional cost and morbidity. So this study investigated the sustained effect of multimodal strategy, including focusing on central line bundle improvement, frequent reminder and feedback of hand hygiene, frequent environmental deep cleaning, enhanced interactive training in the ICUs of a super specialty cardiac hospital, Ahmedabad. So aim of the study is to identify the 50% reduction of CLEPSI rate in post-surgical cardiac ICU within 6 months of implementing multimodal strategies of infection prevention and control. So CLEPSI are a preventable complication that results in thousands of deaths annually and billions of dollars in added cost to treat the patient. So CDC is providing guidelines and tools to the healthcare community to help the end of CLEPSI. So what is central line? So you may be familiar with intravenous catheters that are used frequently to give the medications or fluids into a vein near the skin surfaces, usually on the arm or hands for a short period of time. But the central lines are different from the intravenous catheters because central lines access a major vein that is close to the heart and can remain in place for several weeks or months and be much more likely to cause serious infections. So central lines are commonly used in ICUs. So what is CLEPSI? Means central line bloodstream infection. So CLEPSI occurs when germs, usually bacteria or viruses, enter the bloodstream through the central lines. So healthcare worker must follow a strict protocol while inserting and handling a line to make sure the line remains sterile and CLEPSI does not occur. So patients who get a CLEPSI have maybe a fever, might also have a red skin, soreness around the central line. So let's see how central line is colonized with the germs. So number one source is due to the line is colonized while insertion itself. and then it can be infected by the insertion who has not followed the proper aseptic practice during the insertion. Number 2 source is when central line is not handled properly after the insertion, like it's connected to the unsterile infusate or the unsterile IV fluids, and healthcare workers not following the proper hand hygiene while the handling of lines. Number 3 way is central line is gets infected when infection come from the distinct source, like the patient maybe have UTI or VAP or any other HAI. So the study is conducted in the pediatric post-surgical cardiac ICU of Super Specialty Cardiac Hospital and Research Center in India, which is one of the biggest cardiac hospital in the world. So this study is conducted in 2 phases. In first phase, retrospective study for the baseline CLABSI rate is done from monthly data collected by the infection control team for the year of 2016, 2017, and 2018. In second phase, multimodal strategic interventions that aim to reduce to CLABSI were initiated in January 2019. The prospective study is done for the period of 6 months from January 2019 to July 2019. The incidence rates of CLABSI for the 6 months are compared between the baseline data. So after retrospective study, we took our average rate 6.34 to us want to 50% reduction by implementation of multimodal strategy. So before intervention, our hand hygiene compliance and average central line days has been recorded and documented. As per the baseline data, we also found that 33% CLABSI is occurred between the 3 to 7 days of insertion of central line, while 67% of CLABSI is occurred after 7 days of insertion of central line. So we can also focus on early removal of unnecessary central lines, which is major component of CLABSI bundle approach. So we have implemented this multimodal strategy, re-emphasize on central line bundle care, frequent reminder and feedback on hand hygiene, motivate the staff, enhance interactive nursing staff education, and frequent environmental deep cleaning.
You know what I need to do is...
So, first of all, re-emphasize on central line bundle care. So to decrease the colonization and biofilm production, we re-emphasize on bundle care. So as we know, bundle is a structured way of improving the processes of care and patient outcomes. Usually a small straightforward set of evidence-based practices, generally 3 to 5, that when performed collectively and reliably have been proven to improve the patient's outcomes. So CLABSI bundles includes hand hygiene, maximal barrier precautions, optimal catheter site selection, skin preparation, daily review of line necessity and documentation, dressing, and scrub the hub. So to reduce the CLABSI, we should always follow these tools. So we re-emphasize on bundle care, especially on the scrub the hub protocol, which is most important to reduce the CLABSI. So our bundle approach mainly contains these 3 care: scrub the hub when assessed, hand hygiene just before the assessing the line, and hub should be put on clean or sterile area. Sometimes we observe in our round that healthcare worker put the hub open and put it on the bed or on the patient's locker. So there may be a chances for contamination. So to reduce that, we emphasize that hub should be kept on clean or sterile area. Second component is frequent reminder and feedback of hand hygiene. Hand hygiene plays a vital role to reduce the infection. So to improve the hand hygiene compliance, we set a central announcement system for every area every 2 hourly as please do hand hygiene, clean hands count. Also, we start to give the individual, category-wise and ICU-wide both positive and as well as negative hand hygiene feedback compliance given. So individual can also improve it. And subsequently, we can see improvement in all over hand hygiene compliance. Plus, reminder for early removal of unnecessary central line is implemented during each medical round to reduce the unnecessary handling of central lines. Motivation of the staff. Along with this, we started to motivate the staff. Initially, we used to give the yellow card for the non-compliance of infection control practices, which leads to demotivation of the staff. So as a motivation is the defining factor that turns a good thought into immediate action, and it can positively impact the world around you. So along with multimodal strategy, we started to motivate the staff by giving them green card or say as the star of the month for their good work for infection prevention and control. Next strategy is frequent environmental deep cleaning. Scheduled deep cleaning of the ICU along with the daily cleaning is strengthened. There is a highest chances of cross-contamination if a new admitted patient is placed in a room previously occupied by a patient colonized or infected with pathogenic bacteria like MRSA, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas, etc. So such pathogens are able to survive on the surface for days to months and increasing the risk of infection for patients unless they are removed by the cleaning process. So in addition, cleaning and decontamination form an important part of an outbreak control part. So frequent environmental deep cleaning is very much important. So frequent environment deep cleaning of ICU has been scheduled to reduce the environment contamination of microorganisms. So we made a calendar plan for timely deep cleaning of ICU along with the daily cleaning. Next is interactive continuing nursing education. Interactive continuing nursing education is another evidence-based intervention to reduce the prevalence of MDRO and improve the infection control related compliance. We started incorporated interactive self-directed learning in small group of 7 to 8 people instead of classroom training. So in this, we included audio and visual presentation on various topics of infection prevention and control, such as fundamental of asepsis, hand hygiene, safe injection practice, bundle care, environmental deep cleaning, standard precautions, and transmission-based precautions. So this education in service sessions were approximately 60 minutes each day for 4 days a week. 15 minutes were used as the beginning of the session for a knowledge assessment pre-test to determine the baseline knowledge. So after implementation of multimodal strategies, we calculated our CLAPSI rate for 1000 central line days from January 2019 to July 2019, which is shown as in this table. So we can see our CLAPSI rate is going down gradually. So average rate suggests that 50% reduction of CLAPSI rate with the help of this multimodal strategy. Before enhanced intervention, our hand hygiene compliance was in 2017, it was 57.14, and in 2018, it was 58.9. But after implementation of this strategy, and after the frequent reminder for the hand hygiene and the central announcement system, our hand hygiene rate is increasing gradually. We reach up to 67% of hand hygiene compliance. Improvement in bundle care compliance. We found improvement in bundle care compliance, especially scrub the hub protocol, which is most important to prevent the CLAPSI. So before intervention, it was 50%, and after intervention, it was 69.8% compliance, which was audited by the infection control team. And average central line days also reduced up to the 10% by this multimodal approach. So as Sant Swami Vivekananda said, every new idea first become a joke and then refused by the people. But in last, gradually people accept it. Just like that, in initial phase, we faced behavioral issue, attitude issue, and resistance to change. which is overcome by training, effective communication, and team building spirit. Improvement, including behavioral change in a practical manner, is the key principle of good implementation practice. So our findings suggest that clinically relevant reduction of post-surgical clepsy was reduced with a multidisciplinary and multimodal interventions. Improvement, including aspects of behavioral change in a practical manner, and key principles of good implementation practice. In this sense, our strategy is more in-depth than some promoted bundles. So implementing multimodal interventions focusing on central bundle improvement was effective in reducing the incidence rate of clepsy. So the key message of this presentation is multimodal strategy focusing enhanced interactive training and feedback to the staff for the clepsy bundle compliance is more effective way to reduce the clepsy. So the golden rule of infection prevention and control is treat others the way you want to be treated. So today's nurses are the key players in the fight to ensure the survival of infection control practices. So nurses can lead the commitment to reduce the clepsy and other HAIs and improving the quality of care. So clepsy is a preventable disease, and I can, you can, and we can do it. By this multimodal approach we can use. Thank you very much for this presentation. And if you have any question, you can also ask me on this my mail ID. Thank you very much.
So thank you so much, Dr. Janita John. So if you have any questions, you can ask. So moving on to our next presentation by Dr. Anders Kronström's Infant Bacterial Therapeutics AB from Sweden. Can you please stop your screen, Dr. Janita?
Yes, ma'am. I have stopped, ma'am.
Can I ask, check if you hear me well now?
Yes, doctor.
So I'm trying now to share, and let me know when you see what I'm sharing.
Yes. It's audible to us.
Is this all good?
Yes. Go ahead with your presentation.
Okay, thank you very much. And
thank you.
Good afternoon, everyone. And first, I'd like to thank the organizing committee for inviting me to speak on this conference. I'm very excited to attend, albeit virtual and not in person. So if I just very briefly go over the disclaimer, now you've read that part, I can move on to the presentation. I'd like to start with saying just a few words on where I'm coming from. So I'm work for a company, it's Infant Bacterial Therapeutics. It's a biotech company founded in Stockholm in 2013. We are the vision for the company is to develop medicines, pharmaceutical grade probiotics to prevent life-threatening disease in premature infants. And one of the key assets that we have in development is the drug candidate IBP 9414. It's currently in phase 3 development for prevention of necrotizing enterocolitis and for improved feeding. And today we are actually the first and the only company in phase 3 dosing bacteria to preterm infants under US IND and under equivalent regulatory guidelines in Europe. Before going into the data I intend to present, I just want to sort of illustrate the motivation why we're doing this. Obviously, we have some interesting assets, some drug candidates, we have skilled people, we have resources, and we also have finance to do the development. But that's all means the really motivation for us doing this is, of course, to try to treat and help these very vulnerable patients that you can see on these slides. And our aim, as I mentioned, is to develop preventive medicines in this area. And I don't have to educate you. I think you're all you're all aware of that, on the need for better medicines for this patient population. So let me then talk about the day and the study and the data. The phase 3 study is called the Connection Trial, and it's the first ever probiotic phase 3 study under US IND. It's a double-blind, placebo-controlled, parallel group, multi-center phase 3 study, and we're recruiting babies with a birth weight between 500 grams and 1,500 grams, and they are in between 23rd and 32nd week corrected gestation age. And our primary endpoint in the study is the incidence of necrotic enterocolitis and improved feeding tolerance. And I will come back and explain a bit more how we define the sustained feeding tolerance. We're doing this, the active ingredients in IBP 9414, it's Lactobacillus reuteri. It's given enterally as a single dose of 10 to the 9th CFU, or in the placebo arm in the study, we are dosing steroid water. And the study is performed in 10 countries, US and Israel, and 8 countries in Europe. The two analyses that I want to talk about, there are two previously performed interim analysis done in this study. One where we looked at the profile and frequency of serious adverse events, and the second one is how we look at how different clinical events correlate to the time it takes to reach sustained feeding tolerance. And the materials is based on the 708 infants included in this predefined interim analysis. 116 of the infants were between 500 and 749 grams, with a mean of 648 grams, and 592 infants were between 750 and 1,000 grams. All data is blinded as this study is ongoing. And all the clinical events are collected from investigator reports, how they report in the CRF and on the adverse events. So if I first move into the first in the safety profile, you can see that on this population, this data set, the mortality in this patient population was 12% in the lower birth weight cohort, 500 to 749, and 5.4% in the birth weight cohort, 750 to 1,000. And cause of death is dominated by cardiopulmonary serious adverse events. And by serious adverse events, we mean that they are deemed life-threatening or that they lead to prolonged hospitalization. And that is an assessment done by the principal or the responsible investigator in the study. 38% of the infants in the low birth weight cohort had at least one serious adverse events, whereas 24% had an SAE in the higher birth weight cohort. 50% of all SAEs that we saw in the study that occurred during the first 2 weeks in life, which is not surprising. That's when most of the SAEs occur. And that they were naturally also more common in the lower birth weight interval. Infectious disorders were the most common SAE, dominated by sepsis and septic shock. And that was reported in 18.1% in the low birth weight cohort infants and 8.4% in the higher birth weight cohort. I move on to the conclusion on the safety. There are some other, you can see it on the slides, but now I can't change slide. Let's see. Okay, sorry for that. The conclusion. Overall, in terms of the safety profile in the study, mortality lower than expected, and we can compare that to some networks where they collect similar type of data, and we are naturally lower. And one of the reasons is obviously that we have some inclusion criteria and exclusion criteria in the study. So babies in extremis, for example, that have little chance of survive, they are not included in the study. So obviously in the national general population, the mortality numbers are higher. Apart from that, the SE type and the incidence rates are rather consistent with what we expect to see, which is good because we obviously want to make sure that we don't have any safety concerns with our drug. And as I said, most serious adverse events occur during the first weeks in the study and in the smallest babies. If I then move on to the second analysis we did at this point in time, and that were how we looked at how sustained feeding tolerance correlates to clinically meaningful outcomes in this population. And I will mention SFT, and that's sustained feeding tolerance. And the way we define that is for 10 consecutive days in the study, the daily enteral feeding should be equal or higher than 120 milliliters per kilogram. So it should not drop below 120 during these 10 days. No parenteral nutrition is allowed during that time, and the average body weight increase should be at least 10 grams per kilogram per day. So that means the point in time when they reach sustained feeding tolerance, that should be maintained, fulfilling these 3 criteria for 10 consecutive days. That's how we define sustained feeding tolerance. And what we have looked at in this studies, what clinical events will impact how long time it takes to reach this point. And it's measured from first dose, and that typically occur within the first or second day in life of these infants. The infant material for this analysis, we had of the 708 patients, 519 infants did that actually reach sustained feeding tolerance. So they reached a stable feeding before they reached 34 weeks plus 6 days in life. 122 of the infants did not reach FFT before 34 weeks plus 6 days. And that's the end of the treatment period in our study. So we don't have any data beyond that point in time. So that's why they're not included in this analysis. And 90 infants were excluded due to early study withdrawal. For example, if the baby dies before 34 weeks plus 6, and obviously they will not reach the sustained feeding tolerance. So 90 patients were excluded for that reason. The methods we have used is the univariable correlation of events to the time to sustained feeding tolerance, fairly straightforward. But from that, we have further looked at multivariable correlations with the use of a stepwise procedure to optimize the model better, to look at all the variables that had a p-value of less than 0.05 were looked at that multivariable analysis. So if you then look at the results from this analysis, these are all events, and we were actually looking at more than 28, and these are the events with association of a statistical significance. So they had a p-value from, in essence, 0.00 or less than that, up to 0.02 to the time to sustained feeding tolerance. So the way to read this, it's a lot of numbers. So for example, birth weight. If an infant has an increased birth weight by 100 grams, we looked at 100 grams intervals. So 100 grams more in birth weight reduces the time to reach sustained, correlates to the time it takes to reach sustained feeding by 3 days. So that's the coefficients. That's why it's a minus sign. The bigger babies, they reach sustained feeding earlier. The same goes with corrected gestational age. If they are born later, they are more mature, it takes less days to reach sustained feeding. If we then look at some other parameters, any SE. So if you have any SE in this study, and that's again considered by investigators as life-threatening, if you have an SE, you will have a deferral of the time it takes to reach sustained feeding by 6.8 days. If I take another example, GI perforation, which is fairly common in these small infants, babies with a GI perforation have reaches sustained feeding tolerance 21 days later. We see necrotizing enterocolitis, it differs the sustained feeding tolerance by 6.8 days. Sepsis 5.6. So you can see there are many clinical important outcomes that has a very strong correlation to sustained feeding tolerance. If I then move on to what we did, all the events that had a statistical significance of less than, with a p-value of less than 0.05, were also moved to a multivariable regression and included a stepwise procedure to optimize the model. We can see that, for example, the GI perforation, which had a significant, had sort of a 28 days effect on SFT. In this model, we see and that it has, if you have a GI perforation, you have a corresponding 15.4 days deferral of the time it takes to reach sustained feeding tolerance. And the multivariable regression obviously takes into account the covariation of different factors. So here they are isolated. Clinical sepsis again falls out with some statistical strength in this model. So a clinical sepsis means a deferral of the SFT by 3.5 days. Respiratory SE, 4.5 days. Cardiac SE, also a significant deferral to time to SFT by 9.0 days. And I could also comment on the overall model, the R2. You also saw the R2 values on the previous screen, the univariable. R2 tells you, in essence, to what extent this a certain factor contributes to the variability in SFT. So the overall model here, all these parameters, they contribute to 35% of the total variability you see in the time it takes to reach sustained feeding tolerance. So conclusions, events correlations to the time to SFT. There are several GI complications associated delaying the time to sustained feeding tolerance. Stronger for perforation, as I mentioned, the 21 days and the 15.4 days in the multivariable model. The time to SFT is extended in means that with extra GI complications like pneumonia, cardiac events, and hypotensions. Obviously co-occurrence of events. So if you have several events that co-occur, that would prolong the time to SFT even further. And there are some debate around how aggressive you should feed babies in these small babies. And I think the data that we have shown here, together with other data that we have reported from this study, gives us reasons for for maybe a further evaluation on the sort of how feeding should be done in these babies. I mean, we see that in many cases, feeding is withheld when certain events occur in the study, and maybe there are some reasons to evaluate what should be in the feeding guidelines for these babies. That is what I had to present. Thanks to everyone for your attention.
Thank you. Thank you so much, Dr. Anders. Is there any questions to ask? So thank you so much, Doctor.
Thank you.
So moving on to our next presentation by Dr. Joyce Simard, College of Health and Sciences, Western Sydney from Australia.
Good morning.
Yes, good morning, Doctor.
And are you able to see me?
No. Yes.
Hi.
Hi.
Hello. And
Hello.
thank you so much. Thank you so much for inviting me to be part of your conference. Actually, I live in Florida.
Yes.
And it's morning here in
Yes,
Florida.
yes.
So greetings from Florida, where hopefully we're not going to have any more hurricanes.
Yes.
And today I'm going to be talking to you about a program I developed called Namaste Care. And of course, anyone from India knows Namaste. And I named the program Namaste because I was trying to figure out what I was going to call this program, because obviously it had to have a name. And I read something that said, Namaste, to honor the spirit within.
Yes, sure.
And so that is how it became called Namaste. But you can't copyright Namaste because it's just a greeting. So the care was added so that I could publish about it. A little bit about my background. As I said, I'm a social worker. And when I started social work 40 years ago, believe me, in nursing homes, we had residents that were alert and oriented. And I did discharge planning. I helped them figure out how to get home. I worked with the families. I helped them with the guilt that they were feeling when they had to bring mom into a nursing home. And then the population began to change. And people were looking for their mothers. And we were trying to tell them the truth. You know, your mother's dead. And of course, they'd cry. And it was very, very confusing time, at least in the United States. And then we decided to join their journey. And Naomi Feil developed something called validation therapy, where we didn't tell them that mom had died. We said things like, can you tell me about your mother? She sounds like a wonderful person. Oh, no, it's not, you're not going to work today. It's the weekend. You know, so whatever we were doing, trying to make them happy. And these were really people that were very early and moderate dementia. And then I thought I would retire about 20 years ago, because I was old enough to retire then. And I went back to the nursing home in Vermont, where I started this program called The Club. And it was a program for people with moderate dementia, gave them a reason to get up every day. So it was really fun that they had a job to do. So it was very, very successful. And I went in to observe it, and I found several of the residents were slumped over in their wheelchairs. They had passed the point where they were able to participate in any kind of an activity. And I looked at them, and I, we're keeping them clean. We were feeding them. We're plunking them in front of a TV set or on outside of an activity. And I looked at them and I thought, you know what? They're existing, not living. And I believe everyone should have quality to their life, literally, until they take their last breath. And that's how Namaste was developed. I wanted to have two principles. I knew that it was I knew that it was going to be perhaps different in different nursing homes, and I had, of course, no idea that it would be international. This one little program is now in 15 countries in a variety of settings. But I did set two principles. One is that nothing would be hurried. I don't know about your country, but in our country, especially now, staffing is critical. And so a nursing assistant, very well-intentioned, may have 10 residents to get up. And at this point now, they're all pretty much total care. And so they're moving like this. Everything is fast. Nothing is fast in Namaste care. Everything is offered, excuse me, with a gentle, loving touch. What beautiful skin you have. What a lovely smile you have today. The second principle is that the environment is comfortable. So what we do is we don't use industrial lighting. We use lamps that you would have in your own home. We try to make the Namaste space as home-like as possible. So they feel like perhaps that they're in their living room. And we get them comfortable, hopefully not in wheelchairs because they're slumped over, but in some type of lounge chair. And everyone has their own quilt. So for me, living in Florida, perhaps I would have palm trees or birds on mine. My husband is Czech. He's from the Czech Republic. And perhaps he would have the Czech flag on a quilt that he would have on his chair. So we make sure that it's very individualized. They're brought into the room by the nursing assistants. And we usually start with a small group, maybe 8 to 10, and we can take one nursing assistant off the floor because that's usually how many residents they're assigned to care for. Sometimes the activity department takes over the club and Namaste, and that's actually wonderful too. Sometimes we have volunteers. It's really not very complicated at all. I guess I'm just not that smart. It's all about love, just this loving touch. So what ends up happening is after they have their breakfast, they wake up, they're toileted, they're dressed, they have breakfast, and then the nursing assistant brings them into the Namaste care room. And as soon as they come in the room, they feel, one of the family members said, she feels as if she's being enveloped by a giant hug because there's beautiful music playing. And there's the scent of lavender or whatever your culture is comfortable with or seasonal. In the United States in the summer, for instance, we have roses in a lot of places. So the scent may be rose. And at Christmas, the scent of a Christmas tree. They're assessed for pain. We use a pain ad scale that Dr. Volitzer, my husband, developed with his team of nurses. And it's not copyrighted, so you can even find it anywhere on the internet, PAINAD, PAINAD. And that's to help assess pain in people who have advanced dementia. The next thing we do is we give them something to drink because people with advanced dementia just don't drink enough. And at least in the United States, the reason for hospitalization of people from nursing homes is usually they're dehydrated or they have urinary tract infections. So we give them something to drink with a straw. Their name is on the cup, so we don't have to worry about infection control. And then the next person comes in, and it's Dr. Volitzer, and I'm going to shake his hand. And I'm going to assess him for pain. And then I'm going to give him something to drink. And then I'm going to go back to the first person that came in, and I'm going to give her something to drink. So that continuous hydration continues for the whole morning activity. So after the majority of residents are in the room, and sometimes we put them in a circle. Occasionally we'll have a large screen TV that just has like the rainforest in it or children playing, you know. And then when it's time to start the activities, we usually just put the rainforest on with the beautiful music. Now in the United States, what most women use, and I understand that this is also popular in other countries, Pond's cold cream. And they haven't changed the jar for years. And so what I'm going to do, and hopefully without gloves, although during the pandemic we were wearing gloves, but I love it to be skin on skin. So we're going to take this off and we're going to let them smell it. And then we're going to take a little bit and just brush their face, and just be talking to them about they have lovely skin, they have the best smile, just helping them feel good about themselves, all positive comments. Now, when I was doing this, then I realized that men also have very dry skin. And I'm thinking, I'm not going to use Pond's on them. So we have a lotion that doesn't have any scent to it, but at least in the United States, men oftentimes have used Old Spice. And I understand that that also is popular in other countries. So I'll put a drop of Old Spice in the liquid so that they can smell the kind of the manly smell that they have. And again, offering them something to drink. Fussing with their hair. For some reason, that activity is the most comfortable activity that I can provide. I work in hospice, and as people are making the transition, I sometimes will just fuss with their hair. A dear friend of mine was passing a couple of months ago, and she was very, very agitated. So her husband called me, and I went in, and I had the lavender. I had some beautiful music on my cell phone. And then I just touched her hair, and I said, "Oh, Jackie, I'm here with you today, and I'm so pleased to be with you. You're such a wonderful person." Now, she hadn't spoken in days, and she turned around and she looked at me and she said, "I love you." That was the last thing she said. She passed very quickly after that. So those are the kind of activities that we're going to do. And we're going to fuss with their hair. We may do a hand massage, and not like this. We do everything in threes. So we do on the top with threes, and then down the finger 3 times, and then each knuckle. And this, by the way, is a wonderful activity to show families. Oftentimes, the family member comes in and sits beside their loved one, and "How are you, Mom?" And the person doesn't recognize you as their daughter. And for the most part, they're not speaking at that point. But teaching the family that they can do a beautiful hand massage. And this kind of a hand massage, doing everything 3 times, can probably take up to a half an hour. And it gives the family something to do. I was teaching a family member how to do this in the UK last year. And the mother hadn't spoken for a long, long time. And she opened her eyes and she looked at her daughter and she said, "I love you." And she hadn't spoken to her daughter for months. So that was a very special thing to do. So we do that. And we might just also do some with their arms. So their face, fuss with their hair, do their arms. And then we do some fun things. I oftentimes will bring in, these are dogs that look so realistic, and I get them on Amazon, and they're only $19.99. And I put them in a bag if I assign a dog to one particular resident, so that we don't have to worry about cross-contamination. So we do that. And sometimes, you just want to have fun. And sometimes I'll get one of these, and they make big bubbles. And then I found these at the dollar store, and they can put the bubbles out, or they could burst them, or sometimes they just like to poke at them. Sometimes we just forget that that the giggle is still there. Now, granted, they don't have a lot of life expectancy, but the giggle is still there. Sometimes I'll come in like this, and the big smiles they'll have on their face. So just having fun is what you can do. And then it's time for lunch. So I thank everyone for being there in the morning, and please welcome them to come back in the afternoon. And so they have lunch, they're toileted. And instead of putting them to bed, if they can be in a reclining wheelchair, we take them back to the Namaste program in the afternoon. And what's ended up happening is that we have had a major reduction in the use of sleeping pills, because they're awake in the afternoon. They may nap, off and on, but not like when, when they're put to bed or put in front of a television set and they just fall asleep and then they're awake at 3 o'clock in the morning. So that was one of the lovely results we had from some research that we were doing. So in the afternoon, when they come back, we may do things a little bit differently. I may play some music that is sharper, maybe a march, bum, 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 and they can march, or let's waltz. And I take them by the hands and we march. So it's an exercise program, but I don't call it an exercise program. I call it dancing. So we can do that, which is great fun also. And again, when family members are there, we certainly welcome them to do that. And so that's basically what we do in our program is just have fun. And in the winter, I was living in Massachusetts and it was snowing, and one of the nursing assistants went out and got snow and put them in plastic bins, and they made snowballs. I say bring the outside inside. So right now we have some beautiful flowers that are in bloom here in Florida. And so I would bring flowers in. In New England, the leaves are changing. And so I would just grab some leaves that are on the ground. One day, a nursing assistant brought in a bag. Her husband had cut the grass, and she brought in the grass clippings, and the residents just smelled them. Now, the men didn't like it. I think the men thought, oh no, I have to, mow the lawn. But the women got such a big kick out of it. So bringing the outside inside is also a great activity to do in the afternoon. And then, at the end of the day, I thank everyone for being with me. And also we're doing the hydration in the afternoon also, and hope that they come the next day. And then whatever is appropriate to say goodbye, whether it's a handshake or a hug or just a pat, on the face. And also I wanted to make sure that I mentioned Betty. Betty was a woman who had advanced dementia, never smiled. She just was so sad. And I had an opportunity to talk with her family, and I said, what did Betty like to do before she had such problems with her memory? And they said, oh, she loved to do lunch. And she had this hat, big blue hat with a veil and white gloves. And that's what she wore for her lunch, and she loved it. And I said, by any chance, do you still have the hat and gloves? They said, yes. I said, would you bring them in? I'll promise to keep them in a safe place. And I wish you could have seen the difference. So Betty went to big smile when we put the blue hat on and her gloves. And she was just a different person with her hat and gloves on. So very, very important to know who the person is and what was important to them. And for me, it's going to be a dog. This is Covey. We got him during COVID. Are you bored? So we call him Covey, and he's just the light of our life. And I can see if I were to be in a nursing home, I would hope that somebody would give me a realistic Shih Tzu that I would think would be Covey, and that would be something that I would enjoy very much. And so at the end of the day, again, everyone is thanked for coming. We do very little documentation, mostly just are they there? And then is there something different that happened today that Joyce had a family brought in a dog that reminded her of her own dog. And so let's make sure that Joyce has Kobe every day on her lap. And so we make mostly those are the discussions that we have between staff. And so basically that is the group program. And then I was giving a talk, and a man from hospice came up to me and he said, I like your program. Can you put it in a bag and take it to the bedside? And I said, I have no idea, but I'd love to try. And so Seasons Hospice made bags, So it's an advertisement as well as it has Namaste Care on it. And in here, I have hand lotion, I have scent, I'd have the Ponds, I would have the allspice, and I would really just bring it to the bedside. And last year they provided Namaste Care to their hospice patients 30,000 times. Isn't that incredible? 30,000 times. It's like, this program has just taken off in ways that I never, ever dreamed. And I hope maybe one of the messages that you'll hear today, that you have been hearing from me, is if you have an idea, just a small idea, like I was frustrated at this nursing home in Bennington, Vermont, because the people with advanced dementia didn't have an activity. And that's how Namaste Care started. And look at it now. As I said, it's in 15 countries. In the UK, they do Namaste Care in the hospital, maybe an hour a day, or maybe twice a week. They do it in Iceland in adult senior centers. I developed it for people with advanced dementia, and the hospice that I just spoke about, Accent Care, formerly was Seasons, now gives it to everyone. All of their patients receive Namaste. So it's not, I guess, this whole loving touch and quiet, beautiful, loving environment is something that we all would love. And so that's what's happened to the program. It's just gone in unbelievable ways. Wonder, does anyone have any questions or comments?
Yes, thank you, Dr. Joyce. So
You're
anyone is
very,
having questions? It was a wonderful presentation.
Sorry about the PowerPoint, but I hope I made up for it.
No. It was wonderful, wonderful.
Thank you. Oh, you know, one thing that I didn't show you, I just, you know, people with advanced dementia have a very difficult time, of course, reading anything. And when you work for any kind of company, they usually want your name and your title and maybe the logo. But I also do this. I had one made up. So, and you can certainly do these and make them and put them in plastic and just whatever that person wants to be called. And it's so amazing when the first time I did it, and I put it in on and walked into the room, and how many of the residents looked at me and said, "Hi, Joyce." They got such a kick out of it. So that's another kind of little practical thing that you could do.
Okay. Thank you, Dr. Joyce, once again.
You're welcome. Namaste.
Okay, namaste. So moving on to our next talk by Dr. Najwa Abala. It's an audio presentation.
Testicular torsion in undescended testes, a rare emergency. Cryptorchidism is the most common genital disorder in males and generally should be diagnosed and treated until 18th month of life. The consequences of an undescended testicle are a higher risk of testicular cancer and impaired fertility. Moreover, cryptorchidism is connected with a higher risk of gonadal torsion. It is a common pediatric disorder that occurs in 1 to 4% in full-term newborns and more frequent in preterm infants. It is associated with a high risk of ignorance and delayed diagnosis, which rise testicular necrosis. Therefore, it is the most urgent disorder and surgical emergency. We report 7 male patients with testicular torsion of undescended testicles. To review consequences of delayed diagnosis and how to manage. The aim of our study is to describe torsion in non-descendant testes. As known, it is a frequent cause of testicular necrosis. It is indeed rare, but we must think about this diagnosis whenever we receive a patient for abdominal pain with an evacuate scrotum. Our study is about 7 male infants with undescended testicle torsion. The diagnosis was confirmed clinically and the surgical exploration was done in our department in the period ranging from May 2009 to November 2020. The medical records had to include the age of patient at presentation, the medical history and the physical examination, and the operative findings and the results of follow-up. The diagnosis of torsion of undescended testicles was made clinically and confirmed. Our patients were followed up at 1, 3, and 12 months post-operatively and then examined once a year. Ultrasounds were performed at 3 and 12 months after surgery to assess testicular volume. Testicular atrophy was defined as a difference that is superior than 15% between the affected and the contralateral testes. Testicular hypertrophy was defined as a difference superior to 20%. So, our study included 7 male children of all 200 torsions and 900 cryptorchidisms, which represents 3% of all torsions and 0.7% of all cryptorchidism. The median age of our patients was 3.5, ranging from 15 days and 15 years. We have received 2 babies who were under the age of 2 years, a 15 days newborn and a 14 months infant. In the 7 cases, the left side was always affected, and we report 1 case where we had a bilateral undescended testis torsion. 3 children were known having an undescended testis. The mean duration of symptoms in our study was 35 hours, ranging between 24 hours and 10 days. None of our patients had been admitted before 6 hours. 5 patients were admitted in the hospital for growing pain associated to inflammation signs, and in 2 cases, a swelling of the groin. Unconsolable crying was noted in 2 of our younger patients, and symptoms were accompanied by nausea and vomiting. On physical examination, painful inguinal mass with an empty ipsilateral hemiscrotum was identified in 7 patients. Contralateral testis was palpable in inguinal canal in 1 patient. In 6 patients, the testis was in scrotum, and 5 patients had a fever. We present here a 7-year-old boy presenting with a tender mass of the groin and an empty ipsilateral hemiscrotum. 3 patients only underwent Doppler ultrasound showing inguinal testis with decreased blood flow to the affected testis comparatively to the other side with surrounding hyperemia. A surgical exploration was performed through an inguinal approach. In 3 cases, the testes were preserved after an improvement following a torsion and warming of the tissue. 1 stage orchidopexy was performed. If the testis remained dark, it was wrapped with warm saline-soaked towels for at least 5 minutes. If no recovery in color of the testicle was seen, the tunica albuginea was inside. When no bleeding was detected after 10 minutes, an orchidectomy was performed. All removed testes underwent histopathological examination. In 4 cases, we found necrotic testes. No testicular viability was observed despite appropriate salvage attempts. A systematic orchidopexy of the other side was performed. A contralateral orchidopexy was performed via an inguinal approach at the same time of initial surgery in the post-operative pathological finding showed no signs of malignancy. Testicular hemorrhagic infraction and necrosis was confirmed on histological examination of excised testes. Outcome of the 3 patients with conservative approach was uneventful. No hypertrophic signs were detected after 4 discussion. The first case of testicular torsion was described in 1840 by de la Suave. Undescended testis is a known risk factor for testicular torsion. It is 10 times higher than those with normal testes. There are limited cases reported in literature, and there are no randomized trials. Nawar et al. Found 13 cases of torsion of undescended testicles in 1 adult and 12 children. We report 7 cases over a period of 13 years. Testicular torsion in patients with cryptorchidism accounts for 6.8% to 9.7% of all testicular torsion cases. Johnson et al. Reported an incidence of 21% of torsion in cryptorchidism testes. We note less in our study with a rate under 1%. The mechanism of testicular torsion of undescended testes is not well known and understood. There are some theories about the physiopathology of the torsion of the undescended testes. Similarly to scrotal torsion, we found that an extravaginal type was recognized only in a 15-days-old newborn. There are 2 peaks in the incidence of testicular torsion in the pediatric population, during the first year of life and between the ages of 12 to 15 years of life. As shown in our study, patients suffered from nonspecific complaints like fever, vomiting, or abdominal pain. It should be emphasized that a meticulous physical examination is crucial and it increases the chance of saving the testicle. The main symptoms are an inguinal pain, a tender inguinal mass associated with an empty ipsilateral scrotum should be alarming signs, alongside with vomiting, abdominal pain, restlessness, and fever. The color Doppler imaging is widely used and preferred test with a high sensitivity up to 90%. The duration and the degree of spermatic cord twisting are critical factors in the outcome of testicular torsion. Testicular salvage is possible when a surgical intervention is performed within the first 6 to 8 hours from the beginning of the symptoms. According to a systematic review, When the spermatic cord is untwisted within 6 hours, 97% of the testis survives. In our series, the time of surgical intervention was much higher. Testicular salvage rate in patients with cryptorchidism is ranging from 0 to 53%. Rouzroux et al. Preserved all testes and performed a second look aspiration and was able to preserve 44 out of 70 testes. A prophylactic orchidopexy of the contralateral testis is highly. In conclusion, testicular torsion of undescended testes is a rare phenomenon that should be suspected, diagnosed, and treated without delay. In order to improve the salvage rate of testes and decrease complications such as infertility and testicular malignancy. This series should raise awareness among physicians of the torsion of undescended testes in patients with groin or abdominal pain, causing an improved recognition of cryptorchidism and an earlier surgical intervention.
Hi. So this was the presentation from Dr. Najula Abullah. The second talk has given from here, from University of Qatar from Morocco. Next, we'll have the presentation of the two talks left for the first today's session. That is Dr. Zihong Yang from China, as well as Dr. Shen Mehdi from Peking University of School of Nursing from China. The two talks will be completed by today, and we'll be closing the today's session. Now we are going to play the session of Dr. Xing Yanghun from School of Nursing from China.
Good afternoon, everyone. I'm Zihan Yang, a postgraduate student in Southern Medical University. Today, I want to share my research, Curriculum Humanistic Competence of Nursing Teachers, a grounded theory study, and this is my poster. Well, firstly, I'd like to introduce the background of the research. At present, only relying on a few humanities courses can no longer meet the requirements of undergraduate nursing students' cultivation of a country. And what's more, Xi Jinping, President of the People's Republic of China, stressed that it is necessary to adhere to the model education as a central link and infiltrate ideological and political work into the whole process of education and teaching. So, curriculum thought and politics was put forward. It takes curriculum as a career and politics as a concept, and realize the organic unity of knowledge imparting and value leading imperceptibly based on the idea of curriculum thought and politics. And innovating it, a scholar named Rui Fenshi put forward the concept of curriculum humanities. Well, that is, the humanistic elements are integrated into the classroom teaching and clinical practice teaching of nursing specialty to cultivate the humanistic quality consistently. While curriculum humanities teaching can imperceptibly integrate humanistic elements into professional courses so as to comprehensively improve the humanistic quality of nursing students and make up for the lack of single humanities curriculum. Well, under the guidance of the curriculum humanities, there is a need to build a team of teachers with ability and competence to carry out curriculum humanities teaching better. Well, the competence is a personal characteristic that distinguishes whether a worker is excellent or not. Here are the models, and today we use the onion model. And however, although we have the need, at present, the domestic research on the competence of nursing teachers is mainly aimed at clinical nursing teachers, while the research on the competence of full-time nursing teachers in colleges and universities is less. Moreover, the research on the competence of nursing teachers is mostly limited to professional knowledge and professional skills, although some scholars' research on the competence of nursing teachers involves the content of humanities. They do not systematically elaborate on the curriculum humanistic competence, and the tools specially used to evaluate undergraduate nursing teachers' curriculum humanities competence have not been reported. Well, based on this, the existing competence evaluation index systems are not enough to evaluate the curriculum humanistic competencies of nursing teachers. There is an urgent need to carry out research on the curriculum humanistic competence of nursing teachers and to improve the access, evaluation, and assessment system of nursing teachers. So the purpose of our study is to provide a basis for the subsequent construction of the evaluation index system of nursing teachers' curriculum humanistic competence. Well, let's focus on the methods. We used convenient sampling. We selected 9 full-time nursing teachers from undergraduate colleges. The inclusion criteria is that they are responsible for full-time teaching of professional courses for undergraduate nursing students currently. They also should have more than 5 years of teaching experience, informed consent and voluntary participation, and we selected 10 part-time clinical nursing teachers, including criteria. They have obtained clinical nursing teaching qualification certificate. At present, they are responsible for clinical teaching of full-time undergraduate nursing students. More than 5 years of clinical teaching experience, and participated in the training of nursing humanities and undertook the humanities teaching work of the department. Informed consent and voluntary participation. Well, we also selected 5 experts with medical background in humanities research. Inclusion criteria, more than 5 years of work experience, associate, senior or above, informed consent and voluntary participation, the sample is well representative and the scientific nature of the interview results is granted. Well, the interview outline. Firstly, have you heard of curriculum humanities? How do you understand it? The next is, have you carried out the teaching of curriculum humanities? Can you give specific examples? The third is, what good experiences or practices have you summarized in the process of carrying out the curriculum humanities teaching of nursing specialty? Can you share them with us? The first one is, what are the problems and challenges you encountered in the process of carrying out the curriculum humanities teaching, and what support and help do you need? The last one, the fifth one is, what kind of competence do you think nursing teachers need to have in order to be better qualified for curriculum humanities teaching? The last one is, what good suggestions do you have for improving the curriculum humanities competence of nursing teachers? Well, when we turned the recording into text within 24 hours after the interview, the researchers read the text data word by word and repeatedly, and used the grounded theoretical method of Strauss and Corbin to sort out and analyze the interview data through three-level coding. It means the open coding and axial coding and selective coding. And if the answer is yes, then it means the data analysis is completed. And if the answer is no, then repeat. In this study, the number of words is 153,111. The original sentences related to the research topic were coded in an open way, and 39 initial categories were obtained through the axial coding. The initial categories were summarized and analyzed, and 11 secondary codes were obtained on the basis of the axial coding. Selective coding was carried out. The curriculum humanistic competence of nursing teachers were summarized into 5 dimensions. The results are as follows. The first one is sunrise chart of 3 levels coding, and the next one is coded word frequency diagram. These two pictures will reflect the frequency and proportion of words. And here are the details of the results. It's a list of words, subordinate categories, and categories from coding. Here are the 5 dimensions. And the conclusions are as follows. Firstly, based on the Onion model of competence, we obtained 39 3-level codes, 11 secondary codes, and 5 primary codes, which provides a scientific basis for the evaluation index system of the nursing teacher's curriculum humanistic competence. And further study can be made on this basis to compensate for the deviation caused by the limited number of interview samples. Well, the last one is the references. Well, that's over. Thank you.
Yes, this was a presentation from Ms. Zihang Yung from School of Nursing from Southern Medical University from China. So you will be getting the participation certificate within 2 to 3 working days of the conference. And next we'll go with another speaker, Dr. Shen Mit from Peking University School of Nursing from China. The topic will be the impact of COVID-19 migration, so mitigation measures on preterm birth, a system review, and meta-analysis.
First, background of my topic. It's well known that the rate of preterm births was reported to be 11%, equating to 15 million preterm labor are born around the world. One of the most complex and important challenges is preterm labor, which has a higher mortality and increased risk of short and long-term disease. Currently, researchers in this field have a preference towards secondary preventive strategies on those who are at a higher risk of preterm birth. Will the COVID-19 provides us a unique opportunity to verify the effectiveness of primary prevention for preterm birth. Preterm birth may be decreased as a result of COVID-19 mitigation measures, such as lockdown, limited mobility, or improved hygiene awareness. A national study reported a reduction of preterm births during lockdown and the next period. Another national study found that the extremely preterm birth was significantly reduced during the COVID-19 restriction period in Denmark. It's interesting to know that other studies also produced mixed results. There was no differences in the incidence of extremely rare and moderate to late preterm births among the COVID-19 lockdown groups. And other researchers claimed that during the strict lockdown, the risk of moderate to late preterm births was slightly higher, with no significant increase in extremely preterm births. Given that there has been no synthesis of evidence on the relationship between the COVID-19 mitigation measures and preterm birth. We conducted a systematic review and meta-analysis to evaluate the impact of COVID-19 mitigation measures on preterm birth and identify the potential factors so as to provide evidence for developing primary preventive measures for preterm birth. The following is the presentation of methods. This is systematic review and meta-analysis. Candidate papers from December 31, 2019 to February 18, 2022 were searched in electronic database. The following requirements have to completed for studies to be included in systematic review and meta-analysis. For patients, any gestation age pregnant women were eligible. Pregnant women with COVID-19 were not included in our study. This included study will need to describe mitigation measures. Preterm birth was the primary outcome of interest. Our systematic review, which comprised cohort study and experimental research, and our review excluded papers with no original date, such as reviews, protocols, and conference abstracts. The Newcastle Ottawa score were used by 2 independent reviewers to assess the risk of bias in the included studies. Score which has 8 items and 9 points at most. Next is the results we got. A total of 1,634 records were identified, with an additional 3 records were from citation searching. According to previous defined inclusion and exclusion criteria, 2 quasi-experimental studies and 6 cohort studies were incorporated into our systematic review and meta-analysis. These included papers came from ESA, European, American, and Africa. Majority of studies were from high-income economy countries and upper-middle-income economy countries. Among these included studies, 5 studies were national in scope, 3 were regional, 5 were multi-century, and 5 single-century. Most of the included cohort studies were retrospective. There were low risk of bias in 10 studies, with moderate risk of bias in 8 studies. Two quasi-experimental studies and 15 retrospective cohort studies were synthesized in light of the heterogeneity of study designs. 2 quasi-experimental studies probed at how COVID-19 mitigation measures affected preterm birth over various time windows were carried out in China and the Netherlands. Following the adoption of COVID-19 mitigation measures, preterm birth decreased in the 2nd, 3rd, and 4th months, according to the meta-analysis of these 2 studies. The effects of deployment of COVID-19 mitigation measures on the preterm birth were examined in 15 retrospective studies, and the synthetic results which from 15 retrospective cohort studies indicated that the reduction of preterm birth was impacted by COVID-19 mitigation measures. Given the high heterogeneity of the synthetic results, meta-regression and the subgroup analysis were used to investigate the sources of heterogeneity and the underlying factors of the reduction of preterm birth. In terms of population differences, subgroup analysis by continuing to reveal that preterm birth was significantly reduced in European countries under COVID-19 mitigation measures. Based on the World Bank country classification, subgroup analysis on economic level were conducted for low, lower middle, upper middle, and high-income economies. COVID-19 mitigation measures were associated with reduction in preterm birth in high-income economies. Furthermore, population-level subgroup analysis revealed that COVID-19 mitigation measures only had a significant impact on the reduction of preterm birth in national studies. but had no effect in single-center, multi-center, and regional studies. Based on gestational age, WHO divided preterm births into 3 categories: extremely, very, and moderate to late preterm births. The results indicated that COVID-19 mitigation measures have a positive effect on reducing moderate to late preterm births, but have no significant effects on extremely and very preterm births. Due to the limited reported data, subgroup analysis of spontaneous preterm births and medically indicated preterm births were conducted. These results revealed a significant reduction in medically indicated preterm births, but no significant changes were observed in spontaneous preterm births. Most of the included studies attribute the reduction of preterm births to reduced stress and healthy lifestyle changes, as well as preventive behavioral changes as a result of COVID-19 mitigation measures. These reductions in the risk of intrauterine infection and inflammation may be mediated by preventive behavioral changes. Air pollution reduction has resulted in a decrease in preterm births, which has been confirmed by a large number of researchers. Here are the results of my systematic review and meta-analysis. To our knowledge, this is the first systematic review and meta-analysis which on the impact of COVID-19 mitigation measures on preterm births. Our findings indicated that COVID-19 mitigation measures such as reduced stress, active lifestyle changes, and the preventive behavioral adjustment were more likely to lower the rate of preterm births. Globally, there are a wide range of mitigation measures which can be summarized as attempt to suppress transmission routes and promote protection of high-risk populations. Since the COVID-19 outbreak, preventive behavioral modifications have been made to try to control the transmission channels. These changes included wearing masks, keeping social distance, and raising hygiene awareness. These behavioral changes can lower the possibility of infection. It means that preterm births may be prevented by relevant hygiene measures and behavioral changes to cut off the route of transmission. Lockdown measures have resulted in healthier lifestyles for pregnant women, such as sleep time, balanced diet, and reduced work-related stress, which may have a beneficial effect on preterm births. These findings provided evidence for the development of interventions for primary prevention of preterm births. Overall, this review is the first to highlight the importance of COVID-19 mitigation measures on preterm births, which appear to lower the rate of preterm births through reduced stress, healthy lifestyle, and preventive behavioral changes. However, our studies have several limitations. First off, the results of meta-analysis are influenced by inter-study variability. Despite we performed meta-regression and subgroup analysis to balance the stability and reliability of the data analysis. Second, the methods of comparing export and non-export factors in the included studies may have confounding factors that cannot be measured. Finally, the majority of the studies in this systematic review were retrospective. Future reports of more prospective studies are recommended. COVID-19 mitigation measures have positive impact on preventing preterm births, and the decline in preterm births may be related to reduced stress, healthy lifestyle changes, as well as prenatal behavioral changes. It provided us a natural perspective to assess the effectiveness of primary prevention strategies of preterm births. These findings underscore the importance of primary prevention in pregnant women to reduce preterm births and promote long-term neonatal development. Presently, our systematic review has been formed and under review. That's all. Thank you.
Yes, this was a presentation from Dr. Shen Mehdi from Pekin University of School from China. Yeah, yes, madam, you'll be getting the participation certificate as well as booklet, as well as CPD points within 2 to 3 working days. And last speaker of this day 2 session will goes to Dr. Mary Abarhasi Johnson from Dr. MGR Medical University from India. The topic will be the educational technology in nursing. Yes, madam, you can start sharing your slide from your side. If you are unable to share, please let me know so that we can play from our side.
Can you see the slide, sir? Can you see the slides? Can you see, sir?
Yes, you can start sharing, madam. Just you can start. We can
Can I
see
start? Yes.
PowerPoint on the screen.
Okay,
And
thank you very
are
much.
unable to add your voice.
Can you hear me? Can you hear me? Can
Make
you hear me,
settings in your audio. We are unable to hear your voice. Yes, make settings in your audio.
Yeah.
Yes, madam. Go ahead. Are you facing any problem from your side? Please let me know.
Hear me, sir? Can you hear me? There is voice problem, da.
Yes, go ahead.
Can you hear me, sir?
Yes, madam. You go ahead.
Okay. Now I'm not able to see this slideshow. Can you?
You can start sharing from your side again. Or also do, shall I share from my side, madam, so that every...
Yes, sir. Kindly help me with that.
Yes, definitely, madam, definitely.
Very kind of you to do that. Extremely kind of you to do that.
And for every slide, after completion of every slide, please let me know, madam. Slide change, I can change from here.
Yes, sir. Very kind of you. I appreciate it.
Yes, madam. Go ahead. You are the last speaker of this section.
Yes, sir. At the outset, I would like to thank the organizers and especially sir. You are taking a lot of trouble and all the experts. Actually, in between, I was able to connect and I was able to listen to and very innovative talks, and I'm learning quite a lot from all of you. Next slide, please. I am here to talk about infection control, hospital infection control. I'm working in a pediatric setup, and what sort of measures that we take in order to reduce the bloodstream infections. And Florence Nightingale, she is our founder, nursing founder, and all of us know she's a very well-known figure. And she said the very first requirement in a hospital is that it should do no harm. So patients, they come with a lot of struggles. They come with some kind of anxiety, not knowing what is happening. And on top of that, if as healthcare professionals, if we add on kind of strain on them, that it is unfair. And therefore, as healthcare professionals, whether nurses or doctors, we must always bear in mind that we must take all sorts of measures to minimize any sort of infection, whether it is urinary tract infection or surgical site infection or VAP or any sort of infection. And particularly, I am talking about BSI prevention today. So this is a well-known fact which has been taken from the CDC, where 80,000 catheter-related BSI has been estimated in USA, and 28,000 deaths in ICU, and cost per episode around $45,000. Total annual costing about 2.3 billion, which is quite huge amount. Next slide, please. Next slide, sir. And why are these children or patients who come to the intensive care unit, why are they getting more prone for infection compared to other children or other patients who are in the wards? Sure enough, we all know that it is because of varied factors. One is that their low immune status. Already their systems are knocked off, they're down, and also a lot of invasive procedures happen. We connect them to the ventilator, or we do a lot of invasive procedures, and we pass the NG tube, we start the central lines and various other investigations which are done, which are quite invasive, and therefore a lot of chances for them to develop, and especially bloodstream infections are very, very common in an ICU setup. And so, and also they're immunosuppressive. Some of them may be on immunosuppressants like chemotherapies, or even non-chemotherapeutic immunosuppressants are there. So that can be one of the reasons. And loss of skin integrity. Their skin may be very fragile already, whether it is geriatric population or pediatric population, or even otherwise, because they are very sick. And severity of the underlying illness also is a kind of concern. And active infection at other sites. Not because of bloodstream, sometimes other site infection can also kind of knock off their immune system, and therefore that aggravates, or that it makes it more susceptible for them to develop a BSI. And so other sources of infection, like in pediatric setup, when children come with a simple URI, suddenly we see them landing up with meningitis just within no hours or within no days. And therefore other comorbid conditions attached, and also alteration in patients' cutaneous microflora is the other reason, and failure of healthcare providers to wash hands. All of us know that almost 90% of the hospital acquired infections can be controlled or prevented even just by mere hand washing. And therefore we always talk about hand washing, and we give the patients a trigger. Whenever they get admitted, we tell them, you have to ask us whether we have, it's your right, you have to assert your right. So we put the labels and tags on the beds above on the walls above their beds. Ask the health professional, did they wash their hands? So that's a kind of trigger we give to our patients and the parents who come in here. So contaminated ointment, sometimes even the materials that we use for, because we are handling contaminated ointment or contaminated medication or contaminated equipment, even the catheters and so on. So hand washing is very, very important, and contaminated items can cause a cross infection. Next slide, please, sir. So other than that, it also depends on the catheter functions, how long it has been staying, and where is the location? Is it a peripheral line, which may not be much threat compared to a central line? And even among the central line, the jugular vein, some people prefer, studies have shown that jugular vein is better than the subclavian vein and things like that. So type of placement and where exactly it is peripheral or local central line, or duration of placement. Is it sitting there over for days together? Usually for an ordinary line, we tell them it should be removed within 3 days, not more than 3 days. And so therefore we know the duration also matters a lot. And whether it is an emergent procedure where everybody jets into the spot and everybody handles the child or the patient, and therefore that can also predispose to their susceptibility for infection. And skill of venipuncturist, multiple pokes, whether it is a nursing student or a nursing staff or a medical professional, if they're not skilled enough, then therefore they do multiple pokes, and that can also cause a break in the skin, and that can be a predisposing factor for developing an infection, which we have to be cautious about. And that's why we always train our nurses to undergo that IV therapy every time, either as a CBT or in the wards even we have preceptors and we have specialized IV nurses, and not more than 2 pokes on a child. I am working in a pediatric setup, and so we do insist that there should not be more than 2 pokes. The third poke, they should be alerted and they should be calling the experts, and we try our level best to train them so that just within first or second poke they are able to access the vein. Next slide, please, sir. Next slide, please, sir. So organisms, I'm sure all of us know, just it's a kind of reiteration or a kind of refreshment. So staphylococcal organisms, now coagulase negative staphylococci, enterococcus and serratia, candida, pseudomonas, klebsiella, enterobacter, all cornybacterium, all these organisms are very common. And in an ICU setup, the scenario that we see in our own setup is that when I was a student, long ago, should I say even 3 decades ago, where hardly we will see a second line antibiotic being started on. But now, for varied reasons, our patients, they go to mushrooming. I'm not talking about well-established institutions. There are a lot of well-established institutions in our country where there is a sound ethics, but small clinics where it cannot be found. And so they lavishly started them on even the third line antibiotics. So by the time they step into our hospital, it's almost we are forced to, it's a life and death kind of a situation in an ICU, and therefore we are forced, because partially treated or they have become resistant already, our doctors are forced to kind of start them on a third line antibiotic. So that's a kind of struggle which is actually practically faced within our institution. I'm sure you'll all agree with me, it is a kind of struggle everywhere. Always there's a kind of debating situation between the pediatricians and the microbiologists. They say you are starting them on third line, and the pediatricians, intensivists will say no other go. It's a life-threatening situation. Already they're partially treated or resistant, and therefore we have to start because they have to be there should be a life-saving thought on our mind. So this is a kind of a debating situation, and our intensivists most of the time are helpless, and therefore they go into third line antibiotics, because so many of them come with like vancomycin, imipenem, and colistin and things like that. Because of this kind of struggle which happens within our institution, I'm sure all the hospitals are facing the same kind of scenario. Next slide, please, sir. So biofilms are found to be very effective. Many studies have proven that it is effective, and we are also trying to introduce, actually just it's a kind of initial run. It's not a total study which we have done in our place. We are trying to introduce it. We just used for a couple of patients, but it is very expensive. Population which comes over here, no, they cannot afford for it, but yet, no, to some extent we can pay off from our funds and things like that. So it's a kind of study that is going on now. So it is a proven study elsewhere, but can our patients afford? Can we make it more cost effective and things like that? That's a kind of thought which is going on. So soon enough, this provision will become practical in our setup. Biofilms, I'm sure all of us know the effectivity of the biofilm. Next slide, please, sir. So as I told you already, there are studies which have shown that subclavian catheterization is better than the internal jugular or femoral catheterization. And so using of mask and caps and sterile gowns and sterile gloves and large sterile drapes, all these are found to be reducing the infection rate, which eventually will reduce the cost as well. In our ICU, pediatric intensive care ICU, children hardly stay there for 3 days, 3 to 5 days on an average. So we want to even reduce further so that the cost attached to that will also get minimized. Next slide, please, sir. So disinfecting the catheter hubs, we make it very mandatory. We have this catheter, the infections related to bloodstream infection bundle, and we make sure that the bundle is strictly followed, and we have a checklist for every child where there is an insertion. We, as we all know, that we reinforce these kind of tips to our students and for our staff members, where only when needed, the catheter should be inserted, and as soon as possible, it should be removed. And the disinfecting catheter hubs is very primarily important, and also making sure that the disconnected things should be kept on the sterile surface, and standard precautions and hand washing techniques, all this. And we are actually going to adopt a monitoring kind of system, not to kind of create a kind of fear in our population, but no, it is good for us also to reflect and see how are we in our practices. are we okay in our practices? So maybe a kind of camera can be fixed in and things like that, not to create a fear. Always there is a friendly reminders and things like that, but this will also help us to see where is the lacunae as such. And removing catheters when they are no longer needed, all those are reinforced. I'm sure all the hospitals have this BSI bundle. Next slide, please, sir. Next slide, sir. So hand washing, collecting needed equipment. After collecting some of the stuff, we should not keep going around because we've already washed the hands. So there should not be wastage of time running back to collect some more things and things like that. So we will reinforce that every item should be collected and kept in a sterile manner, and then before starting the procedure, preparation of the patient and counter checking with the chart whether that procedure is literally needed or not, and getting the sterile area ready, and all that reinforcements happen. And proper equipment, all the should be used, and preferably all disposable items, all those are being reinforced in our setup. Next slide, please, sir. Wearing sterile gloves, ensuring that the right hand is always kept sterile in case, so one hand technique also we teach them in case there is struggle with calling another staff with how to maintain sterility just with one hand. The other hand can be used to access the other item. So even that one hand technique, we keep talking to them time and again, reiterating on the importance. And cleaning the hip flesh vials, and all the changing the tubing every 3 days, and if it's a central line, once in 7 days, or changing the dressing once in 7 days, all those are reinforced. Next slide, please, sir. Next slide, sir. Next slide. Cleaning the insertion site and checking the child, the area, whether is there any signs of infection like pain, burning sensation, or any other discomfort felt by the child. Cleaning the catheter with betadine, all those procedures are being followed. Next slide. So informing the child about the procedure, replacing the equipment, because just leaving the equipment, used stuff just like that, then and there, not replaced is also not fair, because another person can come, even the patient's relatives can access them, and they can catch up the infection, and therefore replacing the items on time and getting the area cleaned up with the help of the assistant people there, the housekeeping staff, all those are being reinforced. Recording also how the site looks, that is also being reinforced. Next slide, please. Next slide, sir. So I'm just showing how exactly our procedure is done for the subclavian lines. Next slide, sir. So the entire port and the catheter are under skin, and therefore they require no daily care. The skin over the port can be washed just like that. Rest of the body, and frequently visual inspection of that area is important, whether there is swelling, redness, and collections are there. And keeping the dressing area clean and dry all the time, and remembering to anchor the catheter also. Accidentally it should not be pulled off, and so all those are being reinforced. Next slide, please. This is a child procedure. We can see initial run, child is sort of uncomfortable, but we can see in the end the picture taken where child is so comfortable and sort of comforted. Next slide, sir. So all these procedures, I'm just trying to skip through in want of time. We know how to go about doing a Hickman's dressing. Next slide, please. So we can see how it is fastened with the dressing after completion. It is neatly fastened so that it looks neat, and also it's not giving a kind of opening for any outside infection to go inside. Or so now we can see how comfortably child is smiling after the procedure. And even during the procedure, we have play therapy and a lot of diversion therapies like music playing on, and various things to make the child comfortable, but still child is a child, and therefore some amount of discomfort is felt by the child. Next slide, please, sir. So infection control modes. Next slide, please, sir. We make sure that the standard precautions and the transmission-based precautions are reinforced, especially contact precautions when there are chances, and standard precaution or universal precaution for all kind of patients who step into the institution is being reinforced. We have boards with different colors, where those can also be at the bedside, where it's not so much that the patients can identify, but we have some kind of color coding where we will know that the child is on standard precaution or on contact precaution or on respiratory precaution and things like that. So that's a kind of note for us. We will also be more cautious when we go near the bedside. Next slide, please, sir. So considering all patients as standard precaution, all patients as potentially infectious, and assuming all body and blood tissues as potentially contaminated, and assuming all unsterile needles and sharps are contaminated, so that we will be on the safer side. Next slide, sir. Next slide, sir. So these are standard precautions which I'm sure all of us know already. So using hand washing when there is a visible soil before the start of the shift and after the end of the shift, and the 5 moments, and especially when the hands are soiled, they do the hand washing, and in between patient care, if the hands are not soiled properly, they'll use the hand rub. And we mentioned the 5 steps involved and the 5 moments of hand hygiene and the 7 steps involved in hand hygiene. All those are reinforced. And of course, use of the careful handling of the sharps and use of patient isolation mechanisms if there is a need for isolating the patient, and use of disinfectants to disinfect these items, especially the plastic kind of items. Catheters, most of the time we use the disposable ones, and some of them like where they can be gas sterilized with ethylene oxide, and some items can be disinfected with 2% Silex. So we distinctly say which one should go for what kind of disinfection. And handling of linen also is very important. We disinfect them with Lysol 7% for 20 minutes or in 3% Dakins for 10 minutes. So that is also followed in different areas of the hospital. And disposal of waste also, we are quite careful. I'm sure all of us follow the same mode. Maybe for each state, it is different kind of color coding. And different hospitals can have a different kind of color coding, but the logic is the same. So waste disposal also is taken care so that patients do not catch up infection, or the relatives do not catch up, and even the healthcare professionals will not catch up infection because of a improper disposal of the waste. Next slide, please, sir. So as we saw already, this is the single most important, and 90% of the infections can be controlled merely by hand hygiene. Actually, we do hand hygiene survey, and to be very frank, we did a study some years ago, and where before touching the patient, it was only 37%, and after touching the patient, it was only 45%. And it was a very bad figure, and we have to honestly accept that it is the figure, and we had to project it to our inspectors as well. And we then tried many multimodal strategies like hand hygiene projects and training the staff nurses and various other professionals, and biomedical base segregation mode checking. All that came into line, and now our hand hygiene practice has much gone higher. It is 70 to 80%. Still lacunae is there, and we have to still catch up on. Next slide, please, sir. We know microorganisms can be there, is there very much on the skin, and so therefore hand washing and skin hygiene is very, very important. Even the parents, when they step in, we tell them they have to wash hands and come in, they have to wear the gown and come in, and so all those are reinforced to them. Next slide, please, sir. So hand hygiene, hand washing, and surgical antisepsis, we can see how the flora can be easily washed off, and that can prevent majority of the cry or due to hospital-acquired infections. Next slide, please, sir. So all this, I'm just trying to skip because we all know all this. These are basics. Next slide, please, sir. So soap and water for 60 seconds, and if we use the alcohol rub for 30 seconds, and visibly soiled, definitely we go for soap and water. Next slide, please, sir. And the 5 moments of hand hygiene, which we know already. Next slide, please, sir. The 7 steps of hand hygiene. We are trying to incorporate hand hygiene dance into our culture, so that it's not boring to them. When we teach, it will be in the form of a dance, so that they learn it well. We have done it for our patients, we have done it for our staff nurses and students, things like that. So even for our patients, they enjoy when it is in the form of a dance. Next slide, sir. So we can see the some of the area which are neglected, and so we have this infrared catching up mechanism where we use the infrared and see which are the area and show them also. So these are the areas not covered, and therefore do a scrupulous kind of hand hygiene practice. Next slide, please, sir. Next slide, sir. So 20% increase in hand hygiene compliance and 40% reduction in hospital acquired infection. This was projected in this study. So just by mere hand hygiene, lot of changes can occur within the hospital setup, especially in an ICU setup. Next slide, please, sir. Next slide, sir. So personal protective equipment, no hospital should say it is costly. Wherever it is, whether it is a small hospital, big hospital, it's a right, human rights, whether it's for the staff or patients, all of them have the right to ask for these products, and therefore we assert our students, our staff nurses, and our admin is very supportive. Next slide, sir. Next slide, sir. So wearing PPE, next, giving up, we know where not to use what all kind of PPE. Next slide, sir. So biomedical waste segregation is one mode which all of us have to concentrate. Again, I'm sure it's all happening well in other hospitals, and we have also improved a lot on this. Lot of audits are being conducted in every area, and it's reported, and we will be questioned by the admin if we are lagging behind this. And so, and especially NABH and nursing excellence is coming, not because of that. We are more concerned about patient care, and therefore for the patient safety is our prime concern, and therefore we make it mandatory that education, training, and audits happen very frequently, so that our compliance to the biomedical waste management, compliance to hand hygiene, compliance to the bundle securing, all that happens in a very periodical manner, so that we are happy because the patients are happy. We are keeping patient safety as a top priority. Next slide, please, sir. So all these, how exactly all these are taken care, how they are disposed. Actually, most of our waste are recycled in a beneficial way, so that they can be catered to a poorer population. We utilize them for small emission hospital as well, and they are recirculated in a very non-harmful way. Some of them are sterilized, and some of them are utilized for vermiculture and things like that. So most of the hospital waste are utilized in a beneficial way, so that people, grassroots level people also can be benefited out of the waste, but it is in a safe manner it is done. Next slide, please, sir. So the color coding, all of us know already, and I just put in how exactly each of them are disposed. Just for this is what is followed in our hospital. Different hospital will have different policies which are very safe, and which will promote the compliance. Next slide, please, sir. Next slide, sir. All these are waste management, which we know already. Next slide, sir. Next slide, sir. Cytotoxic content again are safely disposed. Next slide, sir. Next slide, sir. These are very, very important, where all this red stuff, where we are alerted, it is in the red column because it's most infectious, and therefore we make sure that they are incinerated. These stuff are incinerated, and they are not IV tubings and catheters and urine bags. All these are actually shredded. They are shredded, and then they are recycled. Next slide, please, sir. Contaminated recyclable waste. Next slide, sir. Sharps again, they are shredded. We have the sharp containers, and they are shredded, and they are deep buried. We have a big pit, big pits, and so we put them, and they are deep buried, the needles and the metals, so that nobody will develop a kind of needle stick injury hazard due to that. Next slide, please, sir. So all these kind of items are again segregated separately, and they are disposed in a safe manner. Next slide, please, sir. So the waste are divided into biodegradable and non-biodegradable, and they are segregated. Next slide, sir. Spill protecting ourselves from blood and body fluids again is mandatory for our patients and for our staff nurses and the students who step in here, where we ensure that gloves, apron, goggles are used for handling them and covering the spill. If it's a large spill, we put the absorbent cotton and cloth and we discard them in a safe manner. And if it is a small one, again, we have a spill kit, blood spill kit, and we handle that and we try to dispose it very safely. Next slide, please, sir. And using 1% sodium hypochlorite for all the equipment. We clean all the equipment with 1% sodium chloride. And floor washing, all that is done with 7% Lysol. Floor cleaning, we clean 4 times a day. Nighttime once and daytime 3 times using 7% Lysol. And also every area in washing of the walls and washing of the unit happens once in a month. And all the fridge items are cleaned once a week. Fan is cleaned once in a week. So we have a cleaning protocol and we strictly follow that so that patients do not develop any bloodstream infection. Next slide, please, sir. So nurses' role, I'm trying to finalize my talk. Nurses play a very, very major role in preventing infection, and always there is a kind of harmonious relationship between the health team members, whether it's the doctors or non-nursing personnel like paramedics. When they step in, there is always a friendly reminder and there is a give and take in our communication and we respect each other. We may be critical when we correct, but at the same time, we respect each other. And especially they look upon nurses as empowering factor because we stay on the unit for a long time. All the time we are there, we are the managers there, and therefore they look up to us for ensuring that the quality control happens by us and through us, and therefore it's a kind of very harmonious relationship within the team, and we take all sorts of caution. I'm sure this holds good in every other institution. There is always a kind of harmony between the medical team and the nursing team and the non-nursing team like paramedics and things like that, where we all cooperate with each other because for all of us, the center point is the patient and the patient safety, and therefore we try to be more as much as friendly. We try to be friendly at the same time, not giving up on the ethos and not giving up on the safety precautions that have to be followed, because patient safety is our prime concern. Thank you very much for the opportunity given. I apologize very much because there is a delay because of the technical issue, rain and things like that. But you're very patient. I highly appreciate that. Thank you very much, sir.
Yes, thank you so much, madam. It was a thank you for such informative tips. Thank you so much for a speech. Thank you for your tips, sharing your tips with us. If you have any questions related to this topic, you can text us or you can mail us immediately. We'll forward all this concerned speaker officially through mail. Thank you once again, madam.
Thank you, sir. Thank you very much, and thanks. I thank all the team members as well. I'm learning a lot from you all. Thank you very much. I highly appreciate it. Thank you.
Yes, good night, madam. Thank you so much.
Good night. Good night.
Next, this is the last session from Dr. Mary Johnson from India. So, as you know, all the guys, yesterday we have successfully completed day 1 of the conference with in person at Rome, Italy. Today we have completed with the Zoom meeting. So we have started according to the GMT from 9 a.m. till 5 o'clock in the according to Rome, Italy timings. If you go to the vote of thanks, the 6th International Conference on Nursing Education and Pediatrics, during this period we have who have joined the different time zones. Our most useful thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitation to participate in the conference. We have received several papers which will form the basis of our discussion in the various sessions. Let us thank all the associating with this conference by your presence. I am especially thankful to the program manager, Mr. Renal Thomas, as well as Ms. Shilpa, for her has continues put together in all us together in one platform, as well as Ms. Santustela, those who handle the pediatric conference. I would also thank to participants who hope you collaborate in the future in physical or either a virtual event. And you kindly note you will be getting the participation certificate, like a electronic certificate as well as booklet will be sent through email within 2 to 3 working days after the completion of the Congress. Finally, we extend our appreciation for each of you for your participation in these online participants. Thank you once again. Have a nice day. Have a great day. This is signing off.